coming in. You're all very welcome here today. It's great to be back in our old home in Dublin Castle for this, the 20th Annual Gay Health Forum. And this year we're working in collaboration with our colleagues in Gay Men's Health Service to produce today's events. So the way we organise this is every year we issue a call for papers, and we're really gratified and delighted to find that both our colleagues in the network, our colleagues in the NGOs and the statutory service all cooperate with that to provide the interesting and engaging presentations that we have for us today. There's also a range of posters outside which we hope that you have time to have a look at during the day. The range, depth and diversity of the presentations on view today is a credit to all of the work that we do in working towards improving Ireland's sexual health services. So today's presentations are done by a range of different individuals and organisations, and there is some information on your tables there about biographies of the people speaking. We have a very packed agenda for us today, so we're going to try and keep to time. There will be time for questions and answers during breaks and lunchtime as well. But in terms of our speaking, we're going to be a bit harsh and keep our speakers to 10 minutes, so each of the speakers will get a 2-minute notice of winding up before the end of the presentation. So with that, all that remains is to say I hope that we have a very interesting and engaging forum today. And we're going to start with an address from the Minister for State for Public Health and Wellbeing and for the Drug Strategy, Hildegarde Naughton. She's also TD for West Galway. She wasn't unfortunately able to be with us today, but she has sent us the following message. Thank you.
Good morning, everyone, and thank you all so much for your kind invitation to speak at today's event. My predecessors have supported the annual Gay Health Forum previously, and I'm delighted to be able to support your valuable work again. The Gay Health Network and its members' organisation is, in partnership with the HSE, play vital roles in promoting inclusion and diversity, supporting the LGBT+ community and their health. When supporting the recent Pride celebrations last month, it was wonderful to be able to reflect on how far we have come in recent decades. As Minister of State at the Department of Health for Public Health, Wellbeing and the National Drug Strategy, I'd like to stress the importance of ensuring that our healthcare service is inclusive of the needs of LGBT+ in society. The National LGBT+ Inclusion Strategy is the government's policy promoting inclusion, targeting discrimination, and improving the quality of life and well-being for LGBT+ people. The strategy sets out an ambitious vision for Ireland, where the end goal is full equality for LGBTI+ people. The aim is for Ireland to be a place where everyone, regardless of their sexuality, gender identity or expression, or sex characteristics, can reach their full potential to live healthy, safe and fulfilling lives, and to participate fully in Ireland's social, economic, cultural and political life. Health is one of the main themes of the strategy, and the Department of Health, the HSE and other partners work together to implement key actions. We're making a lot of progress. In terms of transgender healthcare, following the CAS report, the HSE has identified the need for an updated, integrated and evidence-based model of care for transgender services, which will support development of a full, dedicated, multidisciplinary service for Ireland. The HSE is also working towards addressing the waiting times faced by those who wish to access care for gender dysphoria. Working with Children's Health Ireland, an alternative pathway for children and young people wishing to access care is also being identified. Diverse and up-to-date sexual health resources, education, information and STI prevention and treatment are key resources for all of us, including the LGBTI+ community. An independent review of the National Sexual Health Strategy published earlier this year identifies that 49 of 56 priority actions were successfully progressed. We hope to publish a refreshed strategy at the end of 2023. And I'd like to thank many of you for engaging with stakeholder meetings, supporting the review previously. Your feedback is so important as we know services are coming under increasing pressure. We know that the STI clinic network is experiencing high demand. STI rates are rising both nationally and internationally. High population growth here in Ireland is also driving demand. I'm happy to be able to tell you that we have put in place a wide range of additional supports for sexual health in the last few years and will continue to support much needed expansion of this area of healthcare. Recent successful initiatives include the launch and expansion of the National Condom Distribution Scheme, the launch of our National PrEP Scheme in 2019, Ireland joining the HIV Fast Track Cities programme also in 2019, and the launches last year of the free contraceptive scheme for women and the free home STI testing service. Their impact has been considerable. Over 1 million condoms were ordered in 2022. Evaluations of the home STI testing service have been very positive, and the scheme is increasing testing capacity by around 33%, in addition to reaching many people who may have been reluctant to come to STI clinics in person. We're also very aware that there is unmet need and demand for HIV PrEP relating to population growth, increasing demand, and international guideline changes widening the clinical access criteria. Just under 3,400 people received at least one PrEP prescription in 2022. We'll be seeking additional resources for the service through the annual estimates pre-budget process this year. Also, as many of you may have heard during Pride, we're starting this investment journey this summer. We have support for a new pilot online platform for individuals undergoing PrEP care and investment in HIV Ireland's counselling facilities, which will together receive approximately €260,000 from the 2023 funding. Finally, last but very far from least, I'd like to celebrate this community's engagement with our department and with the HSE in terms of the research and partnerships that support sexual health. I'm sure today's conference will be a source of great interest and debate, and I'd like to thank everyone involved for their work in preparing for this key event, and I'd especially like to thank Chase Ledden, Maurice Naginton, and Fiona Lyons for their engagement with the forum and their forthcoming presentations, which I'm sure will be of huge interest to you all. It only remains, therefore, for me to thank you all again for your support, and I hope you all have a wonderful day. Thank you.
There's a lot in the speech there that we can be grateful for, I suppose, and certainly her appreciation of Gay Health Network and all its member organisations and the work we do in terms of sexual health is very much appreciated. So hopefully that gives us leverage when we next go for funding for our various projects in the next few years. Her comments as well on trans healthcare is very important because, as we know, trans healthcare is far from ideal in Ireland. And so her commitment to a complete update, overview and funding for this is to be hugely welcomed. We'd also encourage, obviously, the Minister to take the auspices of the trans healthcare out of the psychiatric services and put it into the sexual health services where it belongs. Also, in terms of resourcing the services, again, it's very important, and we're all keenly aware that there is an oversubscription and under-resourcing of STI services and PrEP in Ireland. So her commitment to further funding for PrEP services in Ireland is to be welcomed. So hopefully we can see that additional resources coming to us in the coming year alongside an update of the new sexual health strategy. So lots to look forward to there. Sorry, earlier in my enthusiasm to start on time, I neglected to put up a notice about fire safety and health, so maybe our technician can roll that for us now. Okay, thank you.
May we please have your attention for this public safety announcement. This is the main conference hall. The conference hall has 3 emergency exits. Exit signs will remain illuminated at all times. Please take a moment to check the exit nearest you, bearing in mind that it may be behind you. In the event of emergency, you will be asked to proceed to the exit and move up the stairs to the assembly point located in the lower castle yard beside the church. For your convenience, restrooms are located outside the main entrance to the room. Please ensure that mobile phones are switched to silent while in the conference hall, and remember that Dublin Castle is a no smoking and no vaping building.
Thanks for that, Sue. We'll move on to the next presentation, and also maybe to welcome everybody who's joining us online. Today's event is being live streamed. The next presentation is from Dr. Fiona Lyons, who is the HSE clinical lead in sexual health and consultant at GUM. And she's a featured part of every forum that we've had in the last number of years, and her presentation has come to be regarded as a kind of state of the nation. Sadly, she's not here with us today, and again has sent the following message by video. So please, Dr. Fiona Lyons.
From the Sexual Health and Crisis Pregnancy Programme. Sorry I can't be with you today for your Gay Health Forum 2023 meeting. Hopefully this update from the programme's work is useful and helpful to you, and I wish you all a wonderful conference. Many thanks for the opportunity again to present an update from the Sexual Health and Crisis Pregnancy Programme. I'm going to give a whistle-stop tour of clinical updates from the team of Caroline, Rachel and myself, and then some of the updates from the communications, education and training and research. So by way of clinical updates, well, as you know, in October of 2022, we launched the first home STI testing service on a national basis. This is the first in the world. It's the only place in the world, Ireland is the only place in the world that has a free, nationally available home STI testing service. And you can see from the figures on the slide here that the very busy activity that we saw in 2022 has continued into 2023, with almost 64,000 kits ordered up to the end of July this year. Almost 40,000 kits returned, which represents an almost 62.7 return rate. And of the individuals who are returning kits, about 1 in 10 have a reactive result. So that suggests that in addition to being a very busy service with a good uptake, that actually we are getting the right people who will benefit from the service in terms of identifying an infection and having ongoing additional testing and treatment as needed are using the service. Our plans and things that we're working on this year include the incorporation of the option for ordering condom and lube at the same time as placing an order for an STI test kit. I hope that should be operationalized before the end of this year. In addition, we're going to pilot from September time, pilot the online management of uncomplicated, low complexity chlamydia within the service, such that individuals who are diagnosed with chlamydia through the home STI testing service don't necessarily need to go to a face-to-face service to have their chlamydia managed. They'll be managed within the online STI testing service. This is something that there has been experience of in other jurisdictions, and we're going to pilot it in Ireland. I think that will certainly make it easier for individuals because they don't have to necessarily take half a day from work to go to a clinic. Now, some people may want to do that, and that's why we need to pilot it and see whether or not this is something that our service users would like to avail of. PrEP, never-ending story of PrEP. So as you know, we launched our PrEP program in November 2019. And we struggle with meeting demand and need for PrEP, and our services are extremely busy. At the moment, we have 13 approved public PrEP services around the country, which are indicated in the red points on the map there on the right-hand side of your screen. And we have 17 private or GP-approved PrEP providers, 8 of whom were approved since the last time I spoke to you in November 2022. One of the big projects we're working on at the moment is the development of a PrEP e-learning module alongside our multi-sectoral PrEP working group, which is very busy again, to ensure that we can actually increase the number of PrEP providers in both public and private services. And hopefully this will go to serve to meet the demand and the unmet need for HIV PrEP around the country. You can see a little screenshot from what the PrEP e-learning program looks like on the bottom right-hand side of the screen there, and it's likely to be made up of 6 modules, 3 of which are currently in development. And I have to say, I've been really overwhelmed with the level of engagement we've had from our stakeholders, including community stakeholders and end users, on the development of this resource, which we hope will really help to improve the number of PrEP providers around the country. By way of activity update for PrEP, this is quite a busy slide, so I'll talk you through it. And we, as many of you may know, when an individual is approved for PrEP now, that approval system is done through PCRS, which is a primary care reimbursement scheme in the HSE, and individuals are approved by a PrEP provider as meeting the criteria, the eligibility criteria for PrEP. And then when they present to a community pharmacy with the prescription and that prescription is filled, the community pharmacy is then reimbursed. So we use this data to measure and to monitor activity in our HIV PrEP services. So focusing on the top line, you can see the number of individuals who have been approved in 2022, Q1 23 and Q2 23, we use that as a proxy of how many people are actually presenting to services. And you can see there's quite a lot of activity in Q1 2023 and Q2 2023 compared to all of 2022. And I can tell you our services will certainly tell you that's the way it is for them, that they are very busy. The second line down then looks at the number of individuals for whom the community pharmacy has been reimbursed at least once. And you can see this figure for Q1 is almost 3,000 and is almost 3,500 for Q2 2023. So people, despite the fact that we know we've got significant unmet demand and potentially unmet need for PrEP, that people are still being seen. The next line down is a very important marker of the PrEP program, which is the number of people who have their first PrEP prescription who are new to the service. We want to ensure that all the time we are continuing to get new people who will avail of this and benefit from this intervention into the PrEP program. And you can see from Q1 this year and Q2 this year, we have almost 350 people in each quarter getting their first prescription. That looks like that proportion overall is going down, suggesting that our services are reaching saturation point, and that's something that we need to focus on and keep a very clear and careful eye on as time moves on. And that's one of the key indicators that we report to ECDC of how our PrEP program is functioning. And the final line then is basically existing PrEP users who are having repeat prescriptions. And you can see that services, and this suggests that once individuals get in to PrEP program and start on PrEP, they stay engaged with the PrEP program and that they continue to fill prescriptions. Fast Track Cities initiative is an initiative that Ireland signed up for in 2019, and the Department of Health signed the Fast Track Cities initiative in 2019. And Rachel and Caroline have done Trojan work with many of you in the audience, I'm sure, around working towards developing implementation plans for each of the cities. It's been a huge undertaking that Caroline and Rachel have taken on, and there are many chapters to this study which are being written at the moment, and the intention is that this will be published later in 2023. Rachel presented some of the work at the Fast Track Cities conference in Seville last year, and her presentation has been accepted for presentation in Amsterdam in September next month, which is a good showcase of the work that we're doing in Ireland. And there's a lot of engagement within the Fast Track Cities community of liking the way we're looking at how to understand what each city needs in order to develop their own Fast Track Cities initiative implementation plan. Mpox response, what a difference a year makes. I was looking at my social media feed, and you get your memories posted up every now and again. And this time last year we were in a very different space to where we are now. happily, the epidemiological picture with respect to Mpox remains very stable, in that we've had a very quiet year with the number of cases diagnosed in Ireland up to the week ending 29th of July. There have been 3 cases reported, which represents a 97% decrease from where we were at this time last year. As you know, vaccination is a very important part of our approach in preventing illness and instant infection associated with Mpox. And this time last year, we were faced with some very challenging and tough decisions in the setting of only about 500 doses, and making a decision to offer vaccination to individuals who'd had a recent diagnosis of early infectious syphilis. Fast forward a couple of months from this time, exactly 12 months ago, and we were able to open the national booking portal, self-booking portal, in November 2022. To date, through that service, 18,000 appointments have been made. 11,500 vaccine doses overall, including the early infectious syphilis cohort, have been administered since Mpox vaccination began. And just over 5,250 individuals have completed their Mpox vaccine schedule. That is good to have achieved in less than a year. We do know from services, though, that individuals that they are seeing coming into their services may not have availed of vaccination. Still, there is still an unmet need within the community of people who may benefit from vaccination who've not yet availed of it. Thankfully, we're in a position where we have more vaccine available now, and our focus now is on moving from out of the emergency crisis phase into business as usual, such that Mpox is incorporated into our public services as something that we do, and that individuals who would benefit from vaccination can avail of that, along with the suite of other vaccines that they avail of, including hepatitis A, hepatitis B, and HPV vaccination as needed. Also, since this time last year, we now have antiviral medication available to us, and our stockpile of medication available should individuals present and need antiviral medication is a much more secure situation than we were in this time last year. So whilst we're moving away from the crisis phase with respect to our Mpox response into business as usual, there are many, many uncertainties for the future months, and we must proceed with cautious optimism that the epidemiological picture remains as it is right now, but that is fraught with quite a lot of unknowns into the future. So what next for the clinical work within the programme? So we'll continue to work on our current work streams, and a large part of our work streams are the Mpox business as usual response, prep, and managing the online STI testing service. We will continue to work this year at the Department of Health on the development of the new sexual health strategy, noting that the model of care, which is still an outstanding piece of work from the first strategy, still needs to be done. And that is something within our clinical team we'd really like to focus some time on, but we haven't had the ability to do that thus far. What about DoxyPEP? So I was in Belfast on Bank Holiday Monday, and I walked past W5, which is a very cool interactive space for young people: who, what, where, when, why. In respect of DoxyPEP, I think there's W6. So who would benefit from this intervention, which is where individuals who are at risk of instant bacterial STIs, particularly chlamydia and syphilis, and to varying degrees gonorrhea in different cohorts, have a reduced risk of acquiring these infections if they take doxycycline following a potential exposure. Where will we do it? When will we do it? Why should we do it? Well, the why should we do it is really clear, because there are several studies now that demonstrate that this is an intervention that does reduce instant bacterial STIs, like I said, chlamydia and syphilis, and to varying degrees gonorrhea in different cohorts. Internationally, the response to this intervention within the health community has been varied. At present, it is only currently recommended as an intervention that should be offered to individuals in California. There's a lot of why nots, and I think Ireland needs to consider the whys and the why nots as part of establishing where this intervention will fit in our armamentarium in improving sexual health outcomes for individuals at risk of bacterial STIs. We have started to do quite a bit of work around understanding where this intervention will fit within Ireland. We have to ensure that we, while people will benefit from it, that there isn't undue harm associated with it as well. So I would say to you, watch this space. This is something that we are beginning to focus more and more attention on within the programme. So there ends my clinical updates, and I'm going to give a very quick whistle-stop tour from the other streams of the programme. So with respect to research updates, particularly for the gay, bisexual and other men who have sex with men community, hopefully later on this year we'll have EMIS 2023. And EMIS is the European MSM Internet Survey, and as you know, there have been several iterations of this in the past. Massive team effort going to put this together for a launch in October 2023, we hope. And I cannot tell you that in my work within the programme how valuable the information of this resource has been. If we don't know where we are, then we don't know where we need to go, and we don't know how we're doing in respective response to improve and meet people's needs. So when the EMIS is launched later on this year, please do avail of the opportunity to complete the survey. And a huge thanks to all the individuals who are working with Nicola and Aideen in the programme on getting Ireland's readiness for EMIS 2023 in place. So campaign updates from Anita Butt, and so many of you may know that Anita has now left the programme. She's working with the National Immunisation Office and her post is currently vacant. And Anita works alongside many of you, particularly Porrig in Man to Man on the Gay Health Network and all the campaigns to ensure that individuals have access to the information and the resources for seeking help, and to help them to make good informed decisions around better sexual health outcomes. And just a snapshot of some of the campaigns that have been run in 2023, with particular focus here on our need to run a Shigella campaign, particularly around Pride this year, because unfortunately we are starting to see an increase in the number of cases of Shigella, and internationally there are some concerns about our ability to treat Shigella, so it is a bug that is becoming increasingly difficult to treat. National Condom Distribution Service. So last year I presented some figures on this, and in all of 2022, bearing in mind this programme was only launched in 2015, in all of 2022, over 1 million condoms and almost 620,000 lube sachets were just ordered from the National Condom Distribution Service. The growth between 2021 and 2022 was a very significant increase in the number of condoms and lube sachets that were ordered, but also very importantly, a significant increase in the number of organisations ordering condoms and lubes as well. And to the end, it looks like for 2023, up to the end of June this year, almost over 500,000 condoms have been ordered, and 312,000 sachets of lube have also been ordered, suggesting that this service is actually continuing to meet the needs of individuals in respect of access to condoms and lube to promote better sexual health outcomes. Finally, onto the education and training updates with respect to the gay, bisexual and other men who have sex with men community, and thanks to Moira and Quiva for their update on this. And again, this is, I think, all of our work, all of the updates highlight within that is underpinned the multi-sectoral collaborative working that goes on within the programme. So in 2023, the continued to work on the online facilitator training for delivery of In the Know, and between June 2021 and June of this year, over 1,000 trainers have availed of this facilitator training programme. There's also within HSE land the development of the LGBT awareness and inclusion training, the basics on HSE land, and over 8,000 individuals have availed of and completed this training module between February 2020 and between 2020 and February 2023. and also the programme has worked with Outhouse in continuing to deliver personal development programmes for the gay, bisexual and other men of sex with men community, 6 sessions per programme. And one of the things I'd just like to highlight about the LGBT plus awareness and inclusion training is one of the core criteria for individuals who are looking to become private PrEP providers is that they have completed this. And that's just highlighting the importance of ensuring that there is a cultural competency in individuals who are providing PrEP to people who would benefit from this intervention. And thank you to all my team working at SHCPP and to all of you for listening. I wish you well with the rest of your conference today. Again, I'm sorry that I can't be with you, but hopefully I will be not blown away down in the west of Clare, and hopefully the sunshine will shine down on us when we're down there next week. Thank you.
To give an update on the epidemiology of STIs in HIV in Ireland. So this is just to start with the acknowledgements to everybody in the room and outside the room for the provision of the data and for the support and guidance in interpreting that data. The partnerships we have with lots of people in the room and outside the room are really valuable to us, and thanks also to the HIV and STI team at HPSC. So as we all know, STIs have a very significant impact on sexual health and well-being, and there are key population groups that are particularly affected by certain STIs and HIV. And they include, of relevance today, the gay, bisexual, other men of sex with men community, and transgender people. So for the talk today, obviously it's only 10 minutes, I'll stick within time, and I'm going to focus on 3 particular STIs, Mpox, syphilis and gonorrhea, and then talk briefly about HIV and Shigella. So I think Fiona has referred there to Mpox. As we all know, it emerged in May 2022 as an international outbreak. And in July 2022, it was declared as a public health emergency of international concern, and that's been stepped down in May of this year. And the response in Ireland was a really collaborative response between lots of people who are here today, and people across the health service, community stakeholders, and it really was multi-agency, multidisciplinary. In terms of the global picture, as Fiona said, there's been a total of 90,000 confirmed cases to date. There's really been a decline in cases since August of 2022. And if we look at our own data, so this graph just shows the Mpox notifications by month in Ireland. So we can see that our first case was in May of 2022, and our most recent case has been in April of this year. As Fiona said, just 3 cases so far this year. We can see that the cases increased up to August, and then they began to decline from there. So of our total number of cases in Ireland are 229 cases. The majority nearly all of those were in men, and nearly all of those identified as GBMSM. Significantly, and this is very similar to the global picture, about a quarter of the men diagnosed with Mpox were living with HIV, and about 31% were HIV negative men on PrEP. In terms of where the people were, their region of birth, the 2 significant groups were men born in Ireland and men born in Latin America. And I think, as Fiona says, cautious optimism. There has been some recent cases in Western European countries, and in the 4 weeks prior to last Friday, there was 65 cases reported from Western European countries. Particularly, there's a cluster in Portugal. There's been cases reported from the UK, France, Spain, Italy, Germany. So it's not unlikely that we will see a case or some cases in Ireland, but hopefully we're in a better position to deal with them. To just move quickly on to early infectious syphilis, Martha, my colleague, is here today as well, presented on this comprehensively last year, so it's just an update. So this graph shows the number of early infectious syphilis notifications in males by month, and it starts at the start of 2019 to the middle of 2023. So while we did see a dip in 2020, which was due to the COVID-19 pandemic, we saw increasing rates in 2021 and 2022, but they weren't at the same rate as they had been before the pandemic. And the trend has stabilised in 2022 and 2023. And there had been an outbreak declared in July 2021, and that's now been closed. Our rates are still high for syphilis, so I suppose it's still something for us to be concerned about, but they haven't been increasing. This graph shows the number of notifications of syphilis, particularly in males, and the green portion of the bar represents those that identify as GBMSM. So you can see that's the majority of cases, 90%. Again, similar to Mpox, a significant portion of those men are living with HIV, and of the HIV negative cases, 30% on HIV PrEP. but the remaining negative cases aren't, so it's something to think about as well. Gonorrhea then is another important STI which is very common in Europe and in Ireland. So we saw the same decline in 2020 that we saw across the board, and the trend was looking pretty steady until about the early, say, spring, summer of last year, 2022. So this graph shows the notifications in males by month from 2019 to 2023, and you can see by the middle of last year we saw this sudden increase in gonorrhea in males and in females. So if we compare the numbers in 2022 with numbers in 2019, which is the pre-pandemic year, there's been a 45% increase in male cases and in female cases. And the increase we're seeing is in younger people, so particularly in males, we're seeing it in the 20 to 29 years age group, and we're seeing it in young female heterosexuals as well. And this has been seen across Europe, and it's something that's of concern in most European countries. And this graph as well just shows the notifications, particularly among males, and it's clear that most of the male notifications are GBMSM. And one particular thing which Fiona mentioned as well that has been a change is the online testing programme, which was introduced in 2021 but rolled out more fully in 2022. So when we looked at our 2022 notifications of gonorrhea, almost a fifth of those come via the online testing service. So this is a significant increase in testing capacity, which will increase our diagnosis. So it's not always bad news that we have more diagnosis, but it can't account for all of the increase we've seen. So there is something else going on, probably increased transmission. And HIV, I'm just really going to touch on this. We'll produce a more detailed HIV report in the coming weeks. I think we probably all are familiar with the picture on the left. So it's HIV notifications by year in males. So we had declining notifications in 2020 and 2021 due to the pandemic. And then we have seen this huge increase in 2022. When we look at that if you look at the second graph, it breaks that down by whether or not people have previous history of HIV diagnosis. So the green portion of the bar is people who didn't know they were HIV positive. This was their first diagnosis. The blue bar represents people who were HIV, and they arrived in Ireland and they were linked into care. And the grey part is where we don't know. So I think what we're seeing is not an increase in new diagnosis, but an increase in this group of people who are previously diagnosed positive. And the important part there is to ensure that they are linked into care and there's no interruption in the care, and that is a challenge. Obviously, we had lots of things going on in the world in 2022, but particularly the situation in Ukraine and other situations across the world have led to this. This is that graph again, but just in GBMSM, so it's notifications by year in GBMSM, and the green represents where we know that they're new, and the blue represents where we know that they're previously positive. As Fiona touched on, there's been an emerging situation with Shigella for the last couple of years. So Shigella is usually a gastro infection. It can cause stomach upset, which can be severe, and it's known to be transmitted also by sexual contact. And in March of 2023, you can see this graph just represents cases that were notified between week 1 and 22 each year. So you can see the 2023 is the last bar. So we had this sudden increase in February, March of this year. So an alert was issued by HBSC and an incident management team was formed. And there's 4 clusters of concern among that are being transmitted among GBMSM, and 3 of those have associated antimicrobial resistance, so may present difficulties in treating. And the IMT has had 3 strands, and there's lots of people involved in that. So there's a communications strand, which the Gay Health Network and MPAR have been involved with. And there's a clinical strand looking at guidelines for treating Shigella, and the surveillance strand, which is trying to improve our data. I just wanted to present the next slide on what we know about HIV and STIs amongst transgender people. So we started to collect this data in 2018, and we started to ask about gender identity amongst our HIV and STIs. So what I present here, I think it's not fully complete or comprehensive. So we report people as being transgender if it's reported that they have a gender identity different to the sex of birth. So I would say that this data isn't complete, but I think it's still really important to present it and to begin to show this in all of our reports, so that they can be represented. So the top graph is our STIs we've seen in trans females since 2018. So we've got gonorrhea in the green, syphilis yellow, and HIV blue. So you can see there's a mixture of all 3 over the years. And the bottom graph is our STIs and HIV in trans males. So less overall, but 2 quite big jumps in gonorrhea in 2020 and 2022 in trans males. So in summary then, we know that the COVID-19 pandemic led to a decrease in STI and HIV notifications in the pandemic years, and then we did all expect a bounce back from that as we all returned to normal, socialising increased. The rates have gone back to normal, and they've gone higher, which maybe is also expected due to the severity of the lockdowns. We also must bear in mind that we have increased STI testing. So we have the home testing service, and as Fiona said, it was between 50 and 60,000 people testing with that last year. And also with the PrEP programme, there's more regular STI testing. We've seen a stabilisation and reduction in some STIs, and particularly we've seen an increase in gonorrhea, and particularly in young people. And I suppose the concern with gonorrhea is also the antimicrobial resistance potential of that organism. The recent emerging infections, it's really interesting. I think we think of typical STIs, but then we also have lots of infections that can be sexually acquired and can be transmitted by sexual contact. We didn't expect Mpox last year, and other organisms will be the same. In terms of HIV, it was a very brief look at it, but I suppose it was just to show that the majority of our cases are previously diagnosed positive outside of Ireland. In conclusion, we want to continue to collect, hopefully timely and accurate data on HIV and STIs, and we rely on a lot of people for that data. And that's the main, there's lots of reasons for that, but the main reason is the overall aim is to improve the sexual health and well-being of key populations, and we really want to continue to work in partnership with our statutory and NGO partners. It's probably the best part of our work to get to work with people in this room and outside the room, and otherwise it's just data. Okay, thanks very much, and delighted to be here. Thank you.
Very much, Kate. It's great to see the success story that is monkeypox. It's incredible to think that last year we were all steeped in monkeypox anxiety, and this year is kind of almost nothing, but very sobering. Unfortunately, we see the rest of those statistics rise. It underscores obviously the need for increased resources in testing and treatment services in STI throughout the country. And I always think that we're an amazing, imaginative, intelligent, creative bunch of people, and over all the years that I've worked in HIV and STI activism, the challenge is still there for us to make a successful, sexy campaign that looks at condom use to make them attractive for men. I think we still haven't got that challenge down. Our next speaker is from the Gay Men's Health Service. And the Gay Men's Health Service remains a unique service in Ireland. It's the only one in the country, in Dublin, and that's unfortunate because it would be a great model to put out into other cities. So again, more resources are useful there, but it would be a great model of practice to repeat nationwide. So from the Gay Men's Health Services, our colleague Jessie Ennis, who was involved in organising the conference as well, alongside the conference committee. And Jessie Ennis is Service Manager of the Gay Men's Health Service for the last 2 years. She's worked in the HSE for 6 years with previous roles in project management, HR, and in the National Clinical Programme Office. She sits on a number of national working groups for the LGBT community, including GBMSM Health Committee, Chemsex Working Group, Mpox Implementation Group, and the LGBT Homelessness and HSE Outreach Network.
So my name is Jessie, I'm the Service Manager for Gay Men's Health. I'm going to fly through this because there's a lot. If people don't know, Gay Men's Health, or GMHS, is a sexual health PrEP service for gay and bisexual men, other men-sex men, and the trans community. It's a national service, so people from all of Ireland can attend. We're currently located in the Meath Primary Care Campus in Dublin 8, and we are governed through Community Healthcare East of the HSE. A bit of a background, there's some lovely photos there where it was first established, which was Baggot Street, which I've heard some fun horror stories. So it started in 1992, so, just over 30 years ago, and it was 1 night a week. We're now doing 4 days a week service. We are expecting by the end of this year up to 150,000 visits by the end of the year. Just a background, in the last few years, we were obviously impacted by COVID-19. Most of our staff were redeployed, and then we also had the impact of lab services curtailed with the cyber attack. I will say with the cyber attack, we were completely non-electronic, and we were thankfully not too heavily impacted by that. besides the lab service. We had a PrEP service established and maintained. A lot of our patients then went up to guide during the pandemic. We reopened in 2021 and we're continuing to get back to our numbers as the years go on. The big changes, we had to deliver the service with the IPC guidelines and social distancing, so most of the appointments in there are all booked. We don't have a walk-in clinic. And then just to mention as well, we also had to deal with what was happening with the MPOX in 2022. So post-COVID, again, as I was saying, when I first started in Gay Men's Health, it was very, I feel like dinosaur era, because appointments were on Excels and diaries and things like that. But now we are doing very well. We have a fully implemented electronic patient system, and we have an electronic waiting room management system. And we are now, thankfully, in the last few weeks, receiving our results electronically, which I know the team here we're getting used to it, but it's fantastic. It's going to be revolutionary. We have an online booking system, so patients can make their own asymptomatic screening appointments using SwiftView. And we're also doing virtual screening for the likes of PrEP and some community treatments. We're doing prescriptions via health mail, and patients are doing their own STI screening in the bathrooms. And I'll talk later about the SH24 pathway that we're now using, and we're working with other colleagues here on the social media platform trying to signpost Gay Men's Health and health promotion. So yeah, big change in Gay Men's Health in the last 2-3 years, which is fantastic. Looking at the numbers there, you can see a big drop off there, obviously in 2020, 2021. And we saw just under 7,500 patients in 2022. And we are expecting to see just over 8,000 by the end of the year. I just highlighted there as well, we do have quite a high DNA rate, and if we didn't have our DNA and unable to attend, we'd likely to see around 10,000. So we're steadily building back up. Just for the first time attendees in 2022, we completed the new reg form. 36 had never previously tested for an STI, just under 20% are under 24 years of age, and just under 50% are under 29. 47% are from abroad, so not born in Ireland. 15% reside outside of Dublin, and 2.4% of new grads were trans or non-binary. And we've also seen 950 new patients in 2022. And 30% of our patients are from Brazil. So looking at our clinics, you can see 35% of our clinics appointments attended are for PrEP, and then we have our asymptomatic clinic as well. Then we have our medical treatment or symptomatic clinic, and we have 15% vaccinations, and then about 6% are tested cures. You can see there our clinic sort of times with PrEP on Tuesday, ASINs on Wednesday, and with a vaccine symptomatic clinic on Thursday, and our Tuesday evening clinic for symptomatics and treatments. We also do PrEP phone consultations on the Monday, and throughout the whole week then a large volume of results management. And just again to highlight, we do have quite a high DNA rate in the last sort of 2 years. Vaccinations we have every Thursday, and then also our PrEP patients are vaccinated at their appointments there. So we've administered over 7,000 Gardasil vaccines since 2017. We also do the Hep A's, Hep B's, and then you can just see there we're also involved in the MPOX vaccinations last year for animal that was identified with early infectious syphilis in GHS. Just sort of running through these. Results management, really large part of what our service does. We send and receive approximately 130 to 150 patient samples every week to the lab, and we're interpreting up to 1,000 results every week, individual results. In 2022, there were 1,400 new infections identified, and a further 530 identified as previously treated. All of our patients that have negative results will receive a results all clear SMS. And then just looking at syphilis there, in 2022, we had 153 that was either early infectious syphilis, new latent or reinfections, and then we had almost 500 old infections come through the service as well. On HIV, these are first-time HIV diagnoses that were previously unaware. For us, it's been dropping over the years, and we had 12 new in 2022. Further, more diagnoses, the main STI there will be gonorrhea. In 2022, we had 629 infections, of which 404 patients had at least one gonorrhea infection. And then looking at chlamydia, we had 452 with 320 patients having chlamydia. If you look at the sites there, 50% for the gonorrheas are pharyngeal, 41% rectal, and then for chlamydia, 63% rectal and 15% then are pharyngeal. And then this is just our month-on-month of gonorrhea and GC. It is a little bit higher in the summer months and for some reason in November as well. So yeah, looking at PrEP appointments, if we look at 2022, we had just over 2,500 PrEP appointments attended. And since 2021, we have seen just over 550 new PrEP appointments attended. So the 2023 figure as well is just for the first half of the year, so we're definitely hoping to increase as the year goes on. And then just to highlight as well, we do have quite a high DNA rate for PrEP appointments, which is really unfortunate. In 2022, 388 PrEP appointments were DNA'd, which is 14%. And if you look at even the PrEP screens are at 16%. So I'll talk about how we're trying to tackle that one way. Looking at PrEP patients, so this is a patient who has had at least one appointment in GMHS for PrEP year by year. So you can see there in 2022, we had almost 900 patients who had attended us for PrEP for at least one appointment. And looking at 2023, again, that's just from January to June, we've already seen about 750 patients for just one PrEP appointment. So we have fewer new appointments, but we are continuing to add in new patients. And then just looking there, our PrEP return patients, just 66% are on the daily dosing, and then 23% are on the event-based. So looking at our new SH24 pathway for PrEP patients, we implemented this as part of the HSE PrEP guidelines that came about in March. So certain PrEP patients who meet as criteria are moved on to this. The key benefits of which are that patients can self-manage their sexual health and PrEP use, and there's a 50% reduction in their need to attend our clinic. So what they'll do is they will do an SH24 test, and they'll call us if they have any positive results, but if not, we'll see them then for the next prescription. So progress to date, we've already made 284 PrEP patients onto the SH24 PrEP pathway since March, and it's about 54 patients a month. For our capacity, it's great. We expect to free up 400 PrEP appointments by the end of this year, and it also helps tackle the screening, the DNA rate of 16%. We are thinking it might introduce around 200 new patients for patient appointments for 2024. So yeah, that's just, we have a patient information leaflet. Just to highlight, Dr. Bronagh Courtney, who will be here later, done a new PrEP audit, just looking at the monitoring guidelines of the renal, and just that we've done very well, and it was only 13% failure rate. But we like to do internal audits and then learn from our how we can improve. Just looking at PEP there, a significant decrease for us, and also a 5 weeks, I still have a few more. Just other clinical activity we do. Fiona had mentioned it, some of our positive chlamydias can be treated just through a virtual consultation. No need to attend the clinic, and they get the prescription. We also do a rapid test every month. You can see sort of a month-on-month there of how many we're doing. We also have a full-time health advisor now since January, which is fantastic. So partner notifications happening, and the consultations. And just to show there that we are doing around 14 sex assessments every month as well. Looking then at our counselling, we year on year seeing an increase for the demand for the counselling service, 55 times we're seeing last year, and that's just sort of a word cloud of the issues that arise. So if you look at relationship anxiety, coming out, trauma, loneliness, I'll keep going. Just to say as well, we were involved in the Eurotest Week social media with Man to Man, which is fantastic. So they are available online. And just looking ahead, we're looking to increase capacity, our resources, continue the PrEP SH24 pathway, improve patient experience, patient group directives for vaccines would be great. We are always keen on recruitment and retention, and if I may say, if I'm looking to be a nurse in UNHS, we are always looking, so please get in contact. Education, training, research, reduce our DNA rates. We're looking at Dropbox for samples and TLCs. Doxy PrEP, question mark, we don't know what's going to happen, we're great. PrEP appointments, announced by the Minister of Health, the app, we heard about it, we will see what happens, and then also look at reducing our results turnaround time, which would be great now that we are all electronic. And then just the last one there to say thank you so much to all the GMHS staff who are here. Without them, I
Thank you very much, Jesse. You definitely more than them. Our next speaker is from our own Gay Health Network and man-to-man service. So Padraig Burke has become synonymous now with the various programs that we put out there. Such as his energy and enthusiasm that I think this year is our busiest year yet, with more programs than we've ever produced before. So here to give us a snapshot on all of those programs over the last year is Padraig Burke.
So, yes, I work with Gay Health Network, look after their communications, and I work closely with the Sexual Health and Crisis Pregnancy Programme, which is AVITA, and the Programmes and Campaigns Department, which most often is Mirren, Tristan will be familiar with there. So this is just a quick look at the different campaigns we've had over this year and the previous year, and you can see there the different ways we reach our audiences. So yeah, to look back at 2022, there's sort of campaigns we had with the data you can see we did the prep with the Rainbow Project in Belfast. We went out our another facts manager bottom using hoppers. So monkeypox was a big one that we did in partnership with Empower, and obviously like the communications we put that. And then Shigella as well. We went out with a small Shigella campaign last year, but then a month later monkeypox took over, so we took a back seat, but it's back. And then looking at 2023, we've had a busy year with some nice campaigns. We had Proud and Prepared during Pride. We went out with Euro Testing Week as well, which we did a lot of work for with our partners, the Gay Network, and then Shigella as well. And also we re-promoted the VEDA U equals U during Pride. We were meant to have an HIV stigma campaign going, but there's a little more work needed to be done on that. The community and other partners in the Gay Network as well, and people living with HIV. So hopefully that will go online. This November, we're actually going to throw a lot of focus on that over the coming months. So yes, just to touch on last year, because we had the last Gay Health Forum was last November. So we were updating it last November. So following that, we had some World AIDS Day reads last year, and VEDA did a Know Your Status one first in September for World Sexual Health Day, and she put it out on World AIDS Day, and it got 27,600 votes, which is views, which is a lot. So it just really shows the importance, when you get the right content and important content and working with a sexual ambassador like VEDA, you can get really good results. We also had really good with Jordy as well that we did with some Voices from Afar, because Jordy lives with HIV, and that did really good as well. I think he got 2,000, which is quite a lot, but sometimes you can't it's much more than what our sort of followers are. So this is just a little online campaign we did with Rainbow Project last year as well, just prep, so just some really nice inclusive graphics for that. Okay, so this year's sort of the biggest thing we did coming up to me was testing week. So we developed a campaign, we created a partner pack, so we had a projection on that panty by there, you can see it, which is great for a week at night time. It was a week of Eurovision as well. So we had made the poster side as well, a digital poster, and also we made A5 flyers, which are down at the bottom of the room actually, and if anyone wants to take some back to where you've come from, your venues or your services, please do. They're English and outside, and 3 languages, French, Portuguese, and Spanish and the other. And so that was in May. There was a second part of this as well, so we worked with our partners in the Gay Network, and we created some carousels for Empower, GMHS, GOSH, Sexual Health in Cork, Sexual Health West, and the Rainbow Project in Belfast. So little carousels, just telling people about the testing services that were on offer, like mostly rapid testing, and in the case of GMHS, sort of in-clinic screening as well. So we also then, for this, we made a number of reels. We made 3 with the Gay Men's Health Service, which is really great, and thank you for doing that. So we're actually going to play just first one with Jessie.
Hi, I'm Jessie. I'm the service manager here at the Gay Men's Health Service. So the Gay Men's Health Service, or GMHS, is a sexual health service for gay and bisexual men, other sexual men, and the trans community. The GMHS is located in the new primary care campus on Hastings Street in Dublin 8. The GMHS offers both asymptomatic STI screening, symptomatic STI screening, STI treatment, and the PrEP service as well. We do one version a week of ours, which is still really popular for people who work. Most of our services are provided during the day, so we're providing symptomatic STI services during the day. Our PrEP services provided during the day because the bloods that we take have to be spun down in St James's Hospital, so we couldn't really provide that service in the evening. So we're providing clinical services, face-to-face patient services on Tuesday, Wednesday, Thursday, and then on Tuesday evening as well. So we've really expanded our hours.
So we have a Proud and Prepared campaign as well, which we did in partnership with Dublin Pride and with Link. I think it was important, working with Jamie as well as on board, that we did this for, sort of pushed out a campaign for the sexual health of all, rather than just gay and bisexual men. So we teamed up with Link for that. And beautifully designed graphics as well by Colin Malloy. So they appeared, at the Dublin bus shelter and Stephen's Green. There you can see we had a Pride advertising truck. There's also a big poster, I don't know what you call it, in the Pride Hub. So yeah, it was really good. It looked really well. And we, again, for that, we prepared a partner pack as well that we sent out to all our people, and we also got t-shirts that was also make us sporting there. And we had it as well as Marion Square, which was a lovely day there with Susan Dunn, and we also had it. So yeah, very proud and prepared. So we also had the Shigella awareness campaign, which went out. We created a partner pack for all our partners, and HSE would send that out to their respective departments and everything. And so we did social media, Grindr, and then obviously screens that appeared in Pantigar as well. We have it here. It was also, we also created digital ads. So that's still ongoing, and there it is. Also, there's a Q&A in the Pride edition of GC. So just having a look at our website numbers are down this year. There's a couple of reasons for that. Previous year we had 20 Grindr ads going on because of our partnership. We spent a lot of money. We had less last year, so that accounts for a number of some of the reasons why the numbers went down. Another reason was our organic search went down. And another reason was in October, whatever way the new sort of cookies are happening with the HSE, so if you don't click accept, then you're just not counted. So they think it's about a 30% drop. So anyway, we have a new website coming. It should be online next week. We're hoping to have it online. We can't even have a look at the sort of preview here. But there's a lot of work went into it. We have Diego's looking at the Portuguese version for us over the weekend, so we should be online in the next few days. We'll let you all know so that you can look at that. There's been a lot of work put into it. I mean, it's just an upgrade, but it's tricky. So having a look at Facebook and Instagram there, I mean, these numbers are very impressive. When I'm joking twice, they are, we've got 435% of Instagram profile views, 288% of new Facebook likes, and our paid impressions are down 8%, and our Facebook reach at the top there is at 14%, and you can see the top 5 posts there. So 2003 so far, our Facebook reach is 237,546, Instagram reach 32, and then 1.5 million almost impressions. So the other thing, then just have a look at Twitter. Like profile visits last year was 43,251, and I double checked that as well, which is a lot. I think a lot of that had to do with beta and the Zoom sort of content we had, which is really, really brilliant. This year, everything just sort of has gone wrong with X. So it's definitely one of those figures again. And I mean, now that TikTok has brought in the text option, I think there's a, when they have a lot more younger audience, so there will be the 8 Grindr inbox messages, just like through there, syphilis, mental health, Shigella, and because as well, we're putting out stuff on Mpox, so we didn't cover that. And the digital displays then, like 29,000 clicks to the website. There's a few examples, so they expected 4,700, so that's quite good. Paid search, 256 impressions, click-through rate of 9%. Yeah. Watch rooms there, selection of the posts are going to watch rooms that go out every, like throughout the year, and sort of pinpoint what we're going to cover. Again, last year we worked a lot with our on the impacts. So as well, like there was a bit of an accident with GCN and Vegas poster didn't get into it, so they gave us free advertising at So that's a really great opportunity to reach your perfect audience. So GCN magazine as well, every opportunity we have to integrate to full page ads, and here's the GCN MPOX edition. So we had, it's not really an MPOX edition, we had 3 full ads that were word programmed on the IMO page, and there's a FAQ in as well. And as it turns out, the vaccine wasn't available, so not for another one to just hit the last year, but yeah, so sorry, that's what MPOX edition is funny. So yeah, last year we had Voices from Afar. This year we've Making Waves, which was premiered at Phase Film Festival last Saturday week, and we're actually going to see it later on, and the director Shane is going to come along and introduce it to you. We're delighted with it and we hope you enjoy it. Key findings from our 2022 research survey. So MPACs, 57% have heard or seen the advertising, and LGBT venues is where they saw it. So it just really shows the importance of posters and jacks, and above toilets and hand dryers. People, do you know what undetectable means? It's 71% data from 59 in 2022. Undetectable equivalent 72. Knew what it means up from 62%. And I think that's got a lot to do with the activists that are out there, like Veda and Robbie and many others, creating awareness. And then have you ever heard of PrEP? 75% have from 54 in 2022. And I think that's because of the lack of availability, rather than any sort of big campaign that's been done. I think it's, you can find out more data. Our annual report is just online now. So what's next? The new website of the Style Guide coming up. We have a vaccine campaign coming up next month. We're going to work with our partners in putting that out. And the HIV statement campaign, which I mentioned earlier as well, which is very important. And then 30 years of GHN next year, so we're going to plan for that. And I want to work with all people here that we work with already. And thank you everyone for all work. So I'm going to leave you with a final video.
Bisexual men have many options when looking after their sexual health. PEP and PrEP are 2 medical options to prevent HIV. One is taken before sexual contact, one is taken after. So PEP is post-exposure prophylaxis. If you feel that you've had an exposure to HIV, you have 72 hours to access that medication from any sexual health service or the emergency department. So if you're concerned about a potential exposure to HIV, I would recommend contacting a service as soon as possible. You have vaccinations for hepatitis A and B and HPV, which you can get free at any sexual health clinic. Condom use will protect you from most sexually acquired infections, and I would say that the most important thing for looking after your sexual health is getting tested regularly at one of the free clinics that are available to you. You can order an at-home STI test kit using sh24.ie, but you can also call into your local sexual health service to get a full screen done. You can get tested for HIV, hepatitis C, syphilis, chlamydia and gonorrhea. It's really important to test for those even if you don't have symptoms, because a lot of the time these infections have no symptoms at all.
They did social media pushes, and thank you to David for that. And as well, we were going to mention monkeypox, but then it changed, so we had to cut that bit out. And that's it. Thank you very much.
Thank you very much, Buddy. Very rapid whistle-stop tour of all of our work. And on top of all that, he was also a member of the Forum Organising Committee. So our next speaker is from Empower, Adam Shanley, who leads the Empower programme of HIV Ireland, which is a suite of peer-driven interventions developed in response to sexual health and well-being and needs of gay and bisexual men. So here to give us a presentation on outreach, outbreaks and outcomes in 2022 is Adam Shanley.
Thank you very much, and thank you for inviting me to come and speak today and try to get the mammoth year of 2022 into 10 minutes, which is a bit of a task, but we'll do our best. Yeah, thanks again for inviting me to come along. My name is Adam Shanley, I'm the Empower Programme Manager here at HIV Ireland. For those of you who don't know who we are a small team. We're responding to the sexual health and wellbeing needs of gay and bisexual men. Everything that we develop is peer-driven and community-level interventions. We develop them with a sex-positive approach, judgment-free and harm reduction-based. Our overall aim is to achieve a reduction in HIV and STIs, but also to improve our sexual well-being and to take a kind of a holistic approach to sexual health. We do a whole host of things, and we were really busy last year maintaining our rapid HIV testing, our HIV self-testing service, outreach, trigger warning Mpox and the outbreak response for that, kind of standing up our response to Chemsex, and then maintaining research and advocacy throughout the year as well. So Mpox really took up a huge amount of our time, energy and effort last year, and a part of that response was standing up a kind of communications campaign, which has been mentioned previously. It was a collaboration with HSE stakeholders and Man to Man. And we stood up that kind of communications campaign in 3 stages. The first was alert, and alert was essentially to look at bringing attention to the community about the outbreak, highlighting symptoms, transmission, and testing, and how to get tested. The second stage was empower. So while we waited for access to vaccines, bringing information to the community, so gay and bisexual men could make informed choices about their sex and social lives, as I say, while we waited for the vaccine. When the vaccine did arrive, we moved into the third stage, which was mobilise, and as it suggests, it was mobilising our community into uptake it and to uptake of the vaccine. We employed a whole number of different communications approaches, from outreach, and we had a huge bunch of our volunteers led by Davey in our bars, in our clubs, in our saunas, in our Sex and Princess venues across the city, every day actually in the lead up to Pride, and then a couple of times a month, at least once a week, all the way to the end of the year. Some of the best is dealing with drag queens, and Davey, I think, has a unique job description where dealing with drag queens is one high point in his job description. We also created community town hall talks to keep people, our community, informed and engaged also with the responders from clinical to epidemiology and to people with lived experience as well, so we could kind of tackle some of the perhaps isolation that comes from, or the loneliness that comes from isolation as well. We used Grindr, we created pop-ups on Grindr to continuously keep people informed, collaborated again with Man to Man on video content so that people knew what to expect when coming for screening for Mpox, and of course then continuing to use mainstream social media like Instagram, Facebook, and Twitter to keep people informed as well. We also, in March of 2020, we launched our Emerge report. So Emerge, believe it or not, that's an acronym, it's a stretch, I know, but it's the effect of COVID-19 and government restrictions on the sexual health and well-being of gay and bisexual men. This is a nationwide survey, and we had 942 respondents, gay and bisexual men from across the country. And I guess the purpose was so that we could inform the impact that the pandemic and the restrictions has had on our sexual health, and to kind of create recommendations as to how we emerge from the pandemic. We launched the survey on the dance floor of a recently reopened Great Club Mother, and again, kind of a hat tip to reclaiming our spaces after the pandemic. There is the reports are actually on the back table. If any of you want to pick it up and read a little bit further. We have the main report, community report, and there's also a social media campaign, and to make sure that the information gets back into the community that offered the information in the first place. We led a number of different campaigns throughout the year as well. The first is Give HIV the Finger, which was a beer mat campaign. We had beer mats in the bars that we offered rapid HIV testing in, on one side of the beer mat, explaining it is a finger prick test, 60-second result, what to expect, and then on the flip side, a QR code so that people could find out when testing was available in that venue. And we also, during European HIV Testing Week, ran a social media campaign that encouraged people to take our free HIV self-test, and that in turn encouraged people to kind of post that they were taking the test, and kind of a snowball effect of people using the service. In that week alone, we distributed 500 self-tests across the country. For Irish AIDS Day, Davy was at the Dublin Pride Hub, and again, we ran a social media campaign so people knew that they could drop in and pick up a self-test at the Pride Hub for Irish AIDS Day. As Park had mentioned, Dublin Pride and other block parties is a really ideal opportunity to get our messages and campaigns directly to our community, and so we ran alongside the NPOX messaging about our outreach and our services in general. As you might remember, following the murder of Aidan Moffat and Michael Snee, we developed a guideline for staying safe when using hookup apps. And so basically safety advice when planning to meet someone that you've connected with online. And also we, over a number of years, ran a campaign kind of advocacy in around blood donor criteria changes for gay and bisexual men, which culminated in resulting in a change of the criteria to individual risk-based assessment, which is now the case. So you won't be, it's aligned to sexual practice and risk as opposed to blanket bans on sexuality and gender. We spoke at a host of events about our work last year as well. Mark presented at Fast Track Cities in Seville on our outreach work and using Grindr as an outreach tool. I presented on some of our Emerge data in Seville. And we also had the opportunity to have an oral presentation at the AIDS 2022 conference in Montreal about devising, developing, delivering and evaluating Ireland's first free HIV self-test service. SSS TDI, Outhouse, our Emerge launch, and the NPOX community town hall talks all took part of our parts of the year. So just really quickly, some of our outcomes from our established services. Rapid HIV testing, we took an intake of new volunteers, which brought us up to 51 peer volunteers. We offered the service in 4 venues across the city last year. We had 171 testing sessions, almost 750 people where tests were performed with 12 reactive results. 9 were linked to care, 3 that weren't. One person was living with HIV, is connected to care and wanted to test to see if it would remain reactive even though he was undetectable, so there was an opportunity for an educational intervention there. And there was 2 other people who were diagnosed abroad and felt that they needed to test positive in Ireland to access testing for free. So again, we did link them to care, but in a different session. So 22% of people that tested with us last year were first-time testers, and that's a kind of a constant between a quarter and a fifth of people that test with us every year and never tested for HIV before, which is a really important metric. And the vast majority of people that test with us are gay and bisexual men, but we don't turn anybody away who wants to get a test. We have a feedback loop, so that anybody that does test with us is able to offer some feedback on their experience. We ask them a whole number of questions to rate us out of 5, and you'll see I've just shaved the end off that 5th star, 4.8 stars out of 5, so not too value. But it's really important to kind of get that feedback so that we're constantly listening to the community and tweaking as we go. With self-testing, we got almost 1,500 tests delivered to all 26 counties in Ireland. We had 4 reactive results, 3 were linked to care. They reached out to us directly and we linked out to care. One person identified that they had a reactive result, but they chose not to use a referral pathway for linkage to care. It's also important to note that it's based on people reporting their results to us, and so it's likely that this is an underestimate of the amount of reactive results that we have. 37% not born in Ireland, 13% testing for the first time, and the first time for HIV, and 57% are first time users of our service. Again, predominantly GBMSM. And of the 92% of GBMSM, 36% have had condom single sex in the last 3 months, and they're not on PrEP. So it's a really important cohort that we're meeting to maintain HIV testing. Again, feedback survey there, and I know I heard the bell, so I'm going to rush through this. Outreach, we had 2,500 outreach interactions last year. 53% were on hookup apps, and Mark will speak a little bit about that later on. 33% through WhatsApp. Again, majority GBMSM, a considerable number of people not born in Ireland. 3% identified as sex workers, and we have a whole host of topics of support that we help with. HIV testing, treatment, STI symptoms, concerns, and MPOX all featured heavily last year, as well as PrEP, of course. And we delivered 191,500 lot of condom and lube packs throughout dispensers and at events throughout Dublin and beyond as well. So again, really positive outreach responses that we get. It's always just nice, even if we find out that we're a sound bunch. But it is really important that we're constantly listening to the community and tweaking what we do. So I just want to leave it on the fact that looking forward, we do have a real focus on chemsex response. And last year we welcomed Andrew to the team, who will be leading out on that chemsex response. So hopefully the next time that we're all together, it will be on the launch of that service. Thank you very much.
You had another whistle-stop tour over a very large amount of work there. Thank you for bearing with us. Only one more presentation to go before coffee, and that's from Darren Lyell, who's Senior Addiction Practitioner at Rialto Community Drugs Programme. He has almost 30 years' experience of working in the area of substance misuse and addiction, and since early 2015 his work is primarily focused on working with individuals in the support and therapeutic capacity, predominantly from the GBMSM community, presenting with issues pertaining to club drugs and chemsex activity. And Graham is a member of the chemsex working group. Thank you.
Good morning, and thanks to David for the invite to speak. First Women's Health Forum I attended was in 2015 when I just started working with this cohort, and there wasn't one mention of chems or chemsex. And I sat in the corner and they're very, very frustrated, thinking, what's going on here? There's no one talking about this. But we had a meeting, and there was a number of people who attended that meeting after the forum finished, so it's good to see everybody here again today. So listen, I'm almost working 3 decades in addiction, based in Rialto in the south of the city, but as was introduced, the last 8-9 years primarily been around club drugs and chemsex. The individuals who I've worked with in that time probably total over 450 to 500 at this time, and they would be quite well aware of the positive aspects of the chems that they're using. But when it comes to actually the detrimental effects of the chems and of the behaviours, it's bordering on naivety and a total lack of knowledge and awareness of what they're taking and what it's actually doing to them in a negative way. In relation to their sexual behaviours, everyone that's engaged with me is all well aware of PrEP and PEP and U=U. So the sexual health messages are certainly getting across to the individuals who I've been dealing with. But when it comes to the chems, unfortunately, they're not as au fait with the detrimental side effects of them. And they're just some of the positives and how they appear, but certainly the lows. And these are things that would, in the initial sessions with individuals, a lot of focus would be on this and where they see themselves and how their use has been affected. The main ones would be, of course, G, T, and they're the vast majority of the chems that are being used. But also there's ketamine is very much prevalent on the scene, and cocaine and MDMA. And of course that will go alongside then your poppers, Viagra, alcohol in some cases, and weed. What attracts people is the chems and the chemsex, as everyone knows, the euphoric effect, greater confidence, the sex drive, the libido, increased sociality and identity, and the diminution of sexual inhibitions, heightened and enhancement of a sexual arousal and longevity. And of course that's an excellent attraction to try any Ken, any drug or any behaviour. But however, what that actually masks, and again, the vast majority of people who involve themselves within, say, chemsex scene, you know, they function, they manage their lives, they go to work. It is a minority that go from that trajectory, which I'll talk about later on, into the kind of more darker areas of chemsex and of chem use. All of these headings that are here, and again, for each and every one of these, there will be evidence-based research to back up that these issues are identified. But these are also all issues that have been identified to me over the years by people who engage. One of the first things I learned when Adam and Siobhan used to do training years ago was around a book by Matthew Todd, Straitjacket. The amount of people that I encouraged to buy that book, and I would get a text or a phone call from them, that book's all about me. If anyone really wants to look at primarily around the guilt and shame, blame, the internalized homophobia, societal's reactions to the LGBTI community, it's an excellent book. And when you have an individual engaging with you to contact with you about that and go, that book was about me, and there's a great learning in that for them. As time has gone on, more and more teens are added to that list. Like the ones most recently would be intimate partner violence, and I know Derek's going to focus on that later on, but that is a huge issue that I'm dealing with at the moment. Intimate partner violence within the LGBTI community is referred to as the double closet. There is very little conversation about it out there, and certainly COVID has added to the very negative experiences of victims of IPV. The non-consensual videos and films and what that can do to an individual. A lot of that would be done when people are possibly gone under, or people being forced to do sexual acts that they possibly don't want to do, or with people they don't want to have sex with, but are being forced to do so. More and more are getting involved in the dealing of chems, and again, that can open you up to criminality. Drug driving, I'm currently working with 2 individuals who in the last 4 months have been stopped and breathalyzed, blood tests taken, and chances are charges are going to come from that. And I would always kind of highlight issues rather than wait on someone to bring them in, because I would say, like, well, you know, if I felt that there was the possibility of this relating to someone, I would bring up previous experience of working with people and perhaps raise 1 or 2 teams and see how they react to that. But certainly, there's a vulnerability and an exploitation of a hell of a lot of people that are involved in this scene. A number of individuals have said to me one of the off-putting things about the Dublin chemsex scene is its toxicity. That they would have partied across Europe, in America, in Australia, wherever, but they've said that they've met a tension and a toxicity, as I said, that they've never experienced anywhere else in the world. And I find that very interesting, and perhaps there's a number of reasons for that. Internalized homophobia, I touched upon earlier on, minority stress, that would be a theme very much explored with individuals. This is from the, I think, 2018 or 2019 European Forum on chemsex, and this is how they defined the various trajectory and journey of the person through that chemsex experience. Now, going back to, again, that kind of naivety, and of course everyone's aware of, you know, the view of people who take chems, right? I'm using the word chems, I'm not using drugs. And language is such an important thing. And when you're engaging with someone in the initial stages and you're using that language, that certainly relaxes someone. And like I said, I'm based in the inner city. The demographic that I'm working with is very different from what I started working with in the mid-1990s, which would have been from inner city areas, flat complex and such. Now I'm working with individuals, third level educated, employed, and with a lot of opportunities. As people would say, I never thought I'd wind up somewhere like this. Right? And it's not that they feel they're any better than anyone else, not at all. But for an individual to admit that they have a problem with something that they firmly believe was part of their identity, of their experience, and that, but I'm not injecting heroin, therefore I'm not a drug addict. But again, the terms TEMS, you know, kind of softens the blow, right, of where they're at. Like one person said to me, Graham, cut the bullshit, call it what it is. I don't want you to call it tea, I want you to call it meth. I don't want to say slamming, I'm injecting, right? But that's the kind of model I would work with people to see where they are on it. Because a lot of them now feel because they're in a drug treatment community centre that they're an addict. And to be actually told, well, listen, where would you see yourself on this list, right? Because not all people who take drugs or take TEMS are addicts, but they have that mindset now that they're the addict. So when you actually engage them in that and ask them to see where they see themselves, and more importantly, where they want to go, that's really important. Because again, it's opening up their awareness and insight into substance misuse and the trajectory of addiction. Another framework is, and again, this really engages people, is what I call the 4 Ps. How your chem use and behaviours are affecting you on a personal level, a physical level, a psychological level, and a professional level. And again, that really engages people. And when I started working with this, again, back in 2015, this was all on YouTube. I had to go off and explore, investigate, and understand all of this, right? And one of the things I learned was, because up until then, I had very little interaction with the LGBTI community. So this was all new, this was a huge challenge. And, you know, learning that they've been talked down to their whole life, they've been told, you're wrong, this is your fault. I had to come at it from a very, very different angle. So where you engage them and get their opinions, rather than you telling them, well, this is what's happened with you, this is where you're at. And again, that really embraced people and made them feel comfortable. This is from the guy, Matthew Todd, that wrote Straight Jacket. This is from an interview we gave in the Guardian newspaper years ago. And I wish I had that in 2015 when I started looking at all of this. But that, so many people can relate to that, right? And certainly my experience of working with this brilliant cohort that is underlying. It's, you know, Gabor Mate said, the addiction is not the problem, it's the attempt to solve the problem. And that very much buys into that there. Reasons for relapse. I think I'm finished now. Yeah, okay, sorry. Right, I'll just, right, very quickly. For January to July 2023 alone, right, I've had 30 new referrals. 28 male, 1 female, 1 transsexual. The age range 22 to 64, median 35, and mean age 36 and a half. There's a breakdown of where individuals are coming from. 10 from Dublin, 7 rural Ireland, 1 from the UK, 3 from Iberia, and I've got no one so far to share from Africa or the Middle East. Eastern Europe, 1. South America, 7, and it's not just Brazil. Predominantly it is Brazil, but in the last 2 years it's definitely expanded. There's the source of referrals, and from all over. And I have to say, like, of course, services aren't perfect. Everyone's doing their best, but I have to say, the services and individuals involved that I've engaged with over the years have been the most passionate, motivated, and connected services I've ever had the pleasure to work with. I just wish other aspects of addiction services statutory would react to the community the same way as these are all happening at community level, because we really miss that in relation to other drug use. Now, initially, for the first 3 years, the majority of engagers was GHB. The last 5 years, it's TINA. And that's every year, the gap between the primary drug of choice for an individual has widened from G to T. And And there's also the gender breakdown as well. Okay. Yeah. There's some of the issues again, like I said, chem-induced necrosis, a real issue out there today. Homelessness is increasing, and also one of the ones this year and last year that has really come again related to crystal meth is individuals are self-medicating in relation to what they perceive as an ADHD diagnosis or non-diagnosis within them. There's just a breakdown of that. And to finish off, I'm really sorry for going over. It's all about the cultural competency. And to engage with this, with the individuals involved, you need to have the areas of expertise in relation to the chems, in relation to sexuality. Otherwise, that individual is not going to come back. Okay, thank you very much.
Thank you very much, Graham, for absorbing and challenging issue for us all. I think I'm going to have a keynote speaker again addressing this issue just after the break. We're over time, but maybe we have a minute or two just for a question or a comment or two, if anybody wants to make one before the break.
All speakers are staying, aren't they? All speakers are staying there for the break. Oh, yeah.
Okay. Okay. Oh, sorry, there's one there at the back.
Sorry, question for Jessie. Do you have any sense of why people are missing those appointments?
Well, I think the asymptomatic screens, we let patients make their own appointment, and for some reason they decide if they book maybe 2 weeks in advance. We're seeing almost 30% of them appointments, people just not showing up. For the prep, I think you have to come to our service 4 times a year. I think there's just a drop-off rate in that. And with, say, the prep, there's only a certain number of meetings we can see a week, and people have their appointment for next week, so we can't just get people in. So, yeah, it's just, that's probably the main 2 reasons. Yeah, it's not great. If anyone has any solutions, please, please let us know.
Anybody else? Yeah, go ahead, Robin.
Hi, Kate, do you know where we are in the HIV treatment cascade?
We haven't been able to model it properly, Robbie, in the last couple of years, because we haven't had the data from the treatment audit. So the last TTV treatment audit was done in 2017, and there's one planned for this year. So the Sexual Health and Post-Pregnancy Program, we're leading on that. So they're doing it with all of the HIV treatment centres, so that will really help us, because without that, we don't have the numbers in treatment, the numbers as far as expressed. So we're missing that kind of first part. So hopefully we'll have, I would hope that we would have a good treatment cascade early next year, probably, hopefully.
Okay, thank you. Yes, we're here.
So many questions, but it's after this one. Do you think that the factors and criteria to access PrEP is actually a barrier to people who need to try and access PrEP?
I will say I'm not a clinician, and Dr. Gráinne Courtney will be here later today, and maybe she's better suited to, unless my GM or colleagues want to speak. But I think Gráinne Courtney will be here later, and she'll be happy to answer questions like that.
Okay, that's it. I think maybe we'll go and have refreshments outside, and we might aim to be back at 11:30 if that's okay. Just for a short break.
all down. You're all very welcome back. I hope you've all had a chance for some refreshments. I'm Adam Hurley. I'm a member of GHN. You're all very welcome back. We had a lovely, absolutely wonderful first session. I hope you've all warmed up. Just to let you know, we have addressed the issue with the temperature, so that is we'll just take some time for the heat to circulate in the room. Meanwhile, I'm just full of hot air, but that doesn't count. So that's been addressed. Also, some people have some questions about the Wi-Fi. So if you've been unable to connect, the Wi-Fi password is there and the network is there. But if you're unable to connect, it can sometimes be that you've been here previously and it just won't connect naturally. So if you take yourself out, turn the network off, and turn the network back on, and try to log back in, that would usually help. So we're on now to the second session of the day, which is the Noel Walsh Memorial Lecture. And any of you who've been to GHF previously will be very aware of the lecture here. And it was done, Noel, as some of you know, was a HIV positive activist who worked with GHN and GCN, and who was really a tireless activist for the cause, and who sadly passed away in 2008. And also just an addition, I suppose, for this year, we want to remember David McCarthy, a great friend of Noel's and a regular attendant at the Gay Health Forum, and we think of him because he's recently passed away also. So each year we memorialise Noel Walsh's contribution with this commemorative lecture, and this year we're delighted to introduce our keynote speaker, Dr. Maurice Beckington from the University of Manchester. Maurice is a lecturer in health sciences at the University of Manchester, and he's going to speak to us on the culture of chemsex. Maurice, you're very welcome.
Hello, everyone. Thank you ever so much for inviting me today. It's a real pleasure to come talk in Dublin. And I think the way I've kind of structured my talk is I'm very aware that my research is mostly from Manchester in the UK. So I'm going to sort of give a bit of a sort of slightly historical background, wider historical background about chemsex overall, and then a little bit of context about Manchester, and then a little bit about my study. So the study that I've been working on for several years, thanks for reminding me, Chase, earlier, was interviewing basically 20 gay men for around about 2.5 years, like longitudinally. Now these men were recruited kind of via social media, so the sample that I've got is maybe very different to some of the talks where people are talking about people being recruited through sexual health clinics or various other kind of health services. And then I've also been doing a lot of work looking at films and literature and kind of a whole kind of range of cultural phenomena. So before I kind of go into too much detail about Manchester, I want us to think a little bit about the broader history of chemsex. So one of the earliest, or the earliest reference I've ever found to chemsex was in Richard Dyer's book, Now You See It. And he talked about how a journalist, Ambroise Grot, who was living in Berlin, French journalist, wrote about gay men kind of running around at the weekend, eyes wide, and that was in Berlin in 1923. Now, between sort of that very earliest reference in the 1960s, there's very, very few representations, like one or two others that I've ever found. And what we see is kind of after the aftermath of World War II, one of the major things of World War II was there was a sort of industrial ramping up of drugs and drug production. And that Preciado really documents that really wonderfully in Testo Junkie. But what that means is by the time we reach the 1960s, there's a wider proliferation of novel kind of drugs in society. And also we then start seeing sort of waves of gay liberation around the West. And we start seeing gay men representing themselves largely to themselves, certainly early on. So we have novels like Brad Gooch's Golden Age of Promiscuity, which exemplifies that kind of the pervasiveness of the drug culture and gay culture. So much so that in his novels you kind of often can't really tell who is on drugs and who is not, sort of throughout it. It's one of the sort of features of the writing. So this cultural context idealised the sort of drug-fueled pleasures, and then that was vividly kind of represented. The first visual representation I found is Warren Sonberg's film Amphetamine, which was made in 1966. I could talk about this for ages, but I won't. But it basically shows drugs as very tender and sensual. The soundtrack to it is 3 different songs by the Supremes. Only lasts about 10 minutes, but it also shows how it was kind of very casually engaged with kind of other people around, looking, watching, and you switch between different scenes. So that's the kind of representations we have, at least up until about 1970s. Now then we kind of move into a very different era where HIV activism plays a very transformative role in the visibility of gay men. And over time, I'm skipping over this very quickly, but over time obviously the HIV pandemic was addressed quite comprehensively, but what emerged was a much more public attention, public discourse on gay men and their health. So what we find is kind of in 2004, the word chemsex is first documented by Sean Slavin in a brilliant ethnography in Sydney. But we also see around pretty much exactly the same time, people like Peter Staley in New York, who was a very well-known, very famous AIDS activist in ACT UP. And they start shifting the attempts or the strategies of highlighting health issues into relation to chemsex. So we see his poster here, where he uses these kind of very kind of maximum visibility approaches, and you have the phrase, "Buy Crystal, get HIV free." Now, Peter Staley was very clear that he wanted to, quote, demonise and stigmatise chemsex, which is actually very different to the strategies that we found ACT UP, which was all about not demonising and stigmatising at least the object of it. But we actually see that in HIV activism, there was another quite prominent stream of the way that it worked, where there was, certainly in ACT UP Paris, we see examples where people like Guillaume Bostin, who's this guy here, was very much vilified. And ACT UP Paris, when he died, wrote an obituary titled "Forget Dastin." And that was largely because he had a very candid exploration of drug-fueled condom sex in the early 2000s, and they kind of waspishly rejected this legacy. So whilst HIV activism very often has embodied this kind of compassionate and sort of cooperative approach, there is a kind of more complicated narrative that then started to influence chemsex activism. Now, despite these challenges, chemsex largely remained sort of under the public gaze, and this changed very rapidly in the sort of 2010s when 2 straight white men covered it for Vice Media in the film Chemsex, which I'm sure the majority of people have at least heard of here. And this gave a very newfound visibility. So certainly in the British context, you suddenly started seeing a surge in media coverage, journalism coverage, and people talking about it in British Parliament. And that peaked sort of around 2015, roughly to around 2018. So the point I'm trying to make is that chemsex has a very long history. One that's been reshaped over time by things that we may not intuitively think would reshape it, like World War II and the kind of industrialised production of drugs, and then gay men's activism and HIV. And it will still be changing. And so that's kind of why I want to highlight some of the cultural differences or some of the cultural specificities of Manchester, because I can't speak for Dublin, I can't speak for Ireland. I can say some of what things that have existed in wider context, how that has influenced chemsex and responses, and then hopefully that will start creating a useful conversation for us. So just before I move on, I do want to very quickly just talk about the chemsex film. And one of the main features of this film is it recruited gay men from the 5th-16th Street clinic in London. It did also recruit a few gay men via a guy called Liam Cole, who's a pornographer, just Travelline Media. Now, again, this is something I could talk about for at least an hour. The music in the film is fascinating, and it really kind of produces a sense of fear. And what for me that produced was a way of looking at chemsex where you have an audience who then gets this kind of very worried and very singular approach. So when we start to fear something, we can sometimes become very blinkered in the way we approach something. And I think chemsex, the film, very much started that kind of mode of engaging with it, where there's only one way to address it, and that's kind of to think of it in ways of tragedy, or to represent trauma that we then see as tragedy as something that we must learn from, rather than kind of engage it in any other way. Now, so what we end up with by kind of the mid-2010s is that chemsex has largely become thought of as kind of medical, psychological phenomenon that's started to come under political and legal scrutiny as well. And a lot of that, the great author Dion Kagan, who talked about that as being the re-crisis of HIV. So he kind of dredged up and reworked a lot of the imagery and ways of talking about HIV in the public, and applied that to chemsex. And some of that, for me, links really wonderfully to a very famous quote by Michael Foucault, is that it says, "Do not appear if you don't want to disappear." And there's been very concerted efforts, depending on which commentators you look at, to try and sort of eliminate chemsex. I think we're really onto a hiding to nothing for that one, is my thought. It's been around for a very long time in very different cultural contexts. But what we've seen is from the sort of 60s, gay men emerged into public discourse, and then through the HIV pandemic, the practices increasingly come to light, and increasingly maybe stop being fully under their control. So right in the early 1960s, they were sort of representing themselves to themselves with films like Warren Songbird, but then we see that kind of ability to narrate is slightly taken out of the hands of gay male subcultures and moves into kind of cultures of medicine and psychology and all that sort of stuff. So following the film, there was a real surge in kind of ephemera and the talking of sex in kind of public domain or semi-public domain. And my interview with Sam, who was actually an Irish Catholic and lived in Manchester for about 20, 30 years, kind of underscores that pervasive influence of fear. So Sam worked in hospital, but he never disclosed what his actual profession was, and he often felt there was a great shame in kind of what he was doing, and he, to the point that he would not engage with other people when doing chemsex. He wouldn't kind of teach people how to safe injecting practices. He wouldn't even be in the same room. And the interesting thing is that this sort of idea of shame starts to find its way into the way it's represented in kind of gay spaces. So there's a sign, and these signs don't exist anymore, but they certainly didn't a few years ago. This is a sign that was on the lockers in the sauna, gay male sauna in London, Sweatbox. And I can't quite read it there, but the last bit of it says, "Do you really want your friends and family finding out that you died in a gay sauna?" And sort of driving home that sort of message of slightly implicit shame. Now that kind of, they've redone the architecture of that sauna, and to cut a long story short, you can sort of basically always be surveilled by the staff. There's CCTV, the lockers are now kind of wire mesh things, and you're constantly under surveillance. Now the problem with that is that when people kind of constantly feel under surveillance, they act in very different ways, and it becomes much harder for people to access help because they start policing themselves. And when you see that sort of shame is also policing people, then people start not accessing things when they need it, so people don't raise alarms, etc. So the final bit is some of these, I just want to highlight, we have kind of a real sort of proliferation of various flyers and literature that promotes things like, and I quote, significant behaviour change. And very often when you look at these in a bit more detail, it's quite coded messages about how controlling chemsex is important in order to protect one's career and all the kind of middle class respectability that goes with that. And these aren't free, almost all of these aren't free services. This one is also not a free service, in the Tarantino's Trust. It's all about kind of trying to get a mode of consumption that helps people consume the right way. So you're starting to consume health rather than consuming drugs is the sort of thing I'm quite interested in, how we start talking about chemsex in very different ways. So to move on to Manchester, quite quite a few of you probably know it, but I just want to highlight that Manchester is a city that is also quite full of contradictions. So it's certainly over the past 10 years, maybe 20, 30, there's a huge amount of investment come into the city, but we have locals who can't afford housing. Its deindustrialised nature has left it with a lot of very cheap and affordable spaces for gay men and others to socialise. But these are now sort of becoming slightly at risk, maybe, because of the very rapid redevelopment of the city. So we have a city that's got a very vibrant LGBT scene, a commercial LGBT scene, one that kind of has corporate-sponsored pride events. But we also have, at the same time, a very affordable, what could be termed, just to separate them, a kind of queer rave scene or queer scene. Now, this is quite unlike cities where chemsex has been reported as being really problematic, and so there's a reason why I'm highlighting it. So if you look at reports in cities like New York, in Sydney and London, a lot of the talk about, and Jamie Hakeem talked about this really well, of why chemsex has become so problematic is because it's largely replaced the gay scene, but I think sometimes that's a bit of a kind of a projection onto chemsex. It's not necessarily chemsex is destroying the scene, it's like the scene has been destroyed by other things and gay men still want to socialise, and it's actually quite an affordable way to socialise in those cities. Manchester isn't really like that. There's still, you can't make those socio-economic arguments for Manchester. You can quite easily go out and have a night out for about £10. So maybe €8. And I'm not kidding. That is genuine. That £5 for a ticket, £5 for your drugs, and you are sorted. So it's whereas, as I say, if you look at London, you absolutely could not do that. So we're in very different situations. I think it's very important to highlight that, and I'll come on to that a little bit later in a second or two. Also, the population of the city are very different. So just to compare Manchester and London, you're talking sort of 3 versus 9 million people. Annual visitors, you're talking 1 versus 16 million people. And one of the reasons why that's important is my participants would reflect on how the London kind of chemsex culture leads to a much more disposable transient population, whereas it became quite difficult, or not difficult to become, but it's just Manchester chemsex scene, you would tend to see people repeatedly, and there was also that kind of overlap with the queer rave culture. So some of the people in my sample who were speaking, they would have friends outside, or at least alongside the chemsex scene, who they would then be able to talk about it in a slightly different setting, in a sort of pub on a Sunday afternoon, and sort of laugh about it to some extent. So there was a very different way, whereas the participants who had experience with London and Manchester would say, well, very often you just don't see these people at all outside it. So those are the reasons why I'm kind of highlighting some of these cultural differences. So I want to just move on quickly to talk about some of the professional support that wasn't there. So the clinic, and this is, I think I should highlight, this is from this data is from about 4 or 5 years ago in some cases. It's changed a little bit, I'll come on to that in a bit. But one participant, John, said his care was very medical. It never felt that my head and my spirit were ever considered anything. It was just very much, here's your bloods. So John is kind of, when he's saying here's your bloods, he's probably HIV positive, and he was attending clinic regularly, but never really got any intervention. Now, it's fair to say that John wasn't engaging in chemsex in a way that was maybe severely harmful, but it was definitely enough for his friends to step up to him after a few months and say, look, we need to address this with you. And they did, and he did, and he's fine. But he was attending the clinic for about a year, he said, when he was definitely not okay, and he got no help or support. So the next person, I'm not sure his name on this, but the next person, Mark, is a kind of maybe more serious example of lack of support. So Mark was equally diligent with his HIV medication and attended very often. But he said, I was turning up appointments when I wasn't sober, it was obvious. And he said, the only time they really helped me was when I started shaking through an appointment because of G withdrawal. I was more than willing to accept help, I just wasn't sure how to go about getting it. Now, Mark himself admits in the interviews that his pleas for help were often indirect, but it was only when he was really obviously withdrawing that he got very primarily medical help and was admitted to a medical ward for withdrawal. He didn't receive, at this point, any psychological or peer support, just as he found. He subsequently relapsed and was admitted again, this time to a mental health ward, where he formed some really important connections for him and really important support connections. Now, in the interviews, he implored for staff, and he means sexual health staff primarily, to start digging into it, chemsex. How often and when it is they're doing it. Someone might feel it's a bit personal, but if I was asked those questions, I wouldn't mind. I would be quite happy. And actually, Graham's 4Ps sounded very kind of useful for that kind of starting those conversations. Now, Manchester, as I said, has made some progress on professional chemsex support services, but I think if we're not getting some of those sort of frontline staff asking those questions, we're not going to get referrals into those services. There's also huge problems in Manchester with people even being able to access the service. So in January 2022, only about 20% of requests for appointments, they run a next day appointment system, only about 20% of those resulted in someone actually getting an appointment. Now, things like HIV treatment go a different route, but some of that is being picked up by postal testing kits, but there's absolutely nothing in postal testing kits about anything that isn't an STI. So there's definitely kind of problem going on there about the movement through services. So one of the things that I want to pick up on is peer support. So in Manchester there was a peer support chemsex group, and one of the participants attended this, and he says, I was very impressed. I explained that I did have some experience with chemsex. He found them very welcoming, non-judgmental, what a kind of group support should be, and he actually found the ability to laugh about it really helpful, which actually was a feature of some of the interviews as well. Like, laughter and humour is a really important way of releasing that kind of stress or emotional energy. You know, Freud talks about the fact that we use humour to talk about things that we find uncomfortable. So that kind of, it's really important to have those spaces. And he said, I came away thinking that they're helping each other, basically. So there are one or two kind of professionally organised groups, but actually most of the support that people received was peer support. So John, for example, he was talking in response to reports that gay men often don't help each other and kind of kick each other out on the streets if they've got G overdoses. He was very clear that it would be wrong of me to turf somebody out. It just came very natural to me, and he kind of made sure he sat with him, made sure he was breathing for several hours. There's also kind of emotional and practical support that extended beyond gay peers to encompass female and straight male friends. So Robert was one of my oldest participants. The interviews with him were wonderfully hilarious at times. But he said he had a friend of about 30 years who didn't really know that he goes out and does drugs to the extent that he did, but they have this sort of little monitoring system where if he hadn't been on Facebook, she would call him. If he didn't pick up, she went round and checked on him. Similar examples kind of existed with another participant, Tyler, whose straight male friends provided really important networks of support similar to Robert's. Finally, actually, and I don't mean to be blowing my own trumpet, but it shows the simplicity of the engagement that was needed sometimes. So the interviews also formed a form of peer support. And James summarised, several of the participants talked about this, and James summarised it really well. He said, I thought about things I wouldn't have thought about without them posed as a question. I wouldn't have thought to ask them about myself. You want to understand, and over time, we've developed a friendship. That's allowed me to open up more. So those kind of peer-to-peer conversations were really important, really valuable, but the problem is in most cases, people found that they didn't have access to that. And also in quite a lot of cases, peer support was also what I call quite fragile. So one participant, maybe I've got the wrong name on the slide, that's okay. So one participant, Barry, had very complex, very difficult relationship with his sexuality. His dad had been really abusive towards him because of being gay. And for him, he found that a very close female friend was able to offer him support. And he lived with her rent-free for a while, and he said, I can't be left on my own, I know I'm fine, but she can't worry that I'm going to be missing. But the problem was that after a while, this female friend, kind of completely independently, nothing to do with Barry, found that her mental health deteriorated. And he said after that, there's not really been anyone else. The problem was, during this time, he tried to seek assistance from his GP for antidepressants and mood stabilizers, but was denied it because he was still actively taking drugs. And a professional, like a referral for any sort of professional support only happened after a suicide attempt. Thankfully, after that, things substantially improved. But the point I'm trying to make is that peer support and friendships are really important, really valuable, but they can be quite precarious, and they can't sort of fully substitute for timely professional assistance, which can unfortunately be quite lacking or difficult to access. So, on to my concluding slide. So in exploring the landscape of chemsex and its corresponding sort of support networks within the context of Manchester, there's kind of several overarching things that I want to highlight. So there's this interplay between professional and peer support, which shows there's a real kind of complex, multifaceted needs of individuals engaging in chemsex. And actually, we can talk about chemsex causing mild, moderate, severe problems. In all of the cases where I saw severe problems, actually because it got to being severe because people hadn't been given the help they needed early on, even though people were quite clear that they were in touch with services. So we have to think about the severe effects of chemsex, not necessarily just laying at the feet of chemsex, it may lay at our feet as well. And a lot of this also emerges because of kind of wider socioeconomic forces. And yes, sometimes it's because it's engaged alongside the gay scene, but again, kind of saying that chemsex is destroying the gay scene is maybe a slightly problematic way of phrasing it. So in my sample at least, people tended, almost always, one or two exceptions, to engage in chemsex at least in the first instance because it was pleasurable. There were one or two cases of very clear reasons why it was kind of to do with psychological trauma, but that wasn't the majority by any means at all. Professional support predominantly was situated in sexual health clinics, but this was difficult to kind of navigate their way to the psychological support because there was such a prefacing and predicating of kind of biological, biomedical factors and kind of focus on STIs. Peer support is incredibly valuable, but also quite fragile. In some settings, in a narrow range of settings, it occurred kind of via subcultural groups like clubbing. But in most other cases, it didn't kind of open naturally. But it wasn't actually terribly difficult, I would argue, to get people to talk about this in a way. So people were very open about it in interviews. People were very glad to talk about it. And I think one of the things that I want to highlight is that the people who did have friends to talk to and had friends who were able to support them, you can see a sort of, it's qualitative research, but you can sort of see a slight relationship between people who have that support around their network and less severe kind of problems with chemsex. And I would suggest kind of one of the red flags we need to think about is where there's sort of mild or moderate problems, but there's an absence of any kind of obvious support network for the person, and things can slide maybe quite quickly. And yeah, so yes, I think we can make the arguments for better kind of psychological therapies in services. We have to make sure that people know they exist and that we're asking the right questions kind of at the front line for that. We can also kind of make arguments around peer support, but we have to start understanding around how those peer connections are made, how they're formed, and what chemsex looks like in a specific kind of local context, because the way you'd be looking at supporting people in London is a very different cultural context to the way it would be in Manchester, because there may be a whole different kind of subcultural dynamics going on where people will have different friendship networks or the ability to form friendship networks in very different ways. And so as I started at the start of my talk, no, very little about Dublin, been here about 24 hours. But I think those are some things that I want to highlight, that we need to be very careful about a kind of this sort of medicalised approach which sort of reaches across the globe, and we always know what an STI is, we always know what HIV is, or we think we do. But actually kind of local culture, local effects shape what chemsex is and shape how it shapes people's lives. So that is me done. I think we've got about 10 minutes of questions. So.
A little bit of time in the slot left, so another 5 minutes actually left in the slot. So if we have any questions, Mark's will come back in a later session today. But if we have any questions right now on a particular presentation there, then take questions from the floor. I'm really interested to hear about the £10 night out.
Come to Manchester.
Whatever happens, I think there's Steve.
Does it work? Yeah, it does. Mars, thank you for that. I'm just wondering, obviously it's a qualitative piece of work with your 20 participants. Is there any kind of analysis within the scene in Manchester around the different groups of gay and bi men who are engaging? So I'm thinking particularly when we're hearing earlier from Graham around, for us in Ireland, we've a large Brazilian and Latin American population, and some issues tend to happen within subpopulations of the gay male community. I'm just wondering if that's come up in your work or if there's any analysis from others in Manchester.
Yeah, that's a really good question. I think it's fair to say that like the group of people I was working with are maybe not part of some of the most vulnerable subpopulations. So I'm hopefully going to be starting some work soon looking specifically at sex workers and chemsex. And we know in Manchester, male sex workers, we know in Manchester around about 30% of that population are migrants. I literally have just been looking at this data 2 or 3 days ago, so I can't break it down a lot more for you from that point of view. I mean, Manchester is a very kind of cosmopolitan city, full stop. I think one of the things you find is that the commercial gay scene is incredibly white. You walk down Canal, I mean, it's in the city centre, you walk down Canal Street and it is not representative of what Manchester looks like, or even feels like really, or sounds like. I think, I don't know if there's kind of robust data on that. I've not come across it, if I'm honest with you. It may be being collected in the local sexual health service, but even that's going to be very biased because you're not necessarily getting some of those people into that service. So yeah, I'm afraid pass. There may be 1 or 2 people that are collecting that data, but I'm not sure.
Thanks, John. Any questions? Nothing I see right now. Oh, there we go. Thanks so much. Thanks so much, Mark. So ahead of the next session, then I just asked the next members of the next panel to make their way to the stage. So that's David Comer, Ciara Mulcahy-Lenihan, Dr. Mark Doyle, Sheena O'Reilly, Laura Tully, and John Morris. And similarly to how Bill handled it last time, you've now heard my alarm, which is slightly different, but I'm sure you'll all stick with the beat of the time. I hope we've all warmed up a little bit. We can't set a bonfire in the room, but we would advise we do that. Perfect. Okay, and first up then we have David Comer from the University of Galway. So David is a HRB Sphere PhD student based at the University of Galway, where he obtained a BA in psychology and MSc in health psychology. Very welcome.
Hi everyone. I'm going to be talking about the preliminary needs of gay, bisexual, and intersexual men in Ireland in response to the Mpox virus. And this is work I did with John Gilmore and Chris Moon, and I had the support of Empower and HIV Ireland. just see this research also has a quantitative component, but I'm not going to be reporting on that. So as most of you probably know, middle of last year, the World Health Organization declared a public health emergency of national concern in response to an outbreak of mpox. Europe was identified as being at high risk for mpox, and that included Ireland. Across the world, that outbreak primarily affected gay, bisexual, and other sexual men, and as a consequence, they are identified as being at particular risk for a negative psychosocial impact of that. So that included reduced access to healthcare, so unmet health needs, and potential stigma, and judgments as a result of associations between mpox and their sexual identity, limitations on their employment, potential discrimination, and social isolation, both as a consequence of the preventative behaviours that people enacted to protect themselves from mpox, and potentially the isolation period that people would have to go through if they did contract mpox. So we had 3 research questions for this study. The first one was around the thoughts and concerns of GBMSM in Ireland on the prevention experience and aftermath of mpox. The second one was around the impact of mpox on their daily lives. The third was on the community preferences for support and information provision on mpox. We had an online survey, and we had both closed and open-ended questions, but it was primarily open-ended. And we had proposed a convenient sampling done via social media, so that was mostly through Twitter and Instagram, and shared through research profiles of people working on it and through our particular. We also paid advertising on Grindr and Gay Community News. We also had posters in venues around Ireland with QR codes for people to engage with research. We were just looking to list the experiences of any men living in Ireland aged over 18 who had sex with other men. We collected the data from December last year to the middle of January this year, and we ended up with 163 participants aged 18 to 68. They were predominantly Irish, gay, living in Dublin, most of them had a degree. They tend to be of quite high income, and the overwhelming majority had no mpox diagnosis, so only 5 of the sample actually were diagnosed. For analysis, we took a critical grievous orientation to understand experiences of mpox as an interaction between individuals and their context, and we used Brown and Clark's 6-step RTA to analyse that data and visual mapping of the themes that we generated to the research process there. So we have 4 themes in total. The first one focused on perceptions of the response to mpox, and this was highlighting divergences in urgency, priority, and care between different groups. And it is important to highlight that these themes and the results are reflective of the views of the participants. They don't necessarily reflect the views of the research team or of the funders. So people seem to think that the government in Ireland responded quite slowly and without urgency to this. It wasn't, for some people it was seen as government incompetence, for some people it was seen as a consequence of just that's the way it is. Maybe everyone was struggling with vaccines, but quite a large subgroup of the sample viewed this as being institutional homophobia, so they thought that they were particularly being mistreated because mpox was affecting men of sex and men. The government response here was contrasted with the response internationally, particularly in New York and in France. People felt that they were getting access to vaccines faster, and that they were being provided with resources more readily than we were in Ireland. And people seemed to think that we were kind of being left behind internationally in this response. Government response in Ireland was also contrasted with that of community groups who came across very well throughout this report. And people seemed to think that the community groups were kind of picking up the slack for what the government left behind. So participants said local groups and the LGBT community are doing Trojan work. This should be a government-led response to what's supposed to be a public health emergency. Our second theme was around the mpox outbreak as a sign of othering for many of sex and men. People felt that this was very often portrayed as a gay disease, and many people took issue with this. So one person said they thought it was portrayed in Ireland as a gay plague. People were quite fearful of the stigma and the consequences of that. People were also fearful that maybe other communities who could potentially be affected by mpox wouldn't know that they could be affected because of the way public health messaging came through. There was a lot of different layers of stigma that people were worried about this. So the association between their identity and mpox caused a lot of trouble for people. People were worried about the perceived visibility of symptoms of mpox, so having lesions. People were judgments that would be made about their sexual behaviour if they were to contract Mpox. And there was this real feeling that people's privacy would be exposed because of the nature of the visibility of Mpox, and also the factors that would contribute to their prevention methods. So if they were attending clinics for vaccination or something like that, that people would know that they were gay, would know that they were potentially at risk for Mpox because of the criteria that were being put out. The third theme is also around othering, but this occurred within communities of heterosexual men. And this primarily occurred through Mpox prevention practices. So I think the criteria for vaccination and some other factors really contributed to kind of a lot of judgment within the community. So we have participants calling for increased public health restrictions, shutting down saunas, and this general idea that some members of the community were being more responsible than others, or were maybe being more careful than others, while people were being careless and the rest of the community had to pick up that slack. So we have people engaging in serosorting or something similar to serosorting for HIV, where they were trying to screen their sexual partners based on what might be just arbitrary judgments of how well they knew them. And then particularly with vaccination, we had this idea that because this was kind of a finite resource and people were competing for it, that some people thought that they had reduced their risk intentionally, but as a consequence weren't eligible for vaccination, and felt quite hard done by when other people didn't have to deal with that and could go and get vaccinated. We also had a lot of kind of shaming sexual behaviour, so one participant say they must identify as a slut to get the vaccine. And I think this primarily came through the criteria for accessing the vaccines because of the kind of risk stratification that was required to distribute the vaccine. It caused a lot of maybe perhaps jealousy or competition within the community. And the final thing is around fear of Mpox and how this was shaped by other culturally significant pandemics. So people were quite fearful of the infection. They saw quite painful depictions of it online and images of the lesions. One participant said that they heard it described as being an excruciatingly painful experience. It was generally this idea that contracting Mpox was quite a significant burden if you were to contract it. So people being really worried about potentially having to take time off work and the financial burden that would have on them. And this was realised in one participant who actually contracted Mpox, who said they didn't have anyone to talk to about it except one family member who called them every day during the isolation. It was a lonely and difficult period. Because of people's fear, they had kind of hypervigilance and potential symptoms. So that participant said that they were looking at people's bodies and could relapse during sex. We also have people attending doctors for mild rashes because they were really worried about the illness. And then finally, all of this fear kind of came through a lens of HIV in some cases, where people thought that this was something like history repeating itself. They were aware of the impact that HIV and AIDS had on the community, and that participants saying that the Irish gay community is already so fragile and they don't want it to be another AIDS crisis is between 18 and 20, so it's likely they don't have any first-hand experience with the AIDS crisis, and yet this was really significantly impacting their emotional response to the outbreak. So we came up with 13 recommendations. They are split between our 3 research questions. I don't have enough time to talk through all of them, but the research question recommendations regarding investment in sexual health and public health infrastructure in response to situations like the Mpox outbreak and provide support to the community sector. So as has been mentioned previously, the Irish sexual health sector is kind of oversubscribed and under-resourced, and that came through in people's responses to this. One thing that came up in particular was people in rural areas really felt hard done by, and it was one of the few areas that community groups also were criticised in their responses. Everyone seemed to feel like it was quite an urban focus. There was people living in rural areas who had a 6-hour round trip to access vaccination, and they felt quite left behind, even in the grand scheme of the community generally feeling hard done by through this. In 5 recommendations for our second research question, one of those would be providing greater supports for self-isolation, including financial supports. As I said, we only have 5 participants who actually had Mpox, so the data on that is limited. But people did voice concerns about potentially having to isolate, and that caused a huge amount of anxiety for people. I think some of the ideas of institutional homophobia also came through here, because we saw people who were diagnosed with COVID in the wider population and were getting financial support, while heterosexual men who were affected by Mpox didn't have that financial support. 4 recommendations from my research question. One of those being to continue the partnership between community relations and statutory public health enhance visibility of the public health agencies. I think a lot of the community maybe didn't realise that the decision to let community organisations lead on this was an intentional one, and as a consequence that could potentially affect how people engage with Irish health services when they feel that they haven't acted in their favour. But despite that, the Irish response was generally really good, and our cases are low. So I guess letting community organisations lead the charge is the right thing to do, but we need to make sure that people know that the government is also engaging with these organisations and is on board. Sorry, I'll rush through the rest of it. So this is the first piece of research on community experiences of MPOX in Ireland, with a large sample and mixed methods design. We also had a research advisor group throughout the research. Unfortunately, because it was cross-sectional, we couldn't probe beyond just the short responses that people gave us in the survey. Responses related to quite a small snapshot in time, and we had quite a biased sample, as I mentioned at the beginning. Future research showed that with experiences of MPOX and motivations to vaccination, because obviously the situation has changed quite significantly now. We also need more research on the lived experiences of those who actually had MPOX, and then broader investigations into the health and wellbeing needs of GBMSM. And while it's no longer considered a public health emergency, the outbreak had a very significant impact on the community, and the consequences of that impact are still unclear, so it's something that needs to be monitored going forward. Thank you for listening.
That was very interesting, and I think that at that point that was made earlier, the response to the survey, so many people, particularly in rural areas, felt very kind of left behind or left out. I know that's something that service providers and organisations such as SLAS and GHM are always very kind of conscious of how we bridge that gap for services, urban and rural. So I think that was a very well made point. Thank you on that. Next up then we have Ciara Mulcahy Linehan. She has been working she is a community health worker with Link since 2018, leading and assisting in development of sexual health research and resources as a core element of her work. So, Ciara, you're very welcome.
Thanks for that, Adam. Yeah, I've been working with Link for the last 5 years, and as a community health worker, sexual health research and resources has been really a core part of my work because, as I discovered very quickly, for lesbian, bi, queer and trans women, they're almost non-existent. So what I'm going to talk to you about today is how we engage the community, how we got community buy-in for this study, and kind of where it's going now as well, what the implementation process is like. So the study was to examine the participation and experiences of LGBTI plus people in cervical screening in Ireland. It took about 2 months to land on that title and to agree on it with our steering group, but essentially what it came down to is who has a cervix and are those people engaging in screening. So just to give you a little bit of a background, Link, if you're not familiar with us, we're based in Cork, and these are kind of the core elements of what we do and the services that we provide. So obviously health is my area, it's everything sexual, social, emotional, physical, mental, all aspects of health, and as anybody who works in any kind of health service knows, they all feed into one another. But some of the other areas really helped with this research. So the social support aspect and education and training, they kind of became the family of supports that progressed the research, got a good buy-in from the community, and then also because of our education and training background, we were able to implement some of the findings and some of the outcomes or barriers that we needed to address. Just to say around health, particularly around sexual health, I'm taking this moment to shamelessly plug an event that we have coming in September. It's a Queer Women Sexual Health and Wellbeing Conference. It's going to take place in MTU Cork School of Music on the 16th and 17th of September, and so far we have not been able to find any evidence of something like this happening anywhere in Europe yet that specifically looks at sexual health and wellbeing for LGBTQ women. So do come to that and do support it. It should be very interesting. And it's the fun stuff too. We're going to look at kink, pleasure, shame, fantasy, everything that kind of contributes to sexual health and well-being. So, the service screening report. So it came really, we have an annual health week every February in Link, and we invited Lynn Swinburne from the National University to come and speak to a group of our community members about chronic diseases and about screening. And throughout that conversation, and I think this highlights why it's really important to have community involvement, The mistrust in healthcare practitioners and health services amongst queer women was really, really evident. So that in 2019 started as the beginning of why we knew we needed to do this piece of research. So from there, myself and I put a proposal together and we got funding for it. In terms of what did we do and why, I'm not doing it on there. So after the initial meeting with that group, we set up a steering group, which was made up of members of the National Screening Service, and we had a practice nurse was one of our main members, but we also had a representative from the community, so that it wasn't just the NGO representing the community voice. We also had I think it's PPN it's called, so she was involved in every step of the process as well. And we also engaged lesbian researcher, lesbian identified researcher as well, so that language was always accurate and always appropriate. Our online survey, we had 418 people take part in the survey. I think it's very to know that this happened in 2020, the survey went online in 2020. So where we might be able to usually get, our football involved in our surveys and in pieces of research, we didn't have that. It was all online. So we found actually one of our findings that was that it was quite a high educational attainment amongst our responses. It's quite possible that those who are more likely to engage online are of that cohort, and so we feel like the results might be slightly skewed, that had we had that usual community connection in person, we could offer people to fill in surveys in the centre and also possibly help people to do them. So again, at a different time, we might have had slightly different findings. And then we had 3 focus groups, Dublin, Cork and Galway. We ran 2 of them and then 10 ran the 3rd one. They were all online as well, and we used breakout rooms to kind of do smaller sort of, qualitative pieces of work, and then come back to the wider group and share what people had been discussing. And then there was 4 stakeholder interviews, so that was practice nurses and other LGBTI+ organisations. So then some of the results and the barriers I think was probably won't be surprising to many of you. So we had heteronormative assumptions by healthcare practitioners. So any lesbian, bisexual, queer, trans woman who goes to their doctor knows that you have to often argue with your doctor or explain to them or educate them. The very common question is, are you sexually active? Yes, I am. Could you be pregnant? No, then you're not sexually active. So this was something that a lot of our respondents had experienced, and it just created that relationship of mistrust with their healthcare practitioners. There was fear of the test procedure, heterosexual questions, particularly around what's your boyfriend's name, or that kind of stuff, using boyfriend, husband, presuming that you're when you're sexually active, that you're sexual relations, things like that. So negative came across really from every age. So there was a lot of kind of built into the screening service. That's where it really helped conduit for that. And through our social groups, we already had a community. So people to take part. It was their relationships with us, I think, that really got that engagement. There was a disparity between heterosexual population and women engaging with screening. So that's some of the outcomes, and this is just one of those resources that we created. And again, this is for kind of top 8 practice nurses and GPs can just print and leave on their desk, and it helps with what kind of questions you ask, how to make it neutral, and just ways to make sure that your LGBT+ is comfortable with you. We're also in the process of designing a gender-neutral script by video that to practice nurses and GPs that they can watch. Because what I found is, and I'll mention this in a second, we delivered to lots of screeners, and each fear was just that people would get it wrong. An identity that they hadn't heard before, and it's really just training people on how to ask questions in a job. What questions do you need to ask, and why are you asking them? So staff training to date, I have personally trained over 250 nurses. So that was online training, recorded, so and those spaces really just receive training on terminology or questions. But really findings from this report was looking at how people are captured, how your letters out and who goes out to, and there was an element of looking for female names in terms of where database comes from, and that's really problematic because, as everyone in the room knows, having a cervix does not require a female name. So there's a lot of elements to the implementation process that are going to take a really, really long time, like changing how their data is captured. So you might have heard of the equity framework as well. So a lot of our findings are being migrated to the equity framework, and that's looking at all screening practices and how they can be inclusive. So LGBTI+ people come under that as well. And then I just have over on the side that we were published in a health bulletin, so that it's being really, the information findings are being, well shared. And then just in terms of the experiences of LGBTI+ people, I'll share my own experience from my 5-year HPV screening, and I found that my practice nurse, the experience was in serious contrast to my first HPV screening. Her questions were completely gender neutral. She was very accepting. I felt comfortable within the first 2 minutes to come out to her. And then I complimented her on how she had approached it and how comfortable I had felt. And she responded with, well, there's actually a really interesting report that we got. So it was great to see how that was and how that's coming back. And then following on from that, we have developed a really strong partnership with the National Screening Service. Myself and Lynn meet probably once a month to check in. And they also have a section now, a dedicated section to their website for LGBTI+ people. And they also have a dedicated contact. And often that dedicated contact will end in me or another service, but it's really good to know that there is somewhere people are sent. But in general, I think that they're making the effort and invest on the back of this report. So you can just see how vital it is to have that kind of community engagement and community trust. And I think we're leaving questions to the end. So thank you very much for your time.
Perfectly on time, by the way. I really appreciate that. And then again, I will help you with your shameless plug. So your conference is Cork School Music the 16th and 17th of September. Yes. There we go.
Sorry, it's absolutely free. So.
And it's absolutely free.
And you get fed, so come along.
And you get fed. What more could you want? No, thanks for that, Cara. That was a really enlightening presentation. Next up, we have Dr. Mark Doyle from Empower. So he's a community outreach worker with the program at HIV Ireland and a researcher at the South East Technical University of Waterford. So, Mark, you're very welcome. The floor is yours.
So I'm going to talk to you a bit today about Grindr and its uses in an outreach setting. I know Adam introduced it already, so I'll go through this quite quickly again. So from left to right, Adam, we have Andrew, Diego, myself, and David. And David then has been an honorary member for the last 6 months or so. So we all kind of provide the suite of outreach interventions. We have our here that we kind of, I suppose, slightly specialise in ourselves. So Andrew is developing materials around chemsex. Diego would work a lot with sex workers. I particularly, I guess, work with rural men or maybe men who are not out. And Davey does a bit of everything and looks after our rapid home testing service as well. So just a little bit about what we do. I think Adam spoke a little bit to this already as well. But Empower itself is a suite of peer-driven community-level interventions aiming to achieve a reduction in the acquisition of HIV and STIs and an overall improvement of sexual health among GP and MSM. We deliver that suite of services in a sex-positive and judgment-free way, and we deliver then harm reduction resources as well. So we strive to be inclusive of the diverse identities within the community of GPMSM and to incorporate the experience of both HIV positive and HIV negative men as well. And it's developed within a broader sexual health and wellbeing framework, and also just skip on a bit there, but to look at the mental, physical, and social health as well. So we've taken a holistic approach to our work as well. So in terms of community outreach, it's a bit of a busy slide there, so I won't go through all that, but I think the key part there is maybe the second 2 points. So to look at maybe hard to reach, disengaged, or invisible populations. So how do we get relevant health information and results to populations? And that's where I think Grindr in particular can come in as a useful tool. And it's also being helpful. Like social media and over and having to say Grindr and having Snapchat and things like that. So how gay and bisexual men are very when it comes to these technologies. And so throughout 2022, we had just over 2,500 GPMSM connecting with Empower using different online platforms. And 1,353 of those happened on Grindr, so 53% of all the outreach activity. So it is a large part of our outreach activity. So the type information on HIV and STI testing, and often somebody might be experiencing a symptom, or they might have a concern about a sexual risk event. A question that, because my focus, I guess, is often more on men in maybe rural areas or maybe men who are less connected to the idea of the gay community, I get a lot of questions around sexual risk. And what I would find from that there's a tendency to maybe as being a manifestation of stigma, perhaps. So people, if they were to test positive for something, how they maybe explain that to a partner, to a wife, to a family, and so on, who they're not really out to. So for Grindr itself, I'm sure most people in the room are familiar with Grindr. It's a very quick explainer of Grindr though. So what it basically does is it can create a virtual space across any kind of physical place. So if you're using Grindr, you are in the top left corner. You could be considered, say, the anchor user, so the rest of the grid moves around you. So it's a constantly kind of dynamic space. So it's forever kind of changing. You're unlikely to see the exact same grid twice. So you see about the 100 nearest users. So it's the most kind of popular app of its type in the world. So 11 million users. Harder to get more recent figures for Ireland, but in 2018 there was 30,000 monthly active users in Ireland. And the intensity of that use will vary greatly. My own PhD project last year looked at, say, self-presentation and interactions on Grindr. So anything from somebody going on for a cursory glance once a day for a minute or two to people spending 6 hours plus a day on Grindr. And the reason why Grindr in particular is useful for outreach, it's very much a mainstream application. People know about it, it's covered in the media. You don't have to be particularly connected to, say, the gay community or anything to know about Grindr or to get on Grindr. It's got a low threshold for access. Some apps you need to provide additional details. You need to verify yourself. Grindr, until very recently anyway, all you needed was an email address, and that can be an email address that you could just create and dispose of. So it allows a lot of the many users completely separated from their lives otherwise, and to kind of remove that kind of trace. So we probably we're thinking about Grindr profiles. We're also thinking about the people behind these profiles. So what you might see a lot of on Grindr would be these kind of black and grey kind of silhouettes, kind of blank profiles, like faceless profiles, I'm going to call it, or kind of torso pictures as well. So a combination of those we think would be the vast majority of the profile pictures you probably see in Ireland. If you look at the country as a whole, it will vary a lot, depending on your offline culture, if you want to call it that. So in Dublin City, it's going to look very different to say Cork in Offaly, for example. So it's interesting. These are a lot of the men who I would work with on a regular basis. This would be kind of representative of them, of the profiling that they have. So we kind of read a little bit into that. We might make some kind of common assumptions, or they're not out, or they're married, or they have another partner who doesn't know the right driver. It could be also somebody who is out and is maybe exploring a different aspect of their sexuality as well, maybe more kink-based side of their sexuality as well. But we have different, we can maybe make different readings into that. And if we look at, say, we're mostly talking then about maybe harder to reach populations. I'm sorry, all populations with Grindr, but it has particular benefit for harder to reach populations, particularly not out GBMSM. So based on some of the research I did last year, a quarter or 24% of Grindr users in Ireland would say that they're not out, and that's likely an underestimate as well. So we have an underestimated population who we don't know a whole lot about because they're very, by definition, difficult to recruit for research studies. If you are not out, they're maybe unlikely to apply to a request to take part in an interview or to even fill in a survey as well. So Grindr can also be useful then for researchers as a sampling strategy and as a data source as well. And we can talk then maybe when it comes to not out GBMSM as well, maybe sort of layered stigmatization. So worried about being stigmatized by the broader population, but also maybe within the community as well. Because they don't maybe fit the ideal of maybe the kind of authentic kind of metropolitan queer subject as well. When it comes to rural GBMSM, we have different maybe cultural expectations. There's an idea of localism, particularly in Ireland, and everybody knows everybody, so they can be quite cautious. And there's also a degree of conservatism as well. I think maybe in the last couple of years. We've had maybe a linear, we've kind of assumed maybe a linear amount of progress with things like the marriage referendum and so on, but that doesn't apply equally across the country as well, so we need to be very cognizant of that. And another hard-to-reach population may be GBMSM in direct provision as well. And there's other categories, of course, of hard-to-reach population, but there's some that we look at. So some of the benefits of Grindr as an outreach tool. So we can utilize those technological affordances of Grindr for embedded, context-specific, and individualized health promotion. So by technological affordances, it's the ability to move around, to use GPS services to locate ourselves in different areas across Leinster. So to go to those different communities for monitoring and evaluation. And so actually being able to look back on the work that we've done over the last year, and things like what people's needs be and how we maybe responded to them. For outbreak responses as well, so being able to put links to information on Grindr profiles, and also then that kind of hybrid side of that, where we, I think Adam showed the pictures earlier, where we're out in bars as well, so we can kind of combine the online and offline in that sense, for signposting and referral. So for things like rapid testing, home testing, SH24, to refer towards clinics, counselling services and so on. It's low cost, it's mobile, and it's dynamic as well. And also, in terms of particularly for maybe GBMSM who are not out, it can help maybe preserve their privacy and anonymity, so they can come to me with a question if I'm doing online outreach, and that can kind of, if they want, they get the information they have. If they want, they can block me. They can move on. They can get the information they have and leave it. But at least they've had an opportunity to do that. Some of the challenges we could maybe say is that it differs from face-to-face communication. So we use some of those like visual cues, tone of voice, facial expressions that can be a little bit more difficult when we're interacting with somebody. This is an advantage and a disadvantage depending on your outlook. So the idea of data, trace, trust, and authenticity. So the idea, it's an advantage, I guess, for us in the sense that we can acquire this data, we can learn more about the service that we're providing. But for the service user, as we all know when we're online, we always need to trace. Everything we do online needs to trace. And if you are, particularly if you're not out, that's going to maybe be an impediment as well. There's also the commercial imperatives of Grindr, so they have been good in working with us, especially Grindr for equality. But you don't know when the technological affordances the app might change, terms and conditions of use might change, so you're subject to that as well. In terms of geolocation and proximity and distance, that's the ability to move around, so you can go to places that are very isolated and don't have services. Blocking, again, it could be an advantage or disadvantage. It's an advantage, I guess, for the person who gets the information they have and then wants to kind of move on. And then maybe unsolicited image as well. Do get the occasional interesting picture. So just quickly run through these items. Oh, wait,
Oh, 30 seconds. So case study A, so would be a male, mid-40s, not out, Midlands area, so very few community resources. This will often happen as well, so often Grindr is like the first protocol, and then after chatting on Grindr for a little while, go, yeah, if you want, we also have WhatsApp numbers, we do phone outreach, so then there might be some WhatsApp messages, and then that can move to a phone conversation as well. So depending on somebody's comfortable, you kind of meet them where they're at. Particularly in rural Ireland as well, so we have, say, really different norms around, say, masculinity things, around masculinity as well. So this was just a quote that I think was rather original. So as a masculine closet gay guy, I think people over 30 in particular are still not comfortable with gay people, even though they are more PC about when gay people are around. When no gay people are around, or when they think there are no gay people around, the mask will slip and their true feelings come out. It's quite a sad quote. I intend to live in the closet for the rest of my life. It's sad, but I suppose it is what it is, and I made my peace with it years ago. That would have been a sentiment that would have come up quite often throughout the PhD research that I did last year. This kind of picture interacts as needed, often just for a general chat. He'll ask me, like, Eurovision songs, like, what do you think of that song, chat. So you can kind of have that kind of more laid back kind of approach as well. And the second case study is a young male in his 20s living in direct provision, fled persecution from his home country, persecution based on sexual identity, faced hostility, as we see unfortunately across the country in the local community, and had difficulty accessing healthcare. So he just wants to know, where can I access testing? Can I access PrEP? So we need to send that information on them. And looking he was able to do so. And then the final one then, just to kind of maybe give it a bit of an overview, is a 36-year-old male. And this is just an example of a message I get quite a lot. It's like, what's PrEP? Where can I get PrEP? Or like, what's SH24? So it's often just something, a question like that, that then you can use as a jumping off point for a more in-depth discussion. So we talk then, it could have a chat for hours. We talk about PrEP, sexual risk, transmission routes, be able to introduce U equals U, can introduce SH24, talk about our own home testing service, and then maybe make some recommendations for counselling as well. So you can do all that from just that initial jumping off point. And then just to conclude then, you could say that Grindr kind of, and similar apps, kind of give us this hybrid ecology of healthcare. So it kind of needs to move beyond thinking online, offline, that kind of binary demarcation of spaces is kind of gone. We live in this kind of hybrid ecology. So this allows us to access, I think, a greater diversity of users. We don't maybe, beyond the people we would expect to see maybe in venues or in spaces associated with the community. So we can say that demarcation is redundant, I think, now. So we have, I would say, a scene and screen, then everything in between. So it's kind of a messy mix in between. We help to democratize access to services, information, particularly information. If we think back to that last example as well, so we can give somebody like that the information that they need. Things like SH24 obviously help that kind of hybrid ecology. It's opportunistic and convenient. And that's for both the outreach worker and the service user as well. And it's pretty cost effective as well. So it's a good way of reaching a lot of people in different areas and giving that information. So, there's a reference.
I think that you made as well about, I suppose, Grindr being an opportunity to connect with people who aren't out yet or who live in rural Ireland. Again, that point's been made before, but it's a really obvious and really important venue for that. And I know Pádraig mentioned in his piece earlier this morning as well the benefits we in Mantar and GHN have had in terms of retail through Grindr as well. So I think that point is very well made. Next up then, we have Oisin O'Reilly, who's the Chief Executive of Outhouse LGBTQ Centre. He's previously Deputy CEO, Head of Operations, Fundraising and Corporate Secretary to belong to. So, Oisin, the floor is yours. Cheers.
Good afternoon at this stage, everyone. I suppose in a little bit of a departure from talking about sexual health and well-being and research and work that's going on, I'm going to talk to you about the future of Outhouse and our community centre here in Dublin. I took over as CEO just over 15 months ago, and over the last year and a bit, we've spent a huge amount of time with the community stakeholders, many of you in the room here, with the patrons of the centre and kind of our wider sectoral bodies, to look at what are the needs of our community right now around health and well-being in the most broadest and holistic sense, and what is the future of our community centre. So for those of you who don't know Outhouse, Outhouse is one of the grand old dames of the community that traces its origins back to the early 70s in the original Hirschville Centre, and then reincarnated in 1997 in South William Street. And since 2001, we have been based in 105 Capel Street. And over the last 26 years, I suppose Outhouse has had a very significant, but often understated and hidden impact on queer people and the queer movement in Ireland. And this includes being a focal point for connection and support for tens of thousands of queer people over that time. Last year, 21,000 individuals crossed the threshold of the door. In the first 6 months of this year, 27,000 individuals crossed the threshold. So we are working at scale within the community in providing spaces for connection, support and otherwise. Outhouse also has the honour and distinction of having incubated two of the fundamental organisations that we take for granted in our community now, both Belong To and the Transgender Equality Network, and has supported and played host to numerous activist movements, including both recent referenda campaigns were organised from within the walls, fought from and won from within the walls. So it has been a very cornerstone of activism, community support and otherwise over almost 3 decades. And lastly, taking, I suppose, ownership of one of the oldest buildings in the city of Dublin, it has brought a Georgian building from near demolition into vibrant use, albeit that there are still challenges there. And really, Outhouse's purpose has always been dedicated to the people, spaces, and issues of importance to the community, and it will continue to do that. But I suppose right now, as we look at the context our community is in, we are not safe, we are not seen, and we are not celebrated despite the progress of the last 3 decades. So what does this future look like for Outhouse and how we feel we will best serve our community? And in a way, we have reframed the mission of Outhouse about improving the quality of life for LGBTQ+ people by providing a space in which they're going to find 4 things. First is connection. So we'll be a place and continue to be a place for people to discover themselves, their people, their place and their passions. It's a place for community support, to access information, programs and services. It's a place to come and experience culture, creativity, heritage, discovery and fun. And very much so a place to be part of campaigns and being part of a strong, credible and trusted voice for our communities in the future. And in looking at this and looking at how we approach our work, we really, working with the team and patrons, we selected 5 values through a very open process to guide this. The first is that everything has to start with trust. If the community doesn't trust us as an organisation or a group of people, we can do nothing. It also has to come with respect. Our community is constantly evolving. There are new identities. You know, trans individuals have much greater visibility than they did, a decade and a half ago. Non-binary people have more visibility than they did 5 years ago. There are new subcultures and identities within our community that will have visibility in 5 years' time. And what we do, and everyone in this room does, is really hard work. So there has to be room for joy, a bit of levity, not being able to take everything so serious and to find those little beautiful moments that happen. There's a need for inclusivity. Outhouse has a history of being a pale, male and stale organisation, and there's a real need to unearth that and to create space for LGBTQ+ women, migrants, people of colour, members of the Roman travelling community and others within our community centre. And lastly, the organisation has to focus on the impact we're going to deliver for the community, and that impact is ultimately going to be sustainable. So we have set, I suppose, 4 or 5 strategic goals, and I'm going to share a little bit of a flavour of those with you now. And the first one is very much focused on connection, and that sense of being a place where people can come and discover themselves. So what does connection look like in practical terms? Well, for anyone who hasn't been to Outhouse, it starts with a cafe on the ground floor. The cafe is a low-level psychosocial support service. And in a way, the staff who work in that space are peer support workers that engage with those 27,000 people who cross the threshold in the first 6 months to understand what they need. Some people need a cup of tea. Other people need a much greater level of intervention. In the first 6 months of the year, 600 individuals were offered one-to-one support and a level of casework with issues going on within their lives, everything from homelessness and housing, to the impact of poverty, to accessing social welfare, to needing counselling, sexual health, to safeguarding concerns for vulnerable adults, etc. So what each person needs is very, very different, and our job is to meet the person who comes in with where they are. There's now a thriving set of social spaces that again augment that low-level psychosocial support, that are supported by volunteer members of the community for trans and non-binary people, a Sapphic Social for women. We have various groups for older people and otherwise within the centre, as well as a group of peer support spaces, including Safe Space for refugees and asylum seekers, and other peer support spaces that exist in other organisations that happen and are organised within the centre. It's also a place for community support. And I suppose in a way, those people who are getting that one-to-one case service are moving into that community support level. They're up a tier in the support that they're getting. And we're not the only support service in the centre. We have 80 resident organisations in the centre, including some in the room. I see Shout Out, the Empower programme offer HIV testing every week, and others. And being that space in which people can come to access support is very important. And one of the ambitions that we have over the next few years is to develop a casework support service for the most vulnerable in our community who require additional support to be able to move from our door to the next door in their journey. There are many people who, when they get a referral, don't have the self-confidence to follow through on it. There are many people who need an assurance that the service they're going to is going to be queer inclusive and queer friendly, or will need emotional support on a journey to go from one door to another. And we want to ensure that that's there so that people aren't going to be left behind. When we look at culture, queer culture, I suppose, has been such a foundational piece, and we can't underestimate the importance of entertainment, culture, and levity in the notion of well-being and the totality of our lived experience, and how that plays into how well we feel and the agency we can feel as people to take on challenges, and how it helps us build resilience. And there's such a diversity of culture that happens, and really we have already started to curate a more curatorial set of events and entertainment and otherwise to create spaces for culture, to give expression to our lived experience at this moment in time, to be able to invite those people into the centre for different purposes and meanings. And to give you an example, unearthing some of the history and heritage of our community, in May of this year we hosted Unshrinking Violence, 50 Years of Lesbian Activism, which really looked at the role of lesbian activists in the movement in Ireland and the impact it has had. Last year it was an exhibition on Flickers, which is the original queer nightclub in the old Hirschfield Centre in Temple Bar, the first nightclub to mix beats on an Irish dance floor, and how queer culture feeds into wider Irish society and culture. And also within this, our queer heritage, which needs, I suppose, preservation and curation to preserve it for future generations, but also to make it available to those of us who are living now to be able to access our own narrative and story. And second last, campaigns. And we've thought a lot about in what areas Outhouse will focus its campaigning efforts. And there are 4 issues from the public consultations we carried out and looking at the range of work other NGOs in the space are doing. And we have selected 4 areas where we will lead on nationally. And they are housing and homelessness, poverty and its impacts on our community, the safety of our community and the rise of the right, and climate change and the existential threat it poses to queer people. And lastly, capability, which is a very boring, inward-looking goal, but it's also a very important one when we look at the notions of inclusivity. Many of you will know that 105 Cable Street is a Georgian building and is not universally accessible. And we've committed that by Christmas of next year, we will deliver universal accessibility to the ground floor and basement. And we have commissioned a feasibility study to examine the future premises needs of the centre and a possible redevelopment or relocation of the 105 site in probably 6 to 10 years' time. And within capability, that's about building the capability of the team to respond to need, to maintain resilience and capacity as crises hit our community and otherwise. And ultimately, the strategy is underpinned by 2 commitments that I and the board made. And the first one is a commitment to intersectionality. that our efforts and our resources and our energy are going into the margins within our community as opposed to within the mainstream, and that we're reallocating the resources we're spending in a more equitable way, so that those who most need support are getting that time and time again. So to give you a flavour, there's a lovely roadmap we produced. I have a couple of copies of it with me if anyone would like it. But this charts, I suppose, the outline across all of those 5 goals over the next 5 years of what we hope to achieve as an organisation. And really, we're striving to make of this space, being Outhouse, a haven free of the ills and abuses we find outside it. And in order to do that, we're going to rely on the support of each and every one of you as stakeholders and members of our community and otherwise to help us make it happen. So thank you all so much. Take care.
I think we all probably agree here that if we could recreate what Outhouse does and the service provides in every town and village across the country, that would be an amazing thing if we managed it. Next up then is Laura Tully. She is responsible for the clinical management and delivery of the pioneering nurse-led sexual health contraception and health promotion service for almost 7,000 students on the Technological University of Shannon Midlands campus in Athlone. So, Laura, you're very welcome.
Thank you very much. I'm really honoured to be up here as somebody who's quite new to the area of sexual health. I fell into it by accident. My background was working in student health on the campus at what was known as AIT in Athlone. I'm 12 years there, and I suppose what I am an expert in is student health. And I suppose I'm going to just take you on a little journey today to share with you how I developed a service from nothing. When I arrived to the campus in 2012, my predecessor hid the condoms in the bottom drawer of her desk. The students didn't know about contraception, and the only type of contraception they could access was via one doctor, and it was only the pill. And the word chlamydia was barely spoken on campus, but there was lots of it there. So I had come from a background of living in rural Ireland, working in various settings, and the only time I had heard of STI testing was as a practice nurse. It was routine to carry it out on couples who were struggling with fertility. So you'll appreciate that my own journey is still in its infancy, but I'm delighted to be here to take you through a whistle-stop tour of where we came from and where we are now. So the campus in Athlone has grown to have almost 7,000 students, and it's part of the Technological University of the Shannon, which has 6 campuses really stretching the length of the Shannon across Ireland and across the provinces, with an ultimate 15,000 students. And our students are a very diverse cohort. In Athlone, we have 10% of our students who come from international countries. And we're also a college of sanctuary, which means that we have students attending who live in direct provision or who've just come. On the campus is just it's a small room, student health service, which is staffed by a nurse. It's a nurse-led service, and we contract a GP in for certain sessions during the week. And it runs only during the term time, and we don't have a hospital in Athlone, so we don't have an emergency department, which means we rely heavily then on an out-of-hours MyDoc service that caters for the Midlands, and that's open from 6 p.m. to 8 a.m. So the student profile then is what you'd imagine. Almost 60% of the students who come to my college are in the age bracket of 18 to 24, and therefore classified at high risk of sexually transmitted infections. And I suppose really this is the picture I was faced with when I arrived in 2012, was that there was just a gap in services. The Midlands region is really geographically underserved. And what I was noticing was obviously that students were coming to me with symptoms, and we weren't resourced to look after them. There was no specialist service, and actually my GP at the time didn't provide really any services other than throwing out a prescription for an antibiotic and wishing them the best. So I started to refer my students to specialist services, and you'll see there in the map of the Midlands, you have a long way to go to find one. So I suppose I started really advocating for a service for my students, for the region, and accidentally became a campaigner and an advocate and now ended up running a service. But I suppose it's a good news story in that I got what I wanted. So I captured the data, and the data was that 90% of the students who all would have been symptomatic that I was referring to a service weren't attending. And they weren't attending for all the reasons that you all know about, such as travel time, the distance, the cost of the travel, the actual clinic times wouldn't have suited their timetable. They didn't want to be absent from college, they didn't want to be embarrassed, they might have fears around it, and there was stigma around it. And back there around 2018, the nearest service to me at the time had been in Mullingar Regional Hospital, which was an hour away from the campus, and there's a clinic once a week for 2 hours in Portiuncula Hospital, which is the next town. However, both those were closed down. So that gave me great ammunition to really campaign even further, and obviously it was a disgrace that students would be faced with travelling to Galway or Dublin, and they just weren't going. So as you all know then, a key goal of the National Sexual Health Strategy would be equitable access. So that's the wagon I chose to ride, and funnily enough, the opportunity came along to pitch to Sláintecare in 2019. So this caught my eye, where I thought I could be political about it and challenge the HSE to pilot an integrated service on the campus. So I kind of put all the ingredients that I would like for a service on campus in my proposal, and threw my hat in the ring, and was fortunate enough to be granted some funding to run a pilot at the end of 2019. So no experience in project management, found myself learning very quickly that, you know, I need to make this happen now and show them that if I build it, they will come. As you all know, at the end of 2019, beginning of 2020, there was some other strange stuff happening in the health service, and on the 6th of January, the same week that I started to roll out the pilot programme, I had 21 students fly back from Wuhan in China who were very unwell, and I got a little bit busy with looking after students and their needs throughout COVID. But we did get to run 9 weeks of the pilot until March, when the country closed down, and obviously the campus closed down. So like everyone else, I had to pivot to deliver the pilot and deliver what I could remotely. Now, I wasn't remote, but my students invariably were. So, you know, it was a great achievement really to achieve what we did throughout COVID. And because we had had that 9 weeks of success, we got granted further time and funding to finish out the pilot project, which I'm thankful to say was so successful, has now transitioned under HSE, and we are now permanently annually funded to provide a unique service on the campus, not alone for the students. So the model of service delivery is nurse-led, which I'm very proud of as a nurse. And I suppose I fill that role in terms of being the project manager, I'm the clinical nurse manager, I'm the clinical nurse advisor, and the specialist, and all things to all people. So luckily enough, I don't get sick too often. My governance, I suppose, my buy-in really to make it possible is through my GP service provider. So I'm really fortunate to have a GP who's interested, who has specialised in this area, and I have access to him remotely 5 days a week, but he comes and does a dedicated clinic with me once a week on campus. And then we're linked in with the now up and running service back in Mullingar, which would be the nearest to us, and we fall under Dr. Dominic Rowley and a team there, and we have our colleagues then at Portlaoise as well, who we refer to regularly. So that's kind of the setup of it. Organisationally, it's governed by TUS. I'm employed as I was by the campus, but I suppose administratively and project-wise through the Sexual Health and Crisis Pregnancy Programme. So the college got all excited because we got this funding, and thankfully all my years of cajoling, they put €800,000 into giving me something that was better than the old prefab that we had. So you can see from the images, we have a state-of-the-art facility now, which is very comfortable, confidential and safe for students. We've hit all the targets that we set out to, and in 2022, I provided over 1,200 consultations on the campus. So if you think about an academic year, there's only 11 weeks each side of the term. We really are a busy little spot. So it definitely was a case of build it and they will come. And you know, it's seamless integration for students. This is a safe environment and comfortable for them. And look, it's creating the safe haven that we all are here to do. And I think looking at the values from the previous speaker, that's the whole core of this. So students can come in the middle of their work, their college day. It's normalising sexual health care. And then I suppose the big thing for us is in terms of breaking barriers and building support, particularly for our LGBT plus community. I can't state how valued the work that this network does has been for someone like me. So the education, the training, the terminology, feeling comfortable around discussing this with my students has all come from the training provided by people like HIV Ireland, Empower, the Gay Health Network, and the Transgender Equality Network. And that for me has just been pivotal. We aim to provide culturally competent care, so all our mini team of staff do undertake the training. We've all our inclusive terminology, we ask everyone about their pronouns, we, you know, stuff that you guys all are doing but was definitely not part of campus life. So we've gender neutral bathrooms, we use the pamphlets and leaflets that show diversity, and it's just really creating that safe, non-judgmental space. I've access to a whole team of counsellors which can be arranged on the same day, so resource-wise we're very lucky. And then we've become involved and set up the first LGBTQI+ allies network on campus, which again is just normalising it, giving that kind of green flag to both staff and students. And for the first time ever, the Bridge in Athlone had pride flags this year, so we're really making a little local impact. We do a lot of outreach as well across the campus, as well as the clinical work. Sexual Health Awareness and Guidance Week is a great opportunity for me to get out and about. And a really simple thing like wearing a lanyard or having symbols on display, students will come up and approach and they just give you a thumbs up about it. You know, it's really nice to get that feedback. During Pride Week, we promoted inclusive healthcare on campus. So a lot of our work there will be across social media. Instagram is where the students like to talk to us. We just really promote, I suppose, that, you know, we are here to normalise your healthcare. All students are treated pretty much the same. We're an inclusive service. We normalise asking you about your identity. And then we also say, sometimes we might get it wrong, or if we make a mistake, give us the feedback, because that's where I'm learning the most is from the patients. The benefits, I don't need to tell you, spoiler alert, it is beneficial on campus. It is a good model of care, I think, for our community, and in terms of the strategy and looking at this going forward, I think there's a real role for nurse-led community-based services, whether they be on a campus or whether they be in a rural area or an area that isn't geographically served. You can see there the benefits of the service are exactly what we would want for it, and definitely I suppose the big outcome for me is that ease of access means there's greater attendance, greater uptake, and anecdotally I can tell you that the students that I'm meeting are making healthier decisions now because they just didn't have this education before. Imagine getting to 19 years of age and never having had a sex ed talk, not knowing what's safe, not knowing where to access things like PEP, not knowing what PrEP is. And so, you know, it's really rewarding work. Students are very happy with the service, which is great. And, you know, mostly they comment about how easy it is to make an appointment with an online booking system. And I can provide same-day symptomatic triage. I don't think that's possible in a lot of health services, so that's really impactful. And then our peer support through Students' Union is very well welcomed and, you know, is happy about it. Future for us, looking at like lots of the rest of you, is the same barriers in terms of, I suppose now, expanding the service to actually provide PEP and PrEP on campus, because when we refer a student, they face the same barriers they always did, and now the wait times in that for PrEP, we're finding people just kind of fall off the interest scale when they have to wait a while. So I suppose really we feel it's the right care at the right time and the right place, and that, you know, something from small beginnings became very big. If you can scan that QR code to go into a video about the service, we were lucky enough to pick up an award for it last year. But just thank everyone for their attention and allowing the platform to share the good news story. Thank you.
Laura, I love accidental campaign on advocate. You're doing a huge amount already, so fair play. That's a really tremendous amount of work. Next up then, and I suppose our last speaker for this session is Dr. John Gilmore. So he's an assistant professor in nursing and health systems at the University College Dublin and a Fulbright of Impact Scotland. So John, you have your time.
So much, and thanks everybody for their contributions. They've been amazing. Lovely to see everybody here today. And I want to talk to you about a series of work I've been doing around, I suppose, the broad topic of developing effective healthcare for queer people in Ireland. This is order. Yeah, so no conflicts of interest, not getting paid to be here, so we're check from David. But this research, the pieces of research I'll talk about were funded through UCD's seed funding for Equality, Diversity, Inclusion, but also the Fulbright Commission and the Health Research Board of Ireland. And just a lot of this research was done while I was in the US over the last 5 months. I just want to acknowledge that I was living and working on land that was unceded along a Ramaytush territory and also Lenape peoples and in New York. So really in this whole agenda around developing and delivering effective healthcare for LGBTQI plus people, and there are various things that we need to do. We're doing that, and I think the first thing is really understanding a little bit more about the healthcare needs and experiences of queer people. This is a very much an emerging field. I'm realizing even out in America, when there are loads of people doing this kind of work, it's still very emergent. And until we know, I mean, there's always that anecdote, if you're not counted, you don't count, and we don't know a lot. We know a lot in certain areas. I'm speaking to a lot of people who work in sexual health. We know quite a bit around the sexual health lives, particularly of gay and bi men and trans people, but there's a lot we don't know because we don't ask the questions. So that's a really important kind of thing we need to do. Also looking at the experiences of accessing healthcare and accessing healthcare interventions and treatments. Looking at service needs, and I think that's really important, is working with clinicians and practitioners and infrastructure to develop proper infrastructure and thinking about the models in which to do that. And obviously, anybody who knows I'm a bit of an activist. So I think looking at the policy and kind of political needs around that. What I'm really going to focus on, while the policy political stuff is really important and takes up a lot of my work, and health outcomes research. When I'm going to be talking to you for a few minutes today, and 10 minutes is a challenge for John Gilmore, but I'm going to speak to you about some of the work I was doing in these 3 areas. So just to say that if anyone wants to talk to me about Fulbright, it's an amazing experience. It's the largest and most prestigious exchange program in the world. We're happy to talk to people about it. And I was based mainly at UCSF in San Francisco at the Center for Gender and Sexual Minority Health Research, but also for a short period of time at Columbia University School of Nursing. And I was just exploring different models of LGBTQI plus healthcare. So what I'm going to be presenting to you is not fully analysed. There are emerging findings from 3 pieces of research I've been doing. You might ask, God, I was in America for 6 months. How does he finish this work? Because America is great fun, and I was doing lots of cultural exchange as well. So there, it's not polished, it's not finished, but it is going to be at some point. The term is starting next week. So the first thing, and I think this is quite important as well in terms of we do know a certain amount around LGBT health. We know a certain amount around kind of the experiences of queer people and what queer people might need in terms of healthcare. But there hasn't really been any specific study asking queer people in Ireland, what do you want in terms of healthcare? So this is a study that was funded through UCD. I want to thank Empower and Link and Tenny for circulating and supporting this research. And essentially what I want to do is it's just a snapshot quite quickly of what, we have a lot of kind of, in spaces like this and in other spaces we talk about what we might need and what we should need, but actually engaging with the community. So I did this through asynchronous online focus groups, which are great in some ways and really challenging in others. So it's a space where, an online space where people can come and interact with each other like in a focus group, but in their own time. So, you're not necessarily talking to a person in real time, you're responding to what they've already said about set topic. And these, really what I was looking at here is 4 areas of previous experiences of healthcare, what would you like in terms of healthcare, and what's the priority for you as an individual in terms of healthcare. So I had almost 50 people recruit, and then about 40 people contributed to 3 distinct groups. So there was gay, bi, and sex men group, a lesbian, bi, women, sex women group, and trans group. So people could actually participate in 2 groups if they wanted, and we had people participate in 2 groups in the trans group and also the gay male group or the lesbian group. They're not actually the types of them, that's what I'm going to call them, problematically. But we had like lots of engagement across. So that's what. So I used a platform called Mural, which is an online networking collaboration platform, which kind of it works really well, like what you do if you're doing focus group. You have a flip chart and you have people with sticky notes and all that kind of stuff. So it basically emulates that online. It allows participants to be anonymous, but you choose an avatar, so you can track how people are engaging online. So there was 3 different groups. I have to say, in terms of broad observations, that by far the most active group in terms of participants recruited and also engagement in the mural was the trans group. And I think for me that highlights how much of a priority healthcare is for the trans community in Ireland and how much we're not meeting the healthcare needs of the trans community in Ireland. There was good participation across the board, but you know that was really where you were seeing a lot of engagement, a lot of participation. I think just kind of some of the emerging themes around this is the central role of primary care. People talk about their GPs and their GP practices as the place they need to get healthcare, they need to get effective healthcare. You know, people talk about experiences in specialist services too, but really the GP is where we need to think about focusing, because it is where people, it's the gatekeeper and it's the link into so many other services in terms of healthcare in Ireland. A lot of people talked about experience of homophobia and transphobia, and to make that direct link to I'm not going to the doctor or the nurse because previously I experienced homophobia, transphobia, was misgendered, wasn't respected. So you know, we know through international evidence that experience of homophobia and transphobia really impact health-seeking behaviour. I know a UK report done by Stonewall said that I think it was 17%, about 17%, it's such a specific thing, I think it's 17% of people avoided, did not go to healthcare because of that. So they had a healthcare need and did not go because they feared homophobia or transphobia. People talked a lot about the willingness to engage with practitioners as experts in their own lives. I think queer people have done that right throughout. And I suppose the ask is for healthcare practitioners to be open to that, to be open to somebody talking about their needs. And also speaking about this yesterday around particular health intervention. People talked about, again, that primary care. I mean, the issue is when you have specialist health services, some people were remarking on the fact that everything gets referred into the specialist health service. So, this particularly came up in the trans focus group where they talked about, I don't need to go to the National Gender Service when I break my toe, but it sometimes feels like that when I pretend a healthcare provider. So it can lead to that level of stigmatization. And a lot of people actually, which is disappointing, talk about being willing to compromise, and having to be willing to compromise around being treated culturally responsibly, appropriately, and with respect for good care. And I think we shouldn't be as healthcare providers expecting people to compromise in terms of being treated with dignity. Second study I want to talk about is a study funded by the Fulbright Commission, funded through HRB through the Fulbright Commission, which is really kind of most of the work I was doing in San Francisco and New York and across the US remotely, was talking to clinicians, so providers of healthcare, to understand from their perspective what the enablers and barriers to providing healthcare. So these are people whose full-time job it is to hang out with queer people and provide them healthcare. Sounds amazing. So I just descriptive quality of this, so interviewed 22 clinicians, so MDs, nurse practitioners, social workers, and licensed therapists, to talk about their roles, their work, what they did in terms of the day-to-day, but also what they perceived as the motivations, the enablers and barriers for their work. So there was a constant comparative analysis of this. So by this I mean I'm bringing themes up right throughout, connecting people's themes right throughout the process. So there was actually quite a diversity of participants within those 22. They were across 8 different United States, and again, as everybody knows from kind of the wider global discourse on LGBT issues in the States, there's a great diversity in context of where people are working and living in terms of what they can legally do now as well, and that came up. And also diverse practice environments as well. So some of the people I spoke to worked in what are called federally qualified health centres. So these are centres which are funded to provide healthcare for people regardless of insurance status, migration status, etc., etc. Other people worked only in private practice because that was what was accessible to them. And then other people worked in community sector organisations. So there was a wide variety in terms of what people, that went fast, what people were talking about. So in terms of enablers, one of the things that was really interesting, most people I talked to were queer. That wasn't because I was like, are you a bit queer? No, it wasn't. They just came out through the conversations about why they were doing what they were doing. So this sense of the professional being personal was really interesting, and people really feeling the work was linked to community. One of the kind of things I'm teasing out and teased out through interviews was, you know, nobody becomes a nephrologist because they have one kidney. Maybe some people do. Large people get into kidney care because they find it interesting in med school or nursing school. They have a flair for it, they get into it. Most people are getting into this work because they're queer themselves or they have queer loved ones. And that brings with it a lot of commitment, but also the sustainability around that and how we engage within the wider field. People are really excited because it is an emerging field. It's a frustration sometimes, but you have an opportunity to do medicine and do healthcare that's experimental, it's exploratory, but can have a real impact on people's lives. People talked about the real, like a lot of the people I talked to had previous careers or concurrent specialisms. So people talked about if they were working in nephrology and in primary care for queer people. Like the primary care for queer people brought a huge professional network around us who supported each other, advised each other. The kidney care, you went to the conference once a year and you kind of read people's papers, it wasn't the same. And supported infrastructures as well, as people talked about. While, you know, skeptically in the US, a lot of things were around money, but, you know, the organizations these people were working for committed to working in this field. They could have done other things, they could have made more money and less controversy, but there was a commitment. The barriers were very much lack of visibility in education, so, you know, how we engage LGBTQI plus things within healthcare provider, professional education. A big issue was around professional risks. A lot of people, particularly the older or the longer serving practitioners, but not only, were told, you know, conversations around this is professional suicide. Don't do this, do something else. This isn't serious, it will never be taken serious by, particularly with the BMDs, particularly the medical communities. Big issue around growing demands and accessibility, and also kind of, and this links to the sensitivity to political climate. There are lots of areas in the States where there is no provision, so people were coming to places like New York, San Francisco, trying to access these services that were becoming more and more complex. I did a number of in-person observation studies to health centres across the US, online and in person. So visited lots, great diversity of health clinics. I went in, looked at practice, informal chats with healthcare providers, and looked at kind of the materials and guidelines they were providing. That's my friend Campbell, who's the most amazing person in the world. He's the director of the Strutt, which I'll talk about in a second, and they are well worth visiting. You're there. So these are kind of four of the centres I visited. That's Bellevue, which is a large federally qualified health centre. It's a hospital, a big hospital, orthopedic surgery, a whole lot. And they've a dedicated LGBT health service there. Richard Green, amazing person, ran the centre there. So again, that's a specific model. That's the LGBT health centre, amazing, holistic healthcare provider. Housing, financial support, care for older people, homeless youth, wraparound service along with a fully functional HIV service, primary care service, gender affirming care, everything in there. Helen Lord, probably one of the most famous federally qualified health centres, which is directly working, solely working with LGBT people, and Strutt, which is a large sexual health service, which came out of being a gay men's health service essentially, and then developed into a sexual health service for all people. So there's lots of different models which were provided. I think that was an interesting thing to see, because there were challenges of both. I mean, people liked the fact of these community-based centres because, you know, it was ours, community governance is really important. But like, if you see someone in Bellevue in your primary care service and you're looking at their funny-looking mole and you're like, I'm not sure about that, and you're a GP or a nurse practitioner, you could ring dermatology and they might come down in 5 minutes because they live upstairs because the dermatology department is in the big hospital. So there are kind of benefits in that sense. And one of the big challenges is around the different, so Strutt is very community engaged, very community led. Everything they do is led by the community. Almost everybody who works there, I think, are queer. They look queer. That's a really problematic thing to say. But they're really cool, fun people if they're not. but they do a huge amount of work. And again, what we see in this field is really responding to community care. So started off with gay men, HIV, have developed up because they started seeing people with broader gender. They now, 2 of the nurse practitioners have full caseloads of providing gender affirming hormones to people because that was needed for their sexual health. Because you can't be sexually healthy if you're not helping the rest of your body. They provide care for people who are having sexual functioning issues. They prescribe Viagra or the other drugs. They're real. They do needle exchange. They have a specific program for people who use steroids. So they have loads of different kind of inputs meeting the needs of what they care about. And I think really what you see here is community clinicians. I'll talk about any of these individually people because I'm running out of time. And I love talking about them. And you should visit them if you're in New York or San Francisco or LA. I didn't like LA. The LA LGBT Centre is amazing. So I think what I'm trying to do now is consolidate all this into a final report and really kind of look at. There are a lot of infrastructure things that you think about in Ireland in terms of electronic health records, how we collect sexual orientation, gender identity data, how we really embed this. Because if we create an LA LGBT Centre in Dublin, what are people going to do when they're in Waterford, when they're in Cork, or when they're in Limerick? So we need to think about, multi-pronged approaches and then continue to educate, lobby, and build solidarity. And I think one of the things I would say is when we talk about LGBTQI plus healthcare and healthcare in general, these things are intertwined. You can't be healthy if the wider political and social exclusion is so prominent in your life. But concurrently, we're very proud in Ireland for the rapid social progress we've made in this area. Like we have whiplash, not that long ago, Ireland was a deeply homophobic country, and then we have marriage equality, But I can't say we're a progressive place for LGBTQI plus people, given the state of LGBTQI plus healthcare, because healthcare is a fundamental human right, so they're deeply intertwined. We can't be healthy if we don't have our other rights, but also we can't have full fruition of human rights if we're not healthy. So thank you very much. Follow me on Twitter. I have got there's some posters down there. Anybody's interested in LGBT health research, we have visiting Tanda Hughes, who is probably the biggest, not biggest, but biggest, most renowned LGBT health researcher, has been doing this for 40 years. She's coming to visit UCD on the 27th of September, giving a lecture at 2:30 about her career and kind of the state of LGBT healthcare. Her background is mostly in addictions and women's health, but works across the board. So thank you very much.
John, and apologies to everyone who I've hurried along. I've still managed to beat people's legs, but nonetheless. So just before this, what we do is by Self Productions, so we're very thankful for them. We made this film called Making Waves, which is about LGBT life in Northern Ireland. So I think just before we finish up for lunch, our hope is that we can, yes, well, Shane is here, sorry. If Shane wants to make himself known. Oh, there he is. He's there at the back. Shane, if you'd like to come up, even just, we might just show the film first, I think, and then if you want to say a few words afterwards, that'd be good. Come on, Karen. So if we could just go ahead there.
My name is Bolelani Mfaiko. I'm from Cape Town in the Republic of South Africa. A young lady who lived down the road from where I lived had been abducted and murdered for no reason other than her sexual orientation. She wasn't the first person to be killed for her sexual orientation. I just decided, that was it. I'm not going to stay there anymore and live in fear. I left a one-way ticket back to Dublin. I first consulted several NGOs, including the Immigration Council and the Irish Refugee Council. I then applied for international protection on the 1st of November in 2017. And that experience was very eye-opening because it was the first time that I've ever been deprived of many of my fundamental human rights, such as the right to engage in gainful employment and being stripped of personal autonomy. I couldn't decide what to have for breakfast, lunch and dinner or where to have it. I couldn't decide who I shared a bedroom with for the very first time in my life. And when my first roommate in Knocklashin found out that I'm gay, he said, "I don't like that shit. Boys are supposed to be with girls," and we were expected to share an intimate space such as a bedroom in that environment. Like I used to have days in direct provision where I wouldn't want to even get out of the room. After experiencing hearing homophobic slurs in the common area, like in a canteen, just completely disinterested. Like I had no trust whatsoever. I didn't know who to trust. Who do I rely on? People look to Ireland for progressive ethos, and yet we don't see that coming through in the direct provision system. It is quite contrary to Ireland's human rights obligations because most modern states have signed up to various human rights treaties, such as the Geneva Convention on Refugees, and we don't then see that in the system of direct provision, because you are physically removing people from Irish society, you are divorcing them from social, economical and political life of the country, and that is no different to the way that prisoners are excluded. When you are an LGBTQ plus person in direct provision, there is no recognition of the reasons why you are in an asylum seeker to begin with, because many LGBTQ plus people would have fled horrific situations in their countries. We've had people who survived torture and sexual violence in their countries. Putting people in an environment where they are again subjected to a constant abuse has negative impact on the asylum seekers' mental health. We've had quite a number of LGBTQ plus people who depend on pills in order to cope with life in direct provision, and that is dreadful. The sad part is that people still rely on therapy and sleeping pills and antidepressants long after they've left the direct provision system, and they're still trying to deal with the traumatic experiences that they've gone through. There are very simple things that could be done better. In fact, the government now is showing us that they can get things done very fast if they commit to doing so. If you look at the response to the war in Ukraine, we're not seeing that for asylum seekers in direct provision. We've had people who've been waiting in hotels for months, long before Russia invaded Ukraine. They were waiting for PPS numbers, they were waiting for medical cards, they were waiting for temporary residency permit cards that would facilitate their getting their children to school, for instance. They've shown that they have the necessary resources. It's not an insurmountable task for the Irish state to look after the 8,000 or so people who are in direct provision, many of whom have been in direct provision for many years. The answers are already there. The state knows what the answers are, and the very simple answers is to treat us no differently than you would want to be treated yourself if you went to another country to seek safety. Racism is not something that people experience in faraway places or in closed doors. People will experience racism in your surroundings too. And so I think the very first step that we need to do is to check the environment that we live in. Check your boardroom. Who is in the room? Who isn't in the room? Why are they not in the room? When you walk around Dublin, you will see how diverse the city is. And that needs to be reflected in every part of Irish life if we are to live harmoniously together. I think Irish people can take charge in terms of how to combat racism, because it's certainly not my duty to be going around teaching the Irish government how to treat racialized people with decency. I think Irish people need to take charge in interrogating the spaces that we live in all manner of Irish life, so that we can get to a better place than we are in today.
Hello, I'm Pradeep, he, him. I'm from India and I'm living in Ireland for over 10 years now. The racism is quite interesting topic to discuss as a gay person of color from Asian origin, because most of my racial or racism experiences, they come from the community itself. It comes with spectrum, so there is sometimes they're like passive racism, or sometimes direct in this face. If I give you example, people used to ask me, "Oh, are you from Mexico or are you from Brazil, and if I say no, I'm from India, and they used to like turn back on me and go because I know their intention and what they were expecting. Or if you go to the scruff or a grinder, and those things are happening till now. Asian men or certain part of Asian men that is not welcome, like Indian, Pakistan, Bangladesh. There is also stereotype around it. Asian men are bottom if they are from China, Taiwan, Japan, or Indonesia. So my art come from my experiences as a gay person of color living in Ireland. Honestly, my art has significantly changed over the years. It wasn't like this bold. It wasn't this sexy. Unintentionally, it comes that all my unfulfilled sexual desire, unfulfilled friendships and feasibility desires, that I put everything that frustration into my illustration and into my writing and in my film making. There are many Asian queer people living in this country for all around 40 years or more. But they don't feel welcome, they don't feel encouraged to come to the scene and tell their story, or they don't even feel now to go to the pubs or bars because they have such a horrible experiences. For my personal experience, I still struggle to have friends. I still struggle to have hookups, or I still struggle to build up a friendship that will based on the trust and mutual respect, and that feels really challenging. For my mental health, I develop anxiety and I develop a lot of other issues because of this isolation. And I'm not talking about the isolation of COVID. I'm talking about the isolation that propagated by white gaze culture, and that just put people like me into isolation, without friend, without intimacy, without trust. It became my always priority to look after my sexual health, because if something significant happened to me, I don't have anybody to ask help. So that is my sense of self-awareness and responsibility come from that point. Law can prevent and protect people, okay, but it cannot make racism or hate crime go away. It will be there. It will be there. Only thing would change that we can make more understanding through our education system, media representation. So things won't change overnight. It will take time, but we need to start somewhere to make sure that we have some adequate and reasonable national integration policy, that people who are coming to this beautiful country, that they will also get opportunity to be part of this culture as responsible and creative collaborator.
before we head for lunch then, we'll do a short Q&A with the panel. If anyone has any questions, they might make themselves known. We've got microphones traveling around. So, any questions? Here we go. Race if you're on.
This is a question for Ciara. Ciara, a few years ago I had the privilege of being on a panel discussion at Gay and Grey, the conference in Cork about older queer people. And I was completely astonished when this older man stood up and said, I thought I was coming here for a conference about gay people, why are we talking about lesbians? And like, I was absolutely shocked, and I remember saying to somebody, well, that's why Link exists, you know. So I'm just wondering, is there still this sense of equating gay with males, and you know, that whole, I mean, I can't say rubbishy interpretation, but like, I was really shocked that there was still such a Neanderthal attitude being expressed at a conference only a few years ago.
Just to say, I'm going to answer this based on what I've observed and my own opinion, but obviously it's not representative of the entire queer women's community. But I think it really depends on the age group. I know a lot of younger women, there's a cohort that identify as gay women. And then, say, kind of from my age upwards, there's a lot of women who've reclaimed the word dyke. And, you know, it's synonymous with their feminism and stuff. But as we kind of get to the 25s and under, I think the word queer encompasses a lot more people's identities. So I think that it can be linked, like it's the Gay Health Forum that we're at. You know, and even if you look at the programme, the representation of women and women's issues are still probably not where we'd like them to be. So yes, I would say gay is still synonymous with male sexuality, but I think a lot more women are kind of starting to own that as well. So does that answer? Yeah, okay.
Thank you for that. Any other questions? One hand there, two hands there.
Scott from the Labour Budget Northern Ireland. I was interested in the monkeypox presentation. I was wondering if you'd maybe explored the role of the media and how people had their perception around that, whether that was something you talk to people about. I don't know whether you can answer that directly. Just my own experience of it was seeing, you know, in Northern Ireland, Nolan, who's a famous bigot, I wouldn't say that word, but did some really negative stuff, and then it caused a panic around the whole thing, and I think that's been a thing in the UK and other parts of the world, so I was wondering what you thought about that.
Yeah, people did kind of comment on how the media have reported on it. Some people felt the media hadn't talked enough about it, and one of the recommendations in the report is to have general public health messaging going through media for all, as opposed to kind of queer specific routes to reduce stigma, because people felt that either the media weren't kind of giving it enough attention and weren't giving it the urgency that it deserved, mainstream, or were kind of maybe not misrepresenting it as a queer issue because it was a queer issue, but kind of not doing that in a way that was respectful of queer culture and respectful of the, you know, the potential stigma that could come about as a result of it.
Thank you. Another question right there then?
So I have a question for Laura about the student sexual health services. So I used to work at Dublin City University, and I work at University of Manchester now. And typically what I've seen is engagement in any sort of student initiative or projects tend to come down to queer students and then female students. So I'm wondering, what has engagement been like with straight men or men generally in the student population engaging with your service? Have you noticed any patterns or anything like that?
Would you believe we've 51% engagement with straight men? And I think that came from the original service users saying I was sound. That it was okay, because it was such a new service, and for most people coming to my service, it's their first time to visit a sexual health service. It might be their first disclosure or not. But I think it's word of mouth, and that they had a positive experience, so it led to a lot of the friends coming in. And obviously that's a great thing. So yeah, actually we've more guys using the service. But we also have a lot of students who experiment, so they're not, they're mixing partners without any labels. So it's good that they're coming and getting tested regularly, yeah. And it's a small network in that area, so a lot of people are meeting others, so we're kind of nipping infections in the bud, I think. So yeah, great engagement from our service, yeah, so it's good.
Always something to be said for being sound. Any other questions in the room? There we go. Come on there. Microphone will bring it through.
Hi, this question is for John from Debunking the Myths, the Science of Women and Sexual Health. You're exploring community practices for sexual health in general, but are you doing any research on education in the peer community, especially for like younger aspects of the community and teenagers?
Thank you. I follow you on Twitter and I love what you do, so keep doing it. So I'm not looking at sex health particularly, it's more generic around healthcare for LGBTQI plus people, particularly interested in primary care. I'm not doing anything specifically on education needs, although I have been advised to youth work, race and present youth work Ireland. So I have done a lot of work. We have the YES program we have, it's not mine. I was involved in developing the YES program, which is doing some of those educational works in youth workspaces in schools. So it's definitely something I'm interested in, but not necessarily my direct work right now. But you're doing good work, so keep doing it.
Thank you for that. We have another question?
Yeah, Fintan Warfield, Sinn Féin. Just to say, very inspired for the contributions in the discussion. Laura, well done on all your work, and Shannon, to you. You mentioned in the next steps or in the future, you talked about expanding the frequency of contraception scheme. I know that was recently expanded to 26-year-old women, 17 to 26-year-olds. So I just wondered, could you expand on what you meant by what you're looking for in that regard?
That's easy because I think all women should, all persons who want to access contraception should have it free. So under 26 definitely start, but it's not enough. And obviously the profile that I deal with in terms of students, it's a very different age cohort now. So it's a big barrier for all women, whether it's on or off campus. So huge call out to have that expanded rapidly for everyone who needs access, yeah.
And just the question for David as well, the recommendations that you made, did they come from the survey respondents, or was that kind of your collation of the recommendations?
I suppose they were informed by a combination of the expertise of the research team, which included John and Christine from Galway as well, but based on what had been, represented to us in the survey responses, and some of them, one of the recommendations is lifted directly from the UK report, because the issues that they brought up were echoed in Ireland as well. It came originally from, I suppose, the participant responses, but then there was obviously input from the research team because of the nature of qualitative research, and it is a subjective process, and we did have input into how we shape those recommendations.
Thank you. Cheers.
Thank you, Fintan. Any other questions? I'll take that as a no. Perfect. So first and foremost, we just give a round of applause for our wonderful speakers. And now we will let you go to lunch. And we are asking that you might be back in the room for 2:15 maybe? Okay. I was trying my luck. Not too much better, please. session of the day. My name is David. I'm the Sexual Health Advisor, Clinical Nurse Specialist in the Gay Men's Health Service, and I'm going to chair this final session. I just wanted to say thank you as well as part of the organising committee for the Gay Health Forum, and I've been plaguing a lot of presenters and everything over the last couple of weeks, but the engagement from everyone has been absolutely fantastic, and the quality of the presentations is amazing. So thank you, and thank you for the work you do. Firstly, I want to introduce our second keynote speaker of the day, Dr. Chase Ledden. Dr. Ledden is an interdisciplinary research fellow at the Centre for Biomedicine, Self and Society at the University of Edinburgh. His work explores the intersections of critical public health and queer science and technological studies, with a focus on HIV and STI innovation, sexual health promotion, and sexual health activism and engagement. So we can welcome Chase.
Right, thanks so much, David, and the rest of the organisers for inviting me today. I'm very excited and a bit nervous to talk to you about this kind of ongoing research, which of course, as you'll know from our explorations earlier this morning, that DoxyPEP is quite an emergent phenomenon. So I'm going to take you through the journey of this emergence, essentially, from the UK perspective, because of course this is where I'm based, but I'm hopeful that in this Q&A session that we have afterwards that we can explore some of the implications of this for Ireland. So much of my work today is focused on social aspects of public health, especially related to the framing of the end of HIV and AIDS within the UK and global health promotion. Indeed, this work is part of an ongoing book project and a long-term study about the ideas of social futures within public health. Up to this point, I have argued that post-AIDS imaginaries within HIV health promotion conjure potential futures for society at large to, in their words, secure the future for new generations, putting in place social imperatives for those currently fucking it out to always bear in mind the future. What I want to explore today is intimately linked with this idea of social futures of public health, though I will explore the context and significance of STI innovation, including the emergence and normalization of DoxyPEP in North America and the UK, and the known problem of antimicrobial resistance entangled with this pharmaceutical practice. My core interest is attending to the problem of futurity within sexual health innovation. So, to use a metaphor, public health futures are the substance within the mortar. The pestle takes aim at the substance of futurity and liberates social multiplicities as they become exposed to air and other compounds. As we'll see in the case of DoxyPEP, the future liberated from our scientific process is not only the making of material conditions. The future of public health, and I would argue sexual health specifically, is made up of contingencies leading from the present. This includes our understandings of sexual health as a technological and progressive phenomenon that is necessarily constituted by the changing nature of sex and sexuality in society. As we shall see, DoxyPEP, like HIV PrEP before it, is co-constituted by sexual encounters, identities, ideas, fantasies, discourses, affects, and temporalities, all of which coalesce around and through our existing scientific systems, medical apparatuses, and individual forms of medicinal experimentation and consumption. In the short time I have today, I hope to demonstrate the power of emergent social imaginaries bound up in the emergence of DoxyPEP. But more specifically, I wish to share with you my current understandings of how and why ideas about STI innovation emerge and or depart from the normalization of DoxyPEP. My ultimate goal is to briefly unpack if and whether we can devise a critical public health framework for capturing the complexities of the social imaginaries of DoxyPEP and their contingencies with AMR and STI innovation. If we are successful in devising this framework, we can then begin the difficult conversations about public health mobilization, ethics, and critical inquiry, which, as a long history of scholarship reveals, will enable us to effectively integrate DoxyPEP across short and long-term timescales. So, by way of introduction into this literature, let me begin by briefly defining DoxyPEP. So, DoxyPEP, or doxy post-exposure prophylaxis, refers to the oral consumption of doxycycline, a tetracycline class antibiotic, used to treat a wide range of bacterial infections, including bacterial pneumonia, acne, chlamydia, Lyme disease, cholera, typhus, and syphilis within 72 hours after a sexual encounter. Some scholars have identified its historical use during the Vietnam War and in small groups of gay men in San Francisco since the 1970s. though medical recognition of doxypep has largely emerged in the last 5 years. This is especially within recent randomized trials exploring the now established efficacy of HIV PrEP, or HIV pre-exposure prophylaxis. These trials have helped to determine the 66% efficacy rate of doxypep, and in turn, this scientific marker has encouraged sexual health clinicians, especially in North America, and to some extent in the UK, to prescribe doxypep for communities at high risk of STI transmission, including gay and bisexual men. Of course, in the UK, BASH and the UK HSA, the two kind of major public health bodies, currently advise against the use of doxypep, expressing extreme caution and concern about its potential to increase resistance to antimicrobials within human populations and the environment. Nonetheless, as yesterday's Brilliance Doxypep awareness event hosted by the Love Tank in London revealed, the use of doxypep is both on the rise and framed as a positive innovation in sexual health treatment and prevention in society today. I'll return later to the concern of AMR in the environment, but for now, it's important to note that the emergence of doxypep has arrived with minimal scrutiny and little moral panic, unlike the prolific and heated controversies of HIV PrEP in the 2010s. Part of this soft integration, I suggest, is due to the historical entanglement of doxypep and HIV PrEP. HIV PrEP has carried the larger burden within the moral economy of sexual health since the emergence of effective HIV treatments in the 1990s, and thus, presently, it has diffused some of the initial outcry or panic that might emerge from the both prescribed and unprescribed use of doxypep. So, to be specific, recent findings from scientific studies about HIV PrEP use has challenged the popularized notion that HIV PrEP has caused a rise in STI transmissions. The unceremonious incorporation of doxypep then exists within this breaking of this link, and thus the rather classic problem of STI transmissions emerges from this strange and ambiguous change to our understanding of this link. Though the scientific narrative of doxypep has yet to be examined and told, we can start here by creating links with how recent HIV science has helped to calm unfounded fears about gays spreading untreatable STIs. This link, or perhaps the breakage of a weak link, I would argue, has made room for gentler conversations about the role and process of technological innovation within sexual health after HIV, whatever that means. To understand this calm entrance into the STI prevention world, I want to turn for a very brief moment to examine this very interesting recent San Francisco AIDS Foundation health campaign, which promotes awareness about doxypep and in the San Francisco Bay Area. So as John told us earlier, they're working on some really innovative thinking through their health promotion practices in San Francisco and in America in general. So the messaging in this health campaign prioritizes practices of condomless sex and links these messages with the potential to prevent common STIs. Unlike condom adverts in the 90s, or indeed HIV PrEP adverts in America in the 2010s, which advised the kind of cleaning up of sex using kind of prophylactic modes, the doxypep narrative operates through what cultural theorist Tim Dean might call unlimited intimacy. That is, doxypep literally stands in for the ability to have as much raw fucking as one could want, and this symbolic gesture both normalizes and fantasizes about the naturalness of its consumption and the fucking that is enabled by its consumption. I would suggest that this narrative tells us something interesting about the links between HIV PrEP and STI innovation. These new messages about doxypep align with pre-existing messages about condomless, bareback, or raw sex, messages that were once highly contested by opponents of HIV PrEP, who in the mid-2010s decried the rise of the PrEP whore and lamented the so-called end of the condom. Interestingly, this health campaign doesn't presume a moral stance on the rightness or wrongness of any particular sexual act. Indeed, the opposite is true. The visceral language about getting pounded raw appears both gritty and accepted, a positioning that has become commonplace, perhaps even unchallenged. In this reading, doxypep exists peacefully within a calm landscape of HIV prevention. That is, it occupies a domain where the stigma and moral opprobrium has yet to take hold. With the campaign, doxypep has yet to receive any such condemnation, though it is still early days, in part I would argue because the significance of STI stigma and HIV stigma exist on different scales. From a research perspective, attending to these scales of stigma that emerge from both HIV PrEP and doxypep use will be a new domain for scholarship to explore. But for the purpose of this talk, the fearless positioning, this calm positioning of doxypep and its emergence in the world has the potential to overcome the immediate fear of HIV, creating both a lived and imagined future that is at once far ahead of the 2030 goals to end HIV transmissions, and a speculative present that is currently being experimented with. So, in the same vein, new health promotion messages about doxypep tell us something about what is both prepared for and imagined to come next, and this is where speculative futures come in. So here I mean that in its calm domain, public health imaginaries contain a particular vision of the future that has been accepted and has integrated and consumed, the consumption of pharmaceutical products. This normative acceptance is of course the everyday practice of public health, but it is precisely because it is the perceived everyday that I suggest we must pay critical attention to it. This future imagined with and through doxypep, though it is multiple and indeed undetermined, draws from contemporary biomedical reasoning, namely a one-a-day pill like HIV PrEP, which can be easily taken after sex and thus negates the threat of infection and the pesky trip to the sexual health clinic. This public health logic extends the present into the future by imagining an end to new transmissions through the use of a daily or an event-based dosing. Thus, doxypep, like HIV PrEP, begins to occupy a pharmaceutical temporality of treatment and adherence through repetition, but has been conceived of by scholars as both a long-term biomedical and behavioral imaginary. Now, this might come as a surprise to some, framing this as a regimentation of biomedicine, as a behavioral intervention. But when we think about this concurrent use of both HIV PrEP and doxypep, for instance, we begin to see a social present and an imagined future where both gay and bisexual men are socialized to collect their pills, set their phone reminders, consume before or after sex, making sure not to clash with drug interactions or daily vitamins, and then to pass along this knowledge to younger or newer sexual partners not yet privy to the rhythms of a pharmaceuticalized gay life. The point here is that we are now passing into an era of biomedical influence within gay male communities that has gone unnoticed for some and has been raised as a spectre stalking the town for others. This era, again thinking temporally, feeds the narratives and logics of doxypep, since we have already for the past 10 years consumed and normalized HIV PrEP and its use. This reading now may sound like a critique of the biomedical rhythms of pharmaceutical consumption and treatment adherence, and you would be singularly right in hearing this narrative. But there are many futures that emerge from and within doxypep. So this reading needs to be understood also as a way of attending to gay social life, which is itself heterogeneous. What I mean to say is that the calm entrance of doxypep and the acceptance of increasing pharmaceutical influence within gay male communities means that old social patterns are shifting and new idealized practices are emerging. Given this shift, I suggest that we should pay attention to these social patterns that are being circumscribed within the supposed innovative thinking and integration of doxypep. To do so means not only following where, when, and how doxypep is being consumed and disseminating both inside and outside the clinic, it means also to attend to the desires, pleasures, and intimacies that have historically been largely neglected by medical and public health practitioners. Indeed, where HIV PrEP seems to liberate biomedical discourses from archaic notions of viral determinism, doxypep enables a further step towards expanding potential medical futures and pleasureful futures beyond the clinical encounter to capture the gritty, raw fucking that gay men do, and perhaps fear-telling in clinics lest they withhold the bloody pills. At the end of my talk, I'll return to this idea of the pleasures and possibilities imagined within and through doxypep when I explore how we can develop a kind of ethical and critical positioning in relation to doxypep. But for now, it's worth simply stating that the predominating imagined future of doxypep appears largely positive, that this, without critical discourse, that is, without large critical discourse from gay communities and doxypep users generally. As I mentioned, however, in the UK context, there are, of course, negative perspectives from medical practitioners about the use and integration of doxypep amongst gay and bisexual men. Thus, we should attend to some of these discourses. Whilst it's currently under-theorized, doxypep enters into conversations with existing global health fears about antimicrobial resistance and antibacterial stewardship. This means that before we can even begin to attend to the ethical protocol of life, of a normalized life with doxypep, we must first attend to the context and situatedness of doxypep in global health politics. This, I suggest, will help us to understand the urgencies of antibiotics and microbial resistance in the Anthropocene, or how we occupy the world. So, love this wee graphic. We plan around AMR. AMR is caused by several mechanisms, including enzymatic degradation of antibacterial drugs, alteration of bacterial proteins that are antimicrobial targets, changes in membrane permeability to antibiotics, horizontal gene transfer, and selective environmental pressures, amongst other reasons. Recent attention has focused on these latter two mechanisms in particular and appear as a leading concern for global health policy that brings together humans, animals, and the environment under the trifecta of a One Health model. Our understanding of doxypep and AMR is, of course, intimately bound up in these larger and ongoing public health programs, so it should be part of this narrative. The threat of gene transfer of bacterial DNA that is resistant to antibiotics is now well documented in scientific literature. A recent UN report estimates that resistant infections already cause at least 700,000 deaths every year, including 230,000 deaths from multi-drug resistant tuberculosis. The scale of AMR and its impact upon global population health is underestimated in large part due to poor access to antibiotics and low literacy about their use in certain regions, and more specifically, uneven and incomplete epidemiological data tracking drug-resistant pathogens. The WHO has described AMR as one of the top 10 global health threats facing humanity, and a quadripartite of global health organizations has been developed to mobilize funding, resources, research, and prevention initiatives to tackle AMR in 10, 30, and 50-year timescales. I would go on to argue then that these timescales are especially important for how we understand the local and natural controversies that will emerge from the use of doxypep. It's these timescales to which we must attend if we are to make sense of the scale of doxypep itself, namely if, when, and how sexual health experts contribute to conversations about the global problem of AMR, or indeed, if the problem is so localized within the potential impact of doxypep that it's minimal, negligible, or non-priority for global health. I suspect that doxypep does in fact play some role in conversations about the global and AMR program, and thus what I am raising here is first awareness that doxypep should be captured within global health frameworks, and second, that local and national sexual health experts must think both locally and globally if we are to make sense of the social implications of doxypep, especially for GBSM communities. Since about the mid-2010s, and specifically around 2017, scientific literature begins to describe the use of doxypep for the treatment of new chlamydia and syphilis amongst GBMSM taking PrEP. This literature coincides with the large clinical trials that I mentioned earlier, as well as a few smaller trials that explore specifically the use of doxypep. These studies found moderate efficacy, and they provide supporting evidence that also suggests that the use of doxypep could help to reduce increased risk of HIV transmission through co-infection. This positioning is what I would call the platforming of doxypep. Proponents, it is the making of intimate links of these intimate links between HIV PrEP and doxypep, and it's the creation of an advocacy for new research and accelerated funding to both platform and to continue funding for HIV PrEP, and to also develop new funding for doxypep. But on the other side, to return to opponents, opponents of doxypep have noted strains of gonorrhea that are resistant to doxycycline, especially in North America. Their concerns focus on increased antimicrobial resistance through excessive exposure to antibiotics at a population level, and their argument, whilst vague, attends to a generalized population health perspective, which follows the microbes within communities and national populations. Of course, we all know this to be a kind of generalized epidemiological perspective. However, in the case of sexual health, it's really important for us to then begin to think about, well, what other perspectives are needed here in order to understand doxypep. Doxypep, in this view, whilst understudied and indeed under-theorized, is potentialized as contributing to larger environmental pressures that enable national and global AMR transmission. Cautious opponents, nonetheless, have generally supported favorable opinions of doxypep as a small-scale intervention amongst GBMSM for a limited period and duration. Yet, from a health economics perspective, questions of cost efficiency, especially for the short-term burden of publicly funded doxypep in the case of the UK, and its potential for long-term impacts upon general antibiotics in the future globally have been raised and considered. On both sides, to kind of create a thread between these two, it seems clear that doxypep provides some value for gay and bisexual communities, as well as many other communities, and even where the scientific controversy is starting to emerge, there appears already to be faith, hope, and energy for this biomedical innovation. Now, let's pretend for a moment that doxypep exists somewhere intelligible within the imagined futures of global AMR transmission, so we can then start thinking about initial actions we might take. The One Health model appears in many forms, but for simplicity, this model is a circuitous diagram that connects humans, animals, and the environment. The basic premise of a One Health model is to conceptualize our complex world all at once. That is, to stratify the dizzying layers of complexity from the building blocks of life in cells to planetary processes. As this diagram shows, microbes are porous across these layers, and their confluence is both simultaneous and omnipresent. As such, the problem and scale of AMR must be thought of through the process of compression. To compress, in other words, means to understand the social and natural actors that cut across the rational categories of material difference. So these three things that are being put out here, namely the assumption that all of these things that are being mapped here are necessarily cohesive and distinct, as we've constructed through our understanding of the scientific Enlightenment. This shift in thinking from the kind of structured, rationalized form of how health is created in these kind of distinct forms to a kind of more porous and entangled way of viewing the world creates a recognition that the material world is and always has been more than human, and that our place in the world is necessarily one small part amongst a very complex system. The point here is that the imagined scale and future of AMR, which shapes our understanding, conceptions, and theories of the present and future of human, animal, and planetary health, are entangled. And thus, if we are to understand the social significance and consequences of doxypep, we must, within our clinics and communities, begin to think critically and creatively about how the complex relation of our sex and sexuality on the global stage emerges, and how we can maintain our pleasures, intimacies, and desires through willful and fierce attention paid to these many different scales. So let me think very briefly, knowing my time is limited, about what paradigm we might use to attend to the social complexities of doxypep. On the screen, you'll see a diagram with little bubbles containing actors around the bubble containing doxypep. I imagine this diagram to tell us something about what the complicated and messy social relationships that cross over and diverge from doxypep might do. For instance, it's well established that the risk of AMR developing and transmitting amongst individuals in clinics and hospitals is much higher than through individual encounters. As such, we may not only need to think about where those social actors are placed in the clinic, we may also need to think about where that clinical bubble is shaping, is moving, is kind of getting bigger or smaller in relation to all these other social actors. In short, because doxypep has arrived so calmly and appears, at least in the short term, to be our next innovative intervention, we should spend some time with its social complexities so we can begin to attend to many of the other intersected concerns that rarely pop up in scholarly or community conversations about HIV PrEP, for instance, including how to live with and queer the microbiome with the accepted integration of doxypep, and what kind of queer times and places must be prominent in our understanding of gay life in an era that is increasingly pharmaceuticalized. So, I'm aware that I'm probably approaching the end of my time. I want to raise some questions that might help us to begin thinking about the queer times and places of our microbiomes, of doxypep and AMR, and how thinking about those times and places will necessarily help us to be mindful and critical of rising acceptance of pharmaceuticalization within gay male and specifically queer communities. So first, I suggest that we need to pay attention to the queer relations facilitated by biomedical production, distribution, and consumption, a project that Kane Race in Australia has been working on for more than 20 years. As I've described earlier, we have seen the recent normalization of HIV PrEP, and this has been relatively unquestioned, especially in relation to doxypep, though of course it's emergent, it's new, so of course you can't expect this to already happen. I question here what kind of relationships are created amongst doxy users, and Are they principally driven by a need and desire to use biomedicines and more of them? These are questions that we began to start to unpack in the 2010s in relation to HIV PrEP, but we didn't really answer. There are things that still need to be unpacked. We have another chance to begin to think about these synergies in relation to HIV PrEP and DoxyPEP. If so, previous scholars have cautioned the pharmaceutical life, perhaps to no avail, and our present task then is to study and answer how we might create scientific systems that are capable of enabling a queer science, to use Kane Race's concept, to generate practices related to pleasures of consuming and using medicines and technologies. Paying attention to sexual innovation in this sense means closely analyzing the scientific processes of biotechnological innovation, especially how and why we develop new drugs to prevent AMR, and a science that speaks directly to DoxyPEP consumers rather than operating solely or even principally from financial margins. This is, of course, speculative and wild thinking, I know, but stay with me. When we attend to the social and technological processes of DoxyPEP, which, as I have suggested here, inform the very scientific work that underpins contemporary sexual engagements and intervention practices, we begin to open up critical questions about the publicness of scientific practice. And we then begin to change our understanding of sexual health generally as a community process rather than an industrial hazard. I'm interested, in other words, in developing a multi-perspective scientific, technological, and public health paradigm that is capable of remaining true to the ambitions and ethos of sexual health that has come before DoxyPEP, even in the face of antimicrobial resistance. Future work on the emergence and integration of DoxyPEP, I would suggest, has much to offer global health projects to control AMR, even if those are being subsumed within these larger global health conversations. This is largely because of the specificity, the expertise, and the localized insights of sexual health practitioners and the ways that we think about innovation within our communities. Innovation, then, as I have attempted to show throughout this very brief conversation, is on the one hand about technologies like DoxyPEP, that we have begun to integrate and repurpose to solve pressing public health problems. But innovation is also about a way of knowing within the world. So as we were talking about very briefly, the Anthropocene and our way that we're thinking about different scales, DoxyPEP helps us to channel this understanding. It creates a new understanding about where humans exist in the world. So humans and their sex and sexuality are not the only thing that matter in relation to AMR. But if you bring those conversations about sexual health and sexuality in relation to animals and planetary health, we begin to think differently about these problems. So, to draw upon Sarah Ahmed, thinking of DoxyPEP in the language of innovation is a way of orienting ideas, affects, and ways of being in the world in order to take very specific notions and actions and positionalities in the world. This action, I suggest, must come from a critical and queer way of knowing the world if we are to ever make sense of the situatedness of DoxyPEP. So, in closing, to critically and creatively make sense of the multiple futures that might potentially emerge from DoxyPEP, we should attend to this type of innovation that's happening and its potential imagined futures to proliferate within whatever types of reorientation of our thinking might occur. I'm especially interested, as a science and technology studies scholar, interested in figuring out, well, how do we repurpose our scientific practices? How do we attend to these technologies in biomedicines in ways that aren't simply for the normative processes? What, in fact, are the ways in which people are experimenting with these, and how can they do them safely rather than simply doing them or not doing them? The futures of DoxyPEP in this instance are unknown, but our desires, pleasures, intimacies, and forms of sexual engagements that emerge through and with its use are not. Okay, that was a lot. Thank you. Look forward to exploring some of this with you, both questions and in the panel. Thank you.
Amazing timing. I hope at least someone in the audience took the opportunity to get your local sexual health advisor sitting in front of the slide and said, "Get fucked raw." First of all, I suppose I'm opening up to, is there any questions from the room? Yes, John.
Thank you, thanks, Chase. That was really thought-provoking. And one of the things I was thinking as you were talking was around I spoke about it yesterday, and there's so much excitement around DoxyPEP right now. I'm kind of questioning where that comes from. And just observationally, that feels like it comes from a lot around stigma related to STIs. And, you know, they're not always simple kind of comparisons. When we think about HIV PrEP, the focus on HIV PrEP in many ways, it's done a lot of good, but also has, I think, pushed back a lot of the anti-stigma work we need to be doing around living with HIV and actually destigmatizing living with HIV. And I think, are we missing a trick around, it's not a big deal if you have an STI, that's just go, get tested, get treated. But there's so much stigma around that, and that's what's driving us too, because I hate a world where people are taking notes like that and not going to see David. You know, that's my fear, is that people will just stop testing because they think they're, I don't know if that's a question.
Yeah, no, I absolutely think that it's a question. I think that it taps into this conversation that HIV scholars and practitioners and health promoters and et cetera, have been having about, well, what happened to the conversation about HIV prevention when HIV PrEP came onto the scene? Because HIV prevention in the 90s and especially in the 90s was very much about how do we create better living conditions for people living with long-term HIV. And then suddenly you're giving biomedicines to people who are not HIV positive, and so suddenly you enter a ginormous population and community of people who never had to deal with stigma, and indeed probably didn't have to deal with stigma other than PrEP-related, the PrEP war stigma, which is wholly different than living with HIV and having the stigma of and life with HIV. So I think that you're right, there is something there. There's something there about HIV stigma and PrEP stigma, maybe not easily mapping on to the fact that DoxyPEP is perhaps ignoring the fact that there are certain forms of stigmatization that are both being amplified. So in one of the papers that I read yesterday or the day before, they had studied people who were HIV positive and using DoxyPEP, and that they felt that the use of DoxyPEP had kind of amplified their understanding of stigma. So if we were to then go and study another population who is not HIV positive, and indeed maybe not gay and perhaps is heterosexual, we might find that their understanding of stigma is wholly different. So I think, yes, the baseline answering your question is that attending to stigma will be a very important way for us to understand both people's reaction to it, their integration of it, and whether or not they perceive it to be effective, because that kind of perceptions of efficacy, whilst maybe not scientific, are a really interesting part of how we understand how and why people consume biomedicines. Thanks, John.
I think that's a really interesting point as well, and one of our fantastic posters that's outside is from Jamie Howe, who's done work on HIV, PrEP and PrEP stigma. And I think it's really interesting that as we're still struggling to understand that years later, and now Doxy or PEP is kind of coming on the scene. You know, we seem to be racing quite quickly, I think. Do we have any questions? Yeah.
Can you hear me now?
Yes.
Far too well. No, thank you for that. That's a really interesting presentation. And I don't really have a question, more about an observation or a kind of provocation. But I mean, when you think about the history of technocratic, I guess, innovation in terms of HIV, from the creation of first treatments on through PEP and PrEP and now things like DoxyPEP, you think about first the development of these things as used by people on the ground and the kinds of innovations, the wonderful transformations that people have brought almost ahead of the science, yeah, in terms of these things. And then a whole range of claims become made around all of these different technologies, such as ending HIV by 2030. I mean, that's the latest in a long range of things. So these are imagined futures in addition to all of these technologies. And of course, one of the things that really characterizes, is almost the characterization of the story of HIV, is disappointment. As in, all of these claims generally are never met. And that is the story of technology. You know, so basically it promises something wonderful, it generally fails to deliver, and then creates a lack or a gap or a space in which more technology must rush in to then promise the next thing. Of course, doing the thing now is never enough. We need to promise something for 20 years' time. It's going to be amazing and more wonderful than anything else. So I guess, of course, that's the first thing that comes to my mind when I see DoxyPEP. It's like, what are the claims? What are the claims that are being made for it? Not just in terms of men themselves or people themselves who are using it, and not just in terms of biotechnology and pharma companies and governments who all have huge interests and massive profits to make from these things. But also then, I suppose, into this community here, this policy community, shall I call it, that kind of amorphous group of activists / policy / NGOs, etc. What are the claims that we would now be making for these things? And I guess what do we do when we're inevitably disappointed? And sorry, that doesn't sound, I don't mean that as pessimistically as it sounds. I just think that's part of the whole deal. Yeah, so it's more of a provocation than a question.
Yeah, no, it's a great provocation. I hope that we can move on to the panel, maybe potentially address that. I think that the negative affect, to use kind of weird, blanky academic terms, is a really important way of living with, as you say, technology. And I think this concept of technological determinism, this idea that we invest a lot of emotions and feelings and obviously resources and energy into the development of new medicines and technologies and things in the world, means that we put a lot of ourselves into these in hopes that they're going to put out, essentially. And when we say technological determinism, we mean that they become reified objects. They become things in the world that we desperately need to work, even though at the end of the day, science proves that they don't work. So the social phenomenon around that is that we still cling on to the hope, even if the object itself is being discarded. And it's interesting to then think about how those things that have been discarded, especially in relation to HIV, have also been repurposed in and through the use of HIV PrEP. And I think that's maybe a conversation for a different time and place, but I think that is a really interesting thing that might come to inform DoxyPEP as well. So yeah, thanks for those provocations. They're very interesting.
Yeah, sort of fits with John Stimpson's question here. This idea of sort of disappointment, I'm interested in this sort of what is maybe some of the underlying reasons why is DoxyPEP become so interesting now. And the cynic in me, certainly in the UK context, is we've seen sexual health funded, defunded to around about 30% less than what it was 10 years ago. And no one's saying it, but I'm thinking it, that we seem to be pushing this as a way for gay men to be responsible for their health. And actually being responsible has become increasingly difficult in the ways that we had before, which were maybe, people actually going and seeing a person. And, I know I'm a nurse, I like people, so maybe I'm from a particular ideological perspective, but if we just give people pills, we're getting the same sorts of critiques that we have with our kind of psychiatric issues. That, you take the pill, it's your responsibility to do well. And I think I'm all for the raw fucking, like, don't get me wrong. But it's about what else it turns gay men into, and also the idea that if gay men become responsible, like, do we then also become responsible for AMR? And like, what does that do to like the gay man as this kind of social object of responsible consumer?
Yeah, I mean, these are really difficult questions that I think also are provocations for us to then think about. No, of course, we can say, no, it isn't an individual or community's responsibility to come to AMR and say, because we're now responsible for taking these medicines, it's our problem to solve. No, we might just have to say at the beginning of this this movement, this wave, whatever this is in the use of DoxyPEP, that we are not the custodians of dealing with AMR. We will contribute to the conversation and to the practices of reducing AMR, but you will not unburden yourself from a global health perspective onto gay, male, queer, lesbian communities who are using DoxyPEP and expect us to do all of this work that historically have forced marginalized populations to do. Indeed, we put our foot down, as we have in the past, and say, no, We will deal with the kind of things that allow us to get by in the world, but we will do no more unless you compensate us or unless you change your systems. In the case of the UK, unless you give us a 30% increase in the kind of sexual health services that we have. Of course, again, that's kind of speculative thinking, but it might be that we have to mobilize those kind of activists and advocates and community-driven interventions in the Doxygen movement in order to make those kind of changes without taking on a whole slew of other types of kind of political work that we absolutely just don't have the capacity to do.
Any other questions? Thank you very much. So unfortunately, we've had apologies from our next speaker, Derek Byrne, from Men's Ages, due to present on intimate partner violence. He's unwell at home today. He is watching, and we hope he is feeling better soon. But if Aoife Dillon is here, I'm going to ask her to come up next.
Hello everyone, I am a gerontology advanced nurse practitioner, so this is not a conference I had ever envisioned myself attending, but I am so delighted to be here to speak, and thank you very much. And I'm just going to talk about how we're trying to make change in older person services in St James's Hospital. It's a slow process, but it's something we're trying to do. So how it all started. So back in 2017 I was doing my Masters, and I was invited to go to the Netherlands on an Erasmus programme, just to a workshop which is looking at delivering undergraduate education around LGBT young persons issues with Professor Agnes Higgins. And we spent 3 days in the Netherlands listening to older people from 5 countries talk about their experiences of healthcare, growing up as an adult but also as an older person. And I must say it was a very traumatic experience because they had horrific experiences of healthcare throughout their lives. Everyone in the room was an academic, and I was there as the token clinician because they had funding to bring one, so I had to get up and apologise on behalf of all of healthcare. So that was quite tough. And there I met Eddie, and Eddie was one of the speakers from Ireland, and he spoke about his life and, you know, being a gay man, being married to a woman initially and having children, and his experiences in care in Ireland. And Eddie changed my life because you cannot hear a patient's story about negativity, discrimination and his experience and not want to do something about it. So he changed my life, and he does work with advocacy with LGBT Ireland, and he's an amazingly brave man who puts himself out there to try and make things better for everybody else. So I came back to the Netherlands, my husband told me like a demon, because I was really disappointed in healthcare, but I was so disappointed in myself. I spent the last 20 years nursing older people in St James's Hospital, and I would have considered myself a holistic, inclusive practitioner. But I was discriminating by omission, because I was not considering a whole cohort of people in my care. So by not considering LGBT plus people in my care, I felt like I was discriminating against them. We weren't making our services welcome for them, and I wanted to change things. But I came back and I didn't know what to do. I'd never received education around LGBT issues in my nursing undergraduate training. We'd never talked about LGBT plus older people in all the years I've been in older person's care. So I had no idea where to go. So thankfully I went to LGBT Ireland, who are another group of people who have definitely changed my life. And you can't work or sit with those in LGBT Ireland without leaving and wanting to make the world a better place. They're an inspiring group of people. So they helped me. They run a Champions training program. So this is a program for everybody working in health and social care who work with older people. So anyone who wants to make the lives of LGBT plus older people better, LGBT Ireland Champions program is definitely something for you. They talk about the history, the stigma, the discrimination, and the issues facing older people specifically. As I said, I was doing my Masters at the time when I went to the Netherlands, and I was doing it on osteoporosis. I had to come home and put it in the bin and start again and tell my supervisor that we weren't doing what I thought I was doing, and I needed to look at LGBT older people. So the lit review that I did for that piece of work then really educated me. Because I wanted to bring about change in St James's Hospital and hopefully in older person services as a whole, I realised that I needed to educate myself. I couldn't start this without knowing what I was talking about. So the literature review I did around that piece really helped to educate me in what I need to do to change my practice. So we know internationally and nationally that older LGBT people are an invisible marginalised group. So they're invisible in healthcare, they feel invisible within the LGBT plus community, and they're definitely invisible in healthcare. And they're really concerned about their invisibility in healthcare. When you talk to older people, they want to make change, but that want to make change is really complicated around their fears of discrimination if they come out. And older LGBT adults then experience profound stress when trying to access health and social care because they tell us that they can't vet us. They don't know who's friendly, they don't know who's inclusive. There's no way for them to find out, are we the people that they can go to? And it's exhausting for them. They also tend to need more healthcare going forward. So they access healthcare less, they access health promotion services less, but they tend to need healthcare as they grow older more. They need greater assistance with their activities of daily living. They have huge relocation stress around going to long-term care or needing care at home. When you talk to older people, older LGBT plus people, they tell you that long-term care is their least preferred option. They feel like it's really not for them, they're going to be discriminated against, and it is a definite last resort. When we try to explain that there are laws that focus on discrimination, that they will protect them, but actually do they protect them from discrimination? And they don't. We know that there's heteronormative assumptions across all of healthcare, and particularly in gerontology, because we don't talk about sexuality at all, no matter who you are. You know, once you get over a certain age, that's it, you must be asexual, we don't talk about it. So there's heteronormative assumptions we all know in this room, in language and health literature. We all have an unintentional bias by not using inclusive language or representing LGBT plus people in our healthcare services. We are showing an intentional bias. And we know that this has a negative impact on people. All the admission forms, the information, the leaflets, posters, everything we see in healthcare all has a heteronormative lens on it. We don't see LGBT plus people in usual health promotion, and we definitely don't see older people. Because, as I said, sexuality is completely ignored. And we don't consider LGBT plus older people in any of our policies or guidelines. They're not mentioned. Home care staff don't receive training around LGBTQ adults, so these people feel they cannot attend this healthcare, that they won't be safe bringing these carers into their home. So all of this does have huge implications for healthcare, but we can't fix it all. But we do really need to have an understanding of the health and service needs of older LGBT people, and it's really critical that we do. To meet the HSE and National Clinical Programme for Older People goals of people getting the right care in the right place, and for including patients in the design and provision of care, we need to include older LGBT people. We have a duty of care to this population, and we must consider them. And the thing is, education and training is required for all of us in healthcare. A lot of us, when we talk to healthcare professionals, when we realise that we're not actively or intentionally discriminating against people, but we don't have the education and the skills around it. And when we explain to people why it matters, we all want to help, we all want to change our practice. The majority of discrimination that happens doesn't come from a place of malice, it comes from a place of ignorance. And we can't change without education and training. And research and publications relating to the needs of older LGBTQ plus people really needs to be made a priority so that we can make health and social care services inclusive for everyone. But I don't have that, influence everywhere. I only can influence where I work. So I decided to try and do this in St. James's Hospital. So we decided in older person services to come out. And we said we don't want our patients to have to come out, we will come out as inclusive providers. And I didn't know where to begin. I'm very lucky that my manager, Cara, who's actually here, is a very sensible, calm person. I came back crazy going, I can't not know this, I need to make change. And she just breathe, it's okay, we will change it. So Cara went and did the training program as well, because we more than just the two of us were going to tackle this. So we came out in 2019 as an inclusive service, and we had a stand in the main concourse of the hospital to talk to staff around older LGBTQ plus people and why their needs and the barriers they face accessing healthcare matter. And the majority of healthcare professionals say what everyone says is, why does it matter? Why does sexuality matter? Why does gender identity matter? And it's just, we don't understand as a group of people. And to try and explain to it why it matters to patients that we're an inclusive, safe service, and why it still matters to people who are older. It is like a little light bulb goes off that people think, I didn't know it was important. I didn't know that older LGBTQ plus people were more likely to need care, that they don't have the same resources as heterosexual older people, that they're going to need healthcare and our support more. And once people know this, they want to make a difference in their service, they want to change. So we developed an education program. This is just some of the pictures from one of the first workshops that we did. And what we focus on in the education program is the history of LGBT rights in Ireland first, because the staff to understand why it matters and why older LGBT plus people have a difficulty accessing healthcare is to understand the history of rights in Ireland. If you consider that homosexuality was only made no longer a criminal offence in 1993, and you look at the cohort of patients I nursed, so everybody in their 70s, their 80s and their 90s spent the majority of their life under the label of criminality, so their very being was illegal. And it's just to explain that to staff, why that is their reality. The marriage referendum and everything that came after, people say everything is fine now, we've nothing to worry about. And that's definitely not true, we know that. But for older people, they felt like they were completely unincluded in that they were missed, that they weren't talked about, especially older people who don't feel safe and out. You feel like the whole movement missed them and that they're still not thought about. So we need to teach the history of LGBT rights in Ireland for the healthcare professionals to understand why it matters. And then we also go through the lingo, because everybody's terrified of language, about making mistakes. And we just go through how easy it is actually to change your practice and that how much language matters. So instead of asking about the husband or the wife, asking about support network, who people have at home, using pronouns correctly, using them ourselves so people know that we're a safe person to talk to. And then we go through the specific barriers and challenges that older LGBTQ plus people have and their health needs as well. So when we talk to older LGBT people, they're really worried about needing home care. They're worried about their home being invaded by healthcare professionals who aren't inclusive. So that's their fear. They won't ask for help. Their safe space and where they truly can be themselves is in their own home, and they're terrified of letting us in, or going to a long-term care facility that's not inclusive. They're also, when you talk to people who have HIV, are terrified of getting dementia. They have looked after their medication all their lives, whether they're prescribed years ago or now. A lot of them, older people, haven't disclosed to anyone that they're HIV positive. And they're really afraid of this forced disclosure if they get dementia, because they will no longer be able to manage their medication, someone else will have to do it. And then they have the stigma of HIV and the stigma of being a member of the LGBT community. And they might not have told anybody. So this double forced disclosure, they feel it's coming upon them. So we really need to educate healthcare professionals so that they can be inclusive and that people can feel safe in our service. And we need gerontology to be ready. It's funny, geriatric services are not ready, I don't believe, for transgender people growing older and people growing older living with HIV. And they're afraid that it's coming. And they cannot no longer put their head in the sand. We really need to prepare ourselves to serve these patients correctly so that they're safe in our service, so they can transition from sexual health services into geriatric services so we can help them as they grow older with all the things that we are experts in, frailty, dementia, all that stuff, so that we can be an inclusive, safe place so that they want to come and see us. These are some of the staff thoughts who have done our programme and what they feel afterwards. So I don't know how easy it is to read them. So watching the videos was heartbreaking. So Eddie, who I mentioned changed my life, talks about his experiences of psychiatric care after he came out and how negative it was for him. So the videos aren't quite difficult to watch. It has opened my mind to how people feel inside. I won't forget this. Hope, the beginning of positive change. As a champion now, I feel we need to engage with other disciplines to encourage them all to do a course. We want everybody, this is just the older person's directive that we're looking at. The whole hospital needs to do training and education because older people are one of the largest consumers of healthcare. So no matter where you work, you will meet them. So everybody needs to be prepared. The middle one there, I never thought about how a transgender person is afraid to talk to a healthcare professional. I didn't realise how the questions would make people more comfortable. Didn't realise how naive I am and privileged being heterosexual. And that's a huge piece about being an ally, is we are coming from a massive place of privilege and we need to use that to stand up and talk on behalf of our LGBTQ plus patients because they're afraid to do so. The use of my language and terminology. So people learn a huge amount around language and terminology in the course that we do. And then after that, it's to stand with and to stand up for patients in the LGBT plus community. So we're not just educating people so that they go off and do nothing about it. Once they have that knowledge, we hope that they become activists and advocates where they work as well. Excellent workshop. Learned a lot. Work coming in on my day off, which is always nice to hear. If it's work coming in on your day off, you must be doing something right. And it was actually someone from the LGBTQ plus community did the course and told us that they didn't want to be there because they're from the LGBT community. They didn't have to be there, they do know everything. And their manager forced them to go on the course with us. And afterwards, they'd say they had never considered older people. They had never considered how older people were marginalised. Those within the closet are still there and feel that they can't come out. Or that those who are out and proud, as they age, worry about going back in the closet when it comes to long-term care and getting home care services. So it was good to hear that we had opened their eyes to the plight of older people. This workshop is amazing, should be made part of training for all staff. Thank you for being champions, it's inspiring. So we didn't get any negative response. I didn't not put them up there. There wasn't. One of the ones that I always remember is we do it, obviously we focus on all the people within our directorate, but we get requests from the rest of the hospital to talk to the people, and we spoke to people in cancer care. And there was a nurse working there who is a black African woman and stood up and told us that where she's from, the punishment for being in the LGBT community is prison or death. And that's her culture and what she grew up with. But she said at the end of the training, at the end of the workshop that she did, not only would she go on and be an advocate for the patients that she sees in cancer care, she's going home to her community where she lives to advocate for LGBT patients, to advocate for the community, which is a great thing to do, thinking about where she's from. But I'm reminded by that story every time only 2 people show up to training, and I'm disappointed that we don't have a full room, that it does matter that everyone we speak to, it matters. This is just an example of the need for visibility. So as older people tell us that they can't vet services, they don't know who's friendly or not. Myself and Cara talk all the time about how much visibility matters, that we want to be an inclusive place in the older person services and James's. So when we have helpline numbers up or signs up, LGBT Ireland is there in the information that we have. Older people are on it, we wear lanyards, everyone was welcome signs, and that's, we project it into the Mercer's Institute for Successful Aging. We show the rainbow flag and not just at Pride, all year round, so that people know they're welcome. And because of all the stuff that we've been doing, we do our work in St. James's, but we get to do it outside of that. So it's really important that we get this word across to gerontology and older person services everywhere. So I've had the opportunity to speak at an International Advanced Practice Conference. This is a poster we did for the Irish Gerontological Society, again, where this topic wouldn't necessarily be covered before. So we get to open up this conversation with people working nationally and internationally with older people. And then we get invited to do some fun stuff as well for students of the future. So these are the Trinity College medical students. And they asked me to help them launch their rainbow badge. They wanted to be part of the HSE rainbow badge program so they could show that they were advocates and inclusive to the patients. And of course I was delighted to help, but I made sure that I got to speak about older people, that they weren't just talking about the rainbow badge, and we talked about all LGBTQ plus issues, but we focused a session on older people because again, they're forgotten about, they're marginalised. And these student doctors are the future of healthcare. And no matter where they go and what specialty they work in, almost no matter what specialty, they will meet older people. We want them to consider them and be inclusive of them. Now this is Pride, and Pride matters. Obviously St. James's staff have marched in Pride with HIV Ireland for a long time, but the rest of us had never marched. It was something we'd never done. Myself and Cara felt it was really important that we marched in Pride and that we marched with a banner that said St. James's Hospital, because there's never normally a banner involved. So we felt it was really important for our patients to see us there, to see the St. James's banner, and for our staff to see it as well, so they felt included and inclusive. And the 2 littlest allies at the front. It just shows you that, allyship doesn't just, when you start it starts where you work, but it permeates into all aspects of your life. You can't just be an ally where you work and stop there. It comes in, it becomes involved in everything. So in everything I do, I try to be an advocate. But also the 2 little people will hopefully one day grow up to be older people. So all of us want to live long and successful lives, and we should all want to grow older. And I as a gerontology nurse, think that Ireland should become one of the best places in the world to grow old. But to do that, it must be one of the best places in the world to grow old for all older people. And that's me.
Questions for Eva? Yes.
Hi Eva, thank you very much, that was very inspiring. My name's Matt and I'm a doctor working in geriatrics in rural Ireland. What would be your take-home message for me to help improve my practice for my older queer patients?
Well, it's to get education and training if you haven't had any. Because I think as healthcare workers, we love stats and figures and statistics, and we need to know where the patient's coming from. It needs to be concrete. Especially if it's not coming from a personal place. But I think education and training is needed, and that whole thing about changing our language so that when we talk to patients, like I work in Dublin 8, we're very conversational, very informal. I would have said if there was a man, a male patient with me, and he was married, when I was a staff nurse, I might have said, "How's the wife at home?" Because that's the assumption that was made. But just that little "how's the wife" shuts down the whole conversation with someone because I've made an assumption, and it's about all of you people in the room, especially working in sexual health, you know, you're used to all this inclusive language, and for us in gerontology it was new. It is really that simple about changing our language and asking someone, do they have a partner or a family at home? And the visibility of signs. When I did training with LGBT Ireland, we got this tiny little pin that I wear in my uniform, and I gave out to them and said it was too small that nobody would see it, but they said it doesn't need for the people who need to see it will see it. So the importance of visibility and symbols. But with that comes responsibility. We did lots of training in the hospital, and people who wanted a rainbow lanyard got one, but they had to understand why they were getting a rainbow lanyard. I did have one nurse ask me for a colourful lanyard, and I asked her why she wanted it. She didn't know because she wanted it because it was nice, and I explained to her what the rainbow lanyard meant, and then she told me she no longer wanted one. which is her choice to make. Obviously, we can't discriminate at work, but it's to understand that, you know, symbols and signs matter so that our patients can see them. But with them comes responsibility that we have to be trained and educated to help that person should they need our help. You know?
Thank you.
Thank you so much for the talk. What are your thoughts on queer, LGBTQ plus inclusive nursing homes?
I would hope that everywhere, the whole point I think would be that everywhere should be inclusive, and then that's something I really want to work on is looking at long-term care settings in Ireland and then becoming inclusive for all. We need to find out what other people want, and we need to ask them, you know, what do they want from services, because it depends on who you talk to. Some people have been out and proud all their lives and have grown up surrounded by the rainbow community and would talk about wanting to go into you know, an LGBTQ plus only nursing home. And others don't want that. They want it to be mainstream. They want to be with everybody else. And my fear is, if like, you need specific services when other services don't exist. But if we build a gay nursing home, it will be in Dublin, and that's it. We'll have one place. And then why are other people all over the country expected to move from where they've grown up to go to the one centre that's safe for them? The object should be to make every single older person setting inclusive and safe.
Any other questions? Great, Eva, thank you so much. I am now going to invite our expert panel, so everyone who is on the expert panel. We have Dr. Bonnie Courtney, Dr. Maurice Mackington, Dr. Jay Seddon, Adam Shanley, Dr. John Gilmore, and Kieran Mulcahy Lennon. And just everyone else has been introduced previously in the day, but just to let you know, Dr. Bonnie Courtney is a consultant in HIV and genital urinary medicine at St. James's and the Gay Men's Health Service. She trained in Trinity College Dublin and Federated Dublin Hospitals and the Royal Hospital, the Royal London Hospital in Whitechapel in general medicine, gender medicine, and HIV. Thank you so much. So, I suppose the first question I wanted to ask was to our two keynote speakers. You've kind of gotten a taste of sexual health and LGBT health in Ireland through the various presentations today. What are you taking away? What do you think the state of the situation is here?
I think there's some really interesting things that the fact that you've got countrywide services, I think was really interesting. I think it's one of the things we really lack in the UK, or at least even in just England. I'm guessing even in just Scotland. And I think it makes it. There is a kind of national HIV testing service in, I think, just England. But I think that makes communication about things quite a lot easier, as long as you've got your messaging right. I think the kind of innovations around online PrEP, I know there's a trial literally in the kind of very initial stages in the UK for online PrEP, but it definitely opens up the possibilities for a lot of, you know, for a kind of cohort of people who don't want to or can't, or just for whatever reasons don't attend sexual health clinics. So I think there's some really interesting, innovative things that are kind of starting to happen here that it's been really interesting to hear sort of the scene itself.
Yeah, I would pick up on that idea that like the kind of the synergies that are happening between community organisations and clinics and public health bodies and this kind of stuff, whilst this is also happening in the UK, it seems to be slightly more cohesive, and that might just be because it's a smaller population relative to the UK. But like especially from my context of Scotland, where I do most of my work, these bodies, whilst existing doing work and organisations and activist groups and this kind of stuff, aren't talking to one another. So coming into this room and hearing about all the amazing work that you're doing from Empower and to clinics and all this kind of stuff is just like, well, there are people in my communities in Scotland doing this, but like they're not coming into rooms like this and having these conversations and saying, oh, like here's how we can mobilize together and do this kind of work. So for me, like this is huge. First of all, a generative space, and then second of all, it's very empowering for me to see that there are other places in the world that we could potentially adapt those laws. I know like England obviously gets most of the resources for sexual health. Not much. Yeah, but like even then, like this is just kind of something that we could then begin to try and integrate into our understanding of slightly, if there is such thing as a unified model of sexual health in the UK, which there isn't, could be thinking about that.
Yeah, I mean, I think the opening address by, sorry, I can't remember her name, the minister, that actually reminded me of something that we had in the UK over 10 years ago with Public Health England, which has now been disbanded. And there was that ability to bring everyone together into the room, and we've lost a lot of that infrastructure because Public Health England no longer exists. A lot of the charities don't have the time, money, or the funding. A lot of local authorities just don't have the time, money, or funding. So yeah, keep what you've got here. Like it's just being in this room and having all these charities and professionals, and it reminded me of that earlier. And that's really important, because then when you get things like MPOX, you have those things, pre-existing relationships. And one of the problems with the UK response to that was nobody knew who each other was. And it made it a lot harder to respond. And we were faced with a government that was maybe not terribly interested and just wanted to do the minimum. But also we didn't have those networks between charities, between clinicians, so yeah, it's that idea of infrastructure, I think this is clearly really important.
Speaking of Minister Naughton, who opened the day, she spoke about moving services for trans people towards sexual health services, and I was hoping to hear what your thoughts were from you as a consultant in GE medicine.
Yeah, I think things are really difficult for trans people, because the one gender clinic, the waiting lists are so long. So I suppose it is something that we could look. We certainly see trans people obviously in the sexual health service, not for hormone prescription. It's a really complex area, but I don't see why we couldn't be resourced to do it. It would I'd say take additional significant resources, but it seems like a good fit.
Yeah, I think resources and training, because I don't think it's maybe an assumption that we can provide that care.
Not just like when I say resources, I mean training. Yeah, yeah.
But we've seen that model work quite well in the UK, and is it Clinic Q in Dean Street? So it seems like a really natural fit. So hopefully we will be able to transition towards that. And Ciara, I was going to ask you, I suppose, as a clinical nurse specialist in sexual health, the question does often come up specifically about like cis queer women and about how they don't feature in sexual health services a lot of the time. And I remember hearing repeatedly at days like this and at lectures that, queer women disproportionately unaffected by STIs, they don't need to come to the services. We don't like. What's your thought on that?
I actually had this conversation with somebody on the break, and very interestingly, our identities don't always match up with our behaviours. So one of the things that we found in the literature review of that of the screening report was that on average, lesbian identified women have more male sexual partners than cis heterosexual identified women. So I sent that back twice because I was indignant and I presumed it was a typo. It wasn't. So what I would say is that identities and behaviours aren't always cohesive, or coherent rather. And also that is something that's been, I'm with Think 5 years now, and it's been incredibly frustrating. When you look for resources, you look for information in an Irish context when it simply does not exist. One of the ways we've answered that, specifically around resources for
sexual health for LGBTQ women is that we've created them. So we partnered up with the Crisis Pregnancy Agency and with the Sexual Health Centre in Cork, and we made it. If something isn't there, we need it. Or if there's research that's not there, we have questions that are unanswered or gaps or health disparities, we've gone about searching for that. So now it does exist. It's online, or you can get it in print form. We also have QR codes, and it's sexual health and wellbeing for LGBTQ women. Last year is trans and be inclusive. And then likewise with the conference that we're having in September, it doesn't exist. We can't find it anywhere else in Europe. So what I would say is, if what you're looking for isn't there, do something about it.
And absolutely, and I've seen that resource, and I've used that resource in clinics because, I suppose, I'm a nurse who's predominantly worked with gay and bisexual men, and cis men at that. So suddenly when questions come up that I don't know the answer to, being able to reach for a resource like that is invaluable.
And just to say as well, also, it's very important what we've seen predominantly for lesbian, bisexual and queer women is how to make a dental dam. And one of the problems is we talk about sexual health barriers as, making sex safe, and you need to check in with the communities, but community-led is so important. There's no point in telling people to use something they're simply not going to use. What you need to do is look at safer sex practices and educate people on those. We had a sexual health event recently, and I'll say this really fast. And it was kind of marrying together sexual health advice and support with a night out, and there was goodie bags, and in the goodie bags were dental dams, and just hilarity ensued about what actually happened with those dental dams. And I had a couple of people ask me, what are they? And realistically, it's great to have them, and I as the community health worker for a lesbian and bisexual organisation, I absolutely promote them. But what we need to look at is how do we make realistic, safer sexual choices, and that's what types of sex are risky, and not divorcing not divorcing behaviours and identities and treating them as two different things, because what you do in a night out or what you do in the privacy of your own home doesn't always match up to how you identify in public. So
absolutely, I mean, it's really, about the dental dams in particular, it's really interesting to think, where are these interventions coming from? If the community's not asking for them, professionals are kind of, it's important, like you say, to have that dialogue to say,
we absolutely are promoting them, but I think there's a hierarchy.
To be clear. Perfect. So I hope we've heard a lot today about specialist LGBTQ services, and it got me thinking, what about having specialist services versus general services that provide specialist care? And I suppose we're quite a small country, and more than Aoife talking about having the one, nursing home care facility in Dublin. What are your thoughts on, I might start with you, Adam, about that kind of the divergence of specialised services and general services providing specialist care?
Yeah, I think it's really interesting. I think what kind of comes to mind first off is meeting people where they're at and creating choice for people. I think one of the things that we've recognised through our work at Empower is that you'll have people who have thought that our rapid HIV testing in bars and clubs is a great idea, and they'll constantly use that as their way to check for HIV. And others are still, clutching their pearls at the idea of someone learning their HIV status, in panty bar. But we know that the person clutching the pearls might feel much more comfortable in front of any of the people here that are offering services. And I guess that's probably, the best approach in my opinion, is that we best understand what the needs are for our community, and we devise them appropriately, whether they be clinical or within the community. So I think choice is really the main answer to that. And I think what Aoife had mentioned earlier about, when we do, if there was the development of a queer-only nursing home, you then come up with the barriers of, geographical barriers are very obvious from that. So while choice is really important, we also have to think maybe beyond that choice might have a limit, and we have to consider it too.
And John, I might ask you to come in there as well, just so that this was all of your PhD work.
Yeah, I think that's the key point. Is people should have a range of opportunities to engage and access healthcare and help emotion in ways that are appropriate to them and suitable for them. But there is that. I was thinking, it came up in the Doxy event yesterday. It's come up a few times. It came up a challenge, I think, prescribers at SSS2DI last year around when we talk a lot about
with Morris were the crisis in chemsex. What are we going to do with all these people who are having these issues and we have no service? So you're a prescriber, you're a clinician, you go and do, I know it's not as readily accessible, but go and do some training, go and do some learning. That's what I teach my students. If you don't know something, you have a patient there, they have a need, it's your obligation to find something, and sometimes that's you. So I think, you know, rather than saying that we constantly have to develop a special service, that's what's happening in Ireland. I'm not going to beat around the bush and you know, start with maybe controversial. You know, our National Gender Service is not providing evidence-based care and word practice around evidence-based transgender healthcare. They're making that decision, the clinical staff and leadership are making that decision, and they may have their reasons for that. But, you know, I don't feel as a clinician that I'm okay then, like, waiting for somebody to meet that need if I'm seeing the need. So I think there is need for all of us who work in healthcare to be advocating, to be agitating, but also to be reflecting on our own practice to meet the needs of people we're meeting. And not everybody would agree with that, but when I was in the States, I saw very brave healthcare providers. Different contexts, I get that. But, you know, LA LGBT Centre, Strut, so Strut, Sexual Health Service, gay men, that's what they did. They expanded to people of all genders. They realised that trans people, accessing them, their real need was around their hormones. What did they start doing? The nurse providers there trained themselves up or got training. They now provide gender affirming therapy in their service as part of sexual health service. They provide care for people around sexual function. They provide psychosexual care. Not, you know, this was not within their scope or their role. They expanded that because the need was there from the community, and we need to be responsive to the needs of the community.
And it's interesting because I think, like, the Gay Men's Health Service was born out of that exact kind of sentiment. It was a need that was identified by the community at the time, and, you know, McQuinlan and others, leaders in the community at the time, really pushed for it. What do you think the reasoning is now that we're seeing less of that? Is there like a defensive practice element? Is there a...
I don't know. I don't know. I can't answer that.
Just maybe about why we've seen a decrease in the, I suppose, the energy or momentum to, I suppose, try and transgress those boundaries, maybe.
This is something I've said before. You know, we had the global health pandemic, the emerge report. One of the things that happened over that, I'm also a member of ACT UP Dublin to do my declarations, and we had the GMHS closed essentially for 2 years, by and large, not see people. I don't believe that if that was a community-led organisation, a community-centred organisation, with gay men, bi men, and the trans community involved in the governance of that organisation, it would have stopped seeing more patients for that prolonged period of time. I think if the governance of that organisation, because the governance is held in the statutory organisation and the health services sector, so if you're a clinician working with it, you have to do your basic stuff, you have to go contract rates, you have to go and so on. But actually, if it's a community organisation, we saw community organisations like around the country, like Empower, like others around the country, step up and try to do their best. So I do think there's a place for community-led healthcare as well. Primary care did not come from statutory organisations giving care to communities. It came from communities caring for each other. Then doctors and nurses and all of the wonderful people came on board, and we took a lot of power out of communities, brought them into our organisations, and hopefully in our new kind of way of thinking around primary care, we can bring a lot of that power back into communities to care for themselves with our expertise in care and knowledge.
Absolutely, I think that's really interesting. It's just me and John have to get free. But no, I do think that you do make a point, but I do also think that I suppose the GMHS is a very community-centred, but maybe not led organisation. You know. So what else I want to ask you about? Chemsex is featured a lot in today's presentations, and so we hear about harm reduction approaches to chemsex. And I wanted to maybe tease out a little bit, where it's just around, like, harm reduction is generally a very individualized approach. But what might the impacts of harm reduction be at a population level, or like, do those two things, are they conflicting with each other? Like harm reduction approaches versus maybe community harm reduction. I suppose community harm reduction meaning maybe like the decrease in general chemsex use.
Yeah, I think it's really, I think it's very tempting. Well, I'll maybe start with kind of a top level thing. There was a point maybe about 6, 7 years, I think it was when Theresa May was Prime Minister of the UK, and she said, I think I'm quoting word for word, it's not the government's job to make safe what is made illegal. And I think there has been really, the past 10 years or so, a really difficult structural way for people to do harm reduction stuff, within an ideology that the only harm reduction they want to see is not really harm reduction, but reduction of the use of the thing that they've made illegal. So I think some of those problems start becoming, well, how are we measuring harm reduction? And how does a government acknowledge that? And the fact is, a lot of the organisations doing that work receive a lot of money from government, and I won't name them because it's not that necessarily, but there's a charity that I have a lot of respect for in the UK, and they've kept going through thick and thin, and they do a lot of advocacy work, but they will not come out and criticise some of the issues that are very prevalent, blindingly, obviously prevalent, with graphs that go like that for sexual, in the wrong direction, for lots of outcomes. And they won't make that criticism because their paymasters are, they have to present their service in particular ways. So maybe it goes back to that point which has been made about kind of community-ledness, that how are we either being controlled by the terms of reference, or are we managing to take hold of them a little bit as a community? What does harm reduction mean to us as a community? And are we allowed to operationalise that in a way that we can actually make use of it? Can we get money for people who use drugs in a different way? And I think there's a real problem in the UK at the moment, because a lot of the monies are directed at getting people off drugs and abstinence approaches. There's not much money in things like safe injecting techniques, which 20 years ago was there. Very much so was there. I remember being in front of people being taught it, but the money dropped out the bottom for a lot of that stuff. So yeah, a lot of it I think is tied to ideology. Does that even answer your question?
No, it does. But I might ask them. Contribute as well on that point.
Yeah, it's been a really long road for the very same reasons. It's been very, very difficult to get support to produce truly harm reduction materials. I think Graham mentioned it earlier this morning, after the 2015 Gay Health Forum, we called a meeting to talk about chemsex and start a conversation about chemsex. And we were able to get some kind of seed funding to run, knowledge workshops and some kind of education and training. We had a chemsex working group, which was a kind of a collaboration between HSE addiction, HSE sexual health, and community organisations, and everybody was coming at it from a very different perspective, and largely speaking, it ended up watering down anything that we could possibly do. But this is the way our community talks about sex and drug taking, and you're uncomfortable with that, but this resource isn't for you. You're just funding it, and the purpose is so that we can get it to people that need it. And that difficulty, that's tug of war, can't be won unless everybody's on the same page. And it resulted in a breakdown of that working group, and ultimately the community suffering from a lack of resources in that space. We've gone on that journey continuously because the need has been demonstrated to be there, and I'm happy to say that HSE Sexual Health and Crisis Pregnancy Programme are very, very much on board, and they very much get it, and we're now in a position where there's an understanding that that does need to be community led with the community language, and truly dealing with a harm reduction approach, and that will still make sectors of both our health service and our government uncomfortable. But that's not for us to be concerned about. Our concern is to make sure that we develop those resources that will be useful, and to reduce harm, and not supply reduction or abstinence isn't that's not our side of the house. Someone else can deal with that. But it has been a long road, and as I kind of ended my presentation presentation on is that, you know, Andrew started last year, and we are hopeful that we'll be able to launch, but there are still kinks in the road, there's still a little bit of ironing out to do with some decision makers, but we'll get there, and we're determined. But it is a tug of war, and I think allowing community to lead, that we've seen throughout today, results in really positive outcomes.
And Gordon, I would just ask you, I suppose, from a clinical perspective, how has chemsex changed the scene in the clinics that you were running?
So, I guess if I was really honest, I prefer to be seeing much more of it than I am, because people who come to the clinic, it's a daytime clinic, or we have an evening clinic as well, but they tend to be better organised. I think if you're strung out or you've got difficulty getting to us. So we would really want to, and I sort of urge people, you know, we have an urgent referral service. We do the best we can to make it happen for people if they need to be seen. We want to see them, but we're not seeing them. So I'd say I'm seeing very few.
I think that just jump back in there. You just reminded me of a charity that I'm working with in Manchester, and they have great links with the community they serve, the female sex workers, and they really, you know, they know when these people turn up, they know how to engage with them, and they have very long-standing relationships with them, they know their lives very well, but they can't provide the services because of the way the contracts work. So it's those people are going for services. So unfortunately, the way the commissioning works, they can't do what they need for, even though it's highly good is what they do need, and technically it's not that difficult for the lower level stuff. So yeah.
And then I suppose, speaking of maybe populations or communities that are more difficult to reach, I think we haven't heard anything with sex workers specifically today. And Ciara, I was going to ask you, I suppose, again, coming from like a cis female or non-binary perspective, like, have you seen much work around like female sex workers?
I think what's becoming part of the conversation now is more OnlyFans, and we're seeing like social media platforms being used in that way. I wouldn't say it's a massive part of the conversation just yet, but it is beginning, and we did discuss possibly putting on a talk or a workshop over the conference, but I think that organisationally you sort of have to have a stance or a position, which we haven't arrived at yet. But I do see the conversation emerging a lot more around, particularly around online sex work. And at an event during Cork Pride, I won't mention the event, but I know that feedback came to the organisation through the community around very overt sex work happening, or offers of sex work happening at that event. So it definitely is becoming more prevalent, and it's in our orbit, but I wouldn't say it's a regular part of the conversation.
And it's funny that you say that, as I suppose, and speaking about sexual health futures and how things are evolving. My previous role as a clinical nurse specialist, and one of the questions that I would regularly asked is, in the last 12 months, have you provided or received any payment for sex? And one day I had someone that said, oh, well, I do OnlyFans, and then we were both kind of like, oh, we were not sure, like what's this? So it is like in time that we start thinking about those type of OnlyFans and creators as well.
And I think there is a bleed between the two words as well that's probably not acknowledged yet, where sex work is, emerging for people on those platforms, but it's actually becoming more like, in-person sex work is sort of sometimes the next step, and that's something that we've heard about as well, is that it's kind of a gateway, and can be sometimes, and just to say I'm not taking a position on it, just this is part of the conversation that we're having.
I suppose come back to the big ticket topic of Doxy PEP. I wanted to kind of flip the script a little bit today, and I suppose we always play out these roles of clinicians, I suppose warning about things like antimicrobial resistance and the potential downsides to that intervention. But I wanted to ask maybe, Grania, what you felt the positives that are coming down the line of potentially introducing this intervention for Ireland are, and then I wanted to ask one or two maybe the other contributors what the fears from the community perspectives might be.
So the results of the studies look really good. The study from San Francisco and the IPRDA, with a 2/3 reduction in chlamydia, syphilis, and some reduction in gonorrhea. There's some worries about antimicrobial resistance. I suppose what I worry about is I see some patients now who just access sexual health online and they never come to a clinic and they come in. So, and in terms of sexual health futures, what are we promising and can we deliver? If you think about one of the interventions that really delivers is HPV vaccine. So I saw somebody during the week who had been out for years, never accessed any sexual health service other than STI online, so hadn't had hepatitis A and B vaccine, hadn't had HPV vaccine. We really need to think about that. And in the context of DoxyPrep, I think DoxyPrep is going to come. I think we need, the BASH stance at the moment is that we need more research, that, you know, but we still need to look at our cohort and say there probably are people accessing DoxyPrep at the moment, and we need to start asking people who are coming into the clinic, are you accessing DoxyPrep? But I think we need to think about those people out there who never meet a person because they don't want to meet a person, because they want to do their sex in private, and that's what everybody wants to do. You know, that's what we all want to do. But we need to think about those people that are missing out on services.
Yeah, absolutely. And then I might come to Adam and then to Chase, just sort of maybe from community perspectives, what are some of the fears or some of the barriers that you see there? Like, you know.
Yeah, I mean, I think really we don't know. We haven't really had, this is probably one of the first community conversations we've had about DoxyPrep. And that's great, but it's also a bit of a problem because people are using DoxyPrep. We're a really internationally connected community. And once there was talk of Doxy being effective against STIs 3, 4, 5 years ago, because we are such an internationally connected community, you'll have like early adopters as well as a community too. And so I think there are a lot of people that are using, or there are people using DoxyPrep in our community here, and I don't think we don't have anything really to for me to kind of answer that question, you know. But I think it offers a lot to the community. I think, you know, I think Chase's talk was really interesting, and for us to dig down a little bit more into, you know, constantly biomedical interventions in terms of how we navigate our sexual health. But you know, I think there will be a lot of people that are really sick of STIs that have maybe perhaps from being liberated through the U equals U message and from being able to access PrEP. You know, that fear and concern around sex has melted away somewhat, and so people have had opportunities to enjoy the sex that they want a lot more over the last number of years. But with that, a consequence being an increase in STIs. So there's a positive in that there's more opportunity for us to maintain on that road of pleasure. But you know, conversations around AMR and you know, microbiome and all those other pieces that we need to consider. We need to have those conversations, and we need to ask those questions so we have a better picture of it, so we can move forward.
Is that the next Empower?
That's the
and Chase, I might just let you finish up that.
Sure, yeah. So I guess I'm gonna think through Scotland. So like obviously Scotland compared to England is very much kind of disproportionate image. So obviously England's scale of population as well as the kind of resources that are accessible. So in thinking about the kind of integration of DoxyPrep in Scotland, some of the kind of barriers that England has only recently kind of gotten over, so kind of like 5016th Street being the kind of like big like premier thing in London that gives access to like hundreds of thousands of gay men across the year, is like not the case in Scotland. So first and foremost, kind of access to these kind of clinical spaces to learn about HIV PrEP first and foremost, because we have long waiting lists for them despite it still being free on the NHS. And then second of all, even becoming aware of DoxyPrep is something that is quite a difficult thing. I say it's a difficult thing because health promotion operates much more clearly through the charity sector in England, but it's not quite as clear in Scotland. So obviously we have Waverley Care, we have Terence Higgins Trust Scotland, we have other smaller types of groups, but the type of health promotion work that they do it comes from England, it comes from London. So the messages that we get in Scotland are not localized. They aren't, they're not tailored to the population. So when we were thinking specifically earlier about these kind of rural populations in Scotland, in the Highlands and in the islands, like people are never going to get access to DoxyPEP unless they have a very specific and tailored program to get access to DoxyPEP, because they're not going to be able to buy them online. They're not going to be able to do them safely in ways that, say, people who are in the centre belt in Scotland might be able to do more easily, or indeed in England. So that initial barrier of even getting knowledge about DoxyPEP is a really important thing for us. And I think for me, in thinking about the kind of imaginative and innovative processes of DoxyPEP in Scotland, means that we have this opportunity to tailor those messages now to be out and say, okay, here's what DoxyPEP is going to look like in Edinburgh, here's what Glasgow, what it's going to look like in Glasgow, here's what it's going to look like in Aberdeen, here's what it's going to look like in the Hebrides, and then be like, we have a targeted plan on how DoxyPEP is going to be managed, even if people can't get to clinics immediately. We can say, here's the kind of process that you can do to do DoxyPEP safely, and so we can start to keep track of it rather than it just going wild out into space and then we have no idea what's going on with it.
Absolutely, and I think that's really interesting as well. I think what happens a lot, and in an Irish context, is we see other jurisdictions racing ahead with these interventions, and then we try to map them onto our communities, and it's not the same. So yeah, thank you very much for that. I would like to give the opportunity to people in the audience to ask some questions if they have for our panel. Yes.
Yeah, so I was wondering about what the open to everyone would be on the panel about how we see sexual pleasure as an integrated part of sexual health or sexual health promotion. So I think often in the discussions that we have about even HIV PrEP, or even as we're talking about DoxyPEP now, a lot of the resistance to those interventions often look at that. Well, if we allow for this or we propagate this, then sure, people will be able to access pleasure, but then what does that mean for something else? And so it's like we have this hesitancy with encouraging pleasure. So yeah, just interested in everyone's thoughts on that.
Yeah, can I jump in there on that, just because this is the world that I'm living in at the moment, it's my obsession, is around how we can promote sexual health and also look at the happiness, the joy, the pleasure, the other health benefits that come from an active and healthy sex life. And that's one of the things we're trying to do in September at that conference is, like, we're starting off with our keynote address that's discussing shame by erasure and fetishization of different ethnic minority groups, but that's leading us into a panel discussion on pleasure, and it's the contributors and inhibitors to pleasure. And it's moving then through different, like we're covering kink workshops, ethno-monogamy workshops, but then on the breaks we have resources available, sexual health services available to talk to people. And I think it's about having both conversations side by side and allowing for the joy and the happiness and the pleasure to run concurrently with really positive and really practical sexual health messaging. And I think that's the kind of the...
And we have that there, like pleasure with sex is part of the World Health Organization's definition of sexual happiness. So I mean, it's there, but we don't use it, you know. Would anyone else like to comment on pleasure?
Yeah, I agree, and I think when I was thinking about sexual health futures and now, like pleasure and sex are really why we're all here, and it's quite often never the central point of conversations or meetings like this. And I was at the World Congress of HIV and STIs in Chicago recently, and there was a whole plenary on pleasure, and it was the first time that I'd actually ever been at a meeting where a significant portion of the program was centered on pleasure. So there you go for next year. But it is, it's so important, and our sexual health has to be more, it is more than the absence or the treatment of HIV and STIs. There's so much in relation to pleasure that is important for us to navigate our sexual health. So it's definitely, when I think about futures, it's definitely something I would like to see more, and it's definitely something that would be more of a hallmark of the work that we do at Empower too.
John Gilmore, not you coming on pleasure, not being around pleasure. I think it's important as well. Like when we talk about sexual health services, every health service and every healthcare intervention should encompass this. Going back to Roper Logan Tierney's model and expressing sexuality being core to nursing, but
I've research systems in the military, went to med school in Trinity, not UCT, so, and one of the things they said to me is they never had a lecture about like reproductive anatomy without talking about pleasure. And I was like, I can guarantee that doesn't happen in my workplace, but it should happen because, you know, these are the conversations, the really normal conversations we should be having. I've similar fears to growing around doxycat, it just becomes a thing you do. I love going to, like, my sexual health provider don't necessarily love me come in. I love coming in for a chat about sex, it's just like, what's happening with you, how are you getting on, what do you think? And that's a lovely thing about sexual health. And I remember one day, a clinic that I was at, the flow changed, and I saw about 20 different people, and I did a chat that more than 30 seconds. And one of the nurses asked me what I thought of the new flow, and I said, I hated it. Nobody had a chance to, if I was experiencing partner violence, or having issues around sexual functioning, or any of these other complex things that come up. You know, I'm better off just buying a kit online, but I think it's about creating these conversations at every point in healthcare. Primary care, you know, gerontology, wherever you're accessing, that someone's conscious and talking to you about if you want to, if you don't want to, you don't have to talk about it.
And there are so few spaces where we can have open, non-judgmental conversations about sex and sexual ethics are a place where we can.
So we should be on that side as well.
Outside as well, yeah. Any other questions?
Thanks very much. I think it was probably referred to, or you've touched on it a couple of times. One of the things that keeps on coming back to me is that certainly thinking about the kinds of models and initiatives and the histories of healthcare activism and healthcare organising that have emerged both from around HIV but LGBT communities. Thinking about the current situation that Ireland is in terms of its healthcare system, it's a really, really not a very good system. It's certainly not fit for purpose, and it's certainly ripe for change. And it looks like we're at a crossroads in terms of how healthcare is going to develop in Ireland. So it's just a very quick question. Do you see that there are lessons to be learned or models that we can revive from the LGBT and HIV experience that could really inform the development of more general healthcare systems in the country at this point?
If someone doesn't come forward, I'll pick someone.
Can I answer that?
Yes.
I mean, what's happening in the sexual health and crisis pregnancy program and with Empower, and you know, Adam sitting on the committees with Derval Igola, I just think that's really, really amazing, and that could be rolled out. But I'd also like to say that I think all healthcare is political, and I think that we will never change our healthcare system until we change our political system. So our political system with 5-seater constituencies means that you can't rationalise any service because that person from that party is going to lose their seat. So I really think, I feel our healthcare system is doomed. There's pockets of really good stuff. We've more money than we've ever had, and yet we're doing a terrible job. But I really do think it's due to our party political system. I have to say that.
I'm right with you.
I think community responsive, community engaged. Again, the HIV crisis was not met by doctors and nurses. Well, it was, but those who were engaged. It was not tackled by the medical establishment. Absolutely not. Actually, U equals U. A lot of harm was caused by the medical establishment by preventing that message getting out there. So we've relied continually on that partnership with community. This does not, you know, I work broadly in inclusion health. This does not just happen within queer people, but also other marginalised minorities communities. When you give voice, when you give support, when you put resources and infrastructure in, things, positive, innovative things happen. And I think that's something that we need to kind of think about. We have a lot of headlines with Sláinte Care, and we now have health boards again for some strange reason. You know, but I think a focus on community, if we can make that authentic, I think could really be helpful and useful.
And I do have days like this, and just the energy that I think we can kind of feel in the room around change and positive change and looking at sexual health and health futures, hopefully we will see some change. Are there any other pressing questions?
So I asked the question during my prep. So when I saw the criteria for that they've disclosed their like sexual history in order to prove to somebody who sit there with own beliefs and values around STIs and transmission and different things, that it's in a sense almost either re-traumatizing people or re-victimizing them, because they have to sit there and kind of justify why they need certain healthcare in order to be able to enjoy their children's kind of sex life. But that also like is feeling that might also be a barrier to why people might turn up looking for like PrEP, because of maybe they turn shame, they turn this, yeah. And does it look like it's going to change anytime soon? That might make sense.
Yeah, it's a good question, I think.
I think there's always a difficulty when you have criteria, and often I think when we look, for example, I kind of map it onto PrEP when we were responding to MPOX, and there was a decision around criteria as to who the vaccine would best benefit. It was really important, and something that we pressed at the National Crisis Management Team was to ensure that it was that people could self-identify, that these were a list of things that might allow you to recognise your risk, but that you would be able to turn up and have no questions asked if you yourself have recognised that you need or you would benefit from an mpox vaccine. I think we're probably and hopefully moving more towards PrEP criteria being more of, or PrEP being more accessible beyond the criteria. I would hope so, and I think that there is leeway in the way in which people clinicians can provide PrEP. I think it most definitely acts as a barrier, though. If you look at something, you say, I don't see myself in that, but I feel like I would benefit, or I know I would benefit, there has to be space for that. And I think that's why when the rollout of the vaccine, we made sure that that was something that was clear to people, that this is a guideline as to how those who are at, that would benefit the most, but it doesn't block anybody from accessing the intervention. So I think that's something that should, and I think is moving more towards in terms of PrEP revision in Ireland.
And I think that's not just enough for yes, from an Irish perspective, we don't do enough for PrEP for women, but we do see movement from the UK, and I think PrEPsters look like done a really fantastic PrEP for women campaign. Because like that, it's not necessarily that we'll have a huge population of women that will be PrEP, but that the women that do and will benefit from it know it's there and feel that they can access it. So I think that's work that's to be done.
And I think also it's important to recognise that PrEP isn't solely about preventing HIV either, and obviously it's a main focus of PrEP, but it's also a really important key tool for some people to reimagine themselves as sexual beings and enjoy and access pleasure, without the legacy of 40 years of HIV over their shoulders as well. And so when we have immovable structures like guidelines should guide and not prevent, I think that's the types of approaches that we need to
I think with that, that's the key point with it. And I can't promise you, but I know a lot of sexual health providers in Dublin and across the country, and most of them, if you come to them and you kind of have a chat with them, they would usually be like, yeah, no, that sounds sensible, or maybe you don't, but maybe this is fine. I think one of the bigger barriers is that you have to be registered to, not every sexual health, most sexual health doctors, but not every doctor who might see a patient in their GP practice, they have lots of what we might call risk criteria for PrEP, but that GP cannot prescribe because they're not part of this system, so it's a wider infrastructure issue. And I've talked about this before in terms of a barrier, because I work with clinicians who work in inclusion health, who work with homeless people, who have infectious diseases backgrounds, who cannot provide PrEP and get that for free for their patients, which is absolutely scandalous, and those patients won't necessarily go to GMHS or go to Ireland.
Sure, and I think in fairness to Section's Health Master Pregnancy Programme, they're just about to launch the e-learning module, and once they launch the e-learning module, and all of those people who were I think that we really want to improve access to PrEP, but to make that access on a safe basis where the training and resources are provided. And I think once they do that e-learning module is launched, and I'm hoping loads of people will do it, because it is a complex area of prescribing and it really needs to be done safely, that will improve the access.
So hopefully next year's forum, there'll be a different picture of PrEP across the country. Fingers crossed. I think we will leave the questions there. Thank you so much for the panel. I thought it was really interesting. And I just want to hand it over to Paul O'Connell from the Gay Health Network to close out today's game. Thank you.
Hi everybody, I'm Paul O'Connell. I'm a member of the board of the Gay Health Network. I'm a relatively new member of the board, and I've learned a lot in my time since I joined, especially from Kieran and the rest of the members of the board as well. And I don't come from a sexual health background, so I've learned a lot here today. It's been incredible to pick up on the energy in the room and from all the speakers and all the panelists. I think for me, one of the kind of key themes that's come through is the importance of inclusion and accessibility, that these are key foundational themes in the health and well-being of our community. And they run throughout the day, whether it's on normalising healthcare at university, right through to inclusive care for older members of the community. The threads are clear and they're intertwined. And it seems to me that all of these threads and, of the care and support that we discussed today are critical, and each represent amazing delivery and progress, but we're still a long way from a coherent and knitted whole when it comes to the care and well-being of our community. At the same time, we obviously welcome the plans for improving healthcare for the trans community that were discussed earlier this morning from the Minister, and the reporting and the tracking of the data that will be provided and coming in the next year or two that should find further improvements. We also obviously welcome the 33% increase in testing arising from home testing kits, and the additional resource requests and efforts that have been made to increase access to PrEP. And there's obviously been a clear outcome and improvement when it comes to MPOX. I think the discussion today around DoxyPrep was incredibly interesting. It obviously opens a lot of new possibilities, but obviously brings its own challenges. The importance and of all the awareness campaigns that were discussed today obviously also came through loud and clear, and I think really demonstrates the benefit of all the work that is done across the board by all the organisations, whether it's GHN or Empower or others, when it comes to raising awareness around sexual health in Ireland. And in particular to the GHN, we're particularly grateful for the support that we receive from HSPCC in this regard. Overall, the picture is clear from today that the services are oversubscribed and under-resourced, particularly for marginalised communities, whether geographically or societally. The inclusion and accessibility that was also resonant today around the discussions that we had when it came to chemsex and MPOX. From the chemsex perspective, Graham, it's great to see you on the platform today, and it really actually, for me, shows the benefit of this forum. A topic that wasn't discussed last year that had a lot of discussion today. And obviously we want to invite, if people are in the audience today and they can think of topics that haven't been covered that they really think passionately should be covered, do let us know. Obviously we're going to be talking about pleasure next year, and to put that on the agenda. The importance, however, of a comprehensive and holistic approach to tackling a lot of these problems, whether it's chemsex, or other topics, is incredibly important and really was driven home by the messages today, especially adapting it for the local context. It was interesting also to see the discussion around MPOX and the community self-perception and judgment that came away from that. We've obviously come a long way in the community, both in Ireland and more broadly, in our kind of self-perception, but it's amazing how easily that can take a knock back when something like MPOX comes along. So clearly have a long way to go there. But hopefully, I think we are making a clear path towards normalising and destigmatising sexual health care. It's a long road, but we're definitely making progress, and there's further progress to be made. All of this is to say that forums like this are incredibly important. They bring together a really great community of people to discuss these incredibly important topics and help further improve the provision of these topics for the community. So I just want to thank you all for your time today. We really appreciate it. A lot of time and effort goes into organising events like this, but I think they really do pay off when you sit here today and you listen to such a vibrant and stimulating conversation that we've had. And I hope that you've found it important too. So I just want to wrap up by saying thank you to the Minister for her remarks this morning. And I particularly want to thank our keynote speakers, Dr. Maurice Nannington and Dr. Chase Ledden. I want to thank all of our presenters and facilitating. As we can see, there's a lot on stage today, so I won't name everyone by name, but really do appreciate all the time and effort that you all put in to preparing these talks today and facilitating such stimulating conversation. I particularly want to thank the Gay Health Forum Organising Committee, Padraig Burke, Alicia Barron, David Field, and obviously Bill Foley, with whom we totally lost. I also want to thank the volunteers in GHM, Dublin Pride, and the Gay Men's Health Service. Finally, I just want to say that the Gay Health Network's annual report is published and is on our website if you want to read that. Probably the last night of the day, we are going to go for drinks at Suite 66. So if anyone would like to join us, please do join us at Suite 66. And with that, I'll close out the session. Thank you, everybody.